الفحص كله بنحتاج اوفر نايت عشان نعمل ايه الريكونستراكشن. طبعا الكلام ده كله احنا لما الصوره بتتاخر عندنا بالدقائق بيبقى ايه مشكله بقى في الجهاز. الراجل طبعا طلع منه عدد تذكاري من مجله الساينس، وطبعا لدوره الكبير ان هو خد عندنا جائزه نوبل برايس ان فيسيولوجي اور ميديسين، وكان معاه كورماك برضو كان ده عالم يعني حسابيات، يعني راجل برضو ما كانش برضو فيزيشن، وهو كان حاط له الجزء اللي هو الايه الثيوريتيكال بتاع السي سكان، والاثنين استلموا جائزه نوبل ان فيسيولوجي اور ميديسين. وطبعا احنا تكريما ليه بعد كده اخترنا اليونت بتاعت السي سكان وسميناها هاونسفيلد يونت، وعملنا الهاونسفيلد سكيل اللي بيساعدنا كتير في التشخيص. طبعا احنا الوتر عندنا زيرو، الحاجات الهاي دنسيتي تبقى اباف زيرو، طبعا الرينج بيوصل لغايه 1000 في البون، بينزل لتحت طبعا في الفات والاير لغايه ماينس 1000. وطبعا ده السكيل ده ساعدنا كتير في التشخيص بتاع ايه الحالات. تاني حالة يعني it is easy case. طبعا كلكم عرفتوا التشخيص بتاعها، هو عندنا سيتي سكان وفي عندنا سب اكيوت سب ديورال هيماتوما موجودة في الليفت سايد. تمام. هو بس الفكرة بتاعتنا احنا اللي انا بشوف الموضوع ده في كتير من التقارير، الناس مش عارفه ترتيب الادجكتيف، تكتب ايه الاول؟ هل نكتب significant subacute subdural hematoma ولا subacute subdural significant hematoma ولا significant subdural subacute hematoma ولا subdural subacute significant hematoma؟ كلها نفس المعاني بس في ترتيب في الادجكتيف في الانجليش. تمام. الاجابه الصح عندنا اللي هي هتبقى هنشوفها اللي هي نمره ايه. نمره ايه؟ ليه الإجابة الصح دي؟ لأن احنا في عندنا في الإنجليش في عندنا ترتيب اسمه إيه؟ أوردر أوف أدجكتيف في الإنجليش. أول حاجة في الأدجكتيف تيجي النمبر، يعني نكتب دي 1 أو 2 أو 3 كده. تاني حاجة الأوبينيون، الأوبينيون دي سيجنيفيكانت، دي مايلد، دي سيفير، مش يعني الأوبينيون بيكون تاني حاجة. بعد كده السايز والشيب والإيج والكلر، وفي الاوريجن بنكتب اللي هو اللوكيشن بتاعها او السايت اوف اوريجن او الرايت او ليفت او اي حاجه زي كده، وفي الاخر بنكتب ايه الليجن بتاعتنا او اللي ايه الماتيريال بتاعتنا. يبقى الصح هيبقى لما نيجي نكتب حاجه زي كده بنكتب a significant subdural subacute subdural hematoma. لو هم 2 بنكتب 2، يعني نبتدي الاول ب 2، لو هم 3 نكتب 3 فوكال ليجن، نبتدي بكلمه بالرقم. يبقى اول حاجه الرقم، ثاني حاجه الاوبينيون لازم نحطه، ثالث حاجه يعني الترتيب في ثالث حاجه مش مهم جدا بس ايه، واخر حاجه معروف ان هو ايه الماتيريال عندنا او الليجن اللي احنا بنقولها. فدي برضو يعني اتمنى من الجونيورز كلهم يراعوا الحاجه دي، ان اول حاجه يكتب الرقم وثاني حاجه يكتب ايه هيز اوبينيون. ثالث حاله برضو بنرجع كده للبلين اكس راي. البلين اكس راي طبعا مظلومه في الايام دي، وعندنا هنا بلين اكس راي في الليفت هاند، وطبعا دي 35 years old female with left sided wrist pain وعندها mild trauma. لو احنا بصينا عليها في عندنا اختيارات نورمال late onset rheumatoid arthritis دوكورفين ديزيز psoriatic arthropathy. تمام. لو احنا بصينا من البون هنلاقي البون دنسيتي كويسه، البون ما فيش عنده اي حاجه اوستيوليتيك سكليروتيك ليجن، ما فيش فراكسز اي حاجه، يعني غالبا this looks normal. فيها اي نوع من الارثرايتس؟ لو بصينا على الجوينت سبيس كلها كويسه. تمام. هيتبقى عندنا حاجه بس ديزيز في النص، جنه في النص كده اسمه ايه ديكورفان ديزيز. ديكورفان ديزيز طبعا ده ديزيز هو مش ماسكوسكيتال، هو ديزيز ماسكوسكيتال بس لا في البون ولا في الجوينت، ده في السوفت تيشوز. يبقى انا لما يكون عندي ديزيز بيجي في السوفت تيشوز لازم اشوف ايه السوفت تيشوز، فلازم هنا اشوف السوفت تيشوز عندي. وما ننساش واحنا بنعلق على البلين اكس راي ان احنا بعد ما نتكلم على البون وبعد ما نتكلم على الجوينت نبص على السوفت تيشوز. هنقارن السوفت تيشو اللي هو لاترال للارنا او ميديال للارنا ولاترال للايه للراديوس. هنلاقي في فرق بينهم، هنلاقي في عندنا significant thickness في السوفت تيشو اللي هو لاترال للراديوس. تمام. وطبعا الناس اللي عارفه ديكورفان ديزيز هو ده ديزيز بيجي طبعا ايه بيجي في التندونز اللي هم عندنا الاكستنسور بورسز بريفس لونجس والادكتور بورسز لونجس اللي هم موجودين هنا في الايه اسمهم ايه الراديال جروف موجود هنا. تمام. وده بنسميه ايه الهاوس وايف سامب او الاورسمان ريست ووشر وومن سبرين، لان ده ليه علاقه بالاكشن. الديزيز ده بيجي مع الاكشن، مع كونتينوس فريكشن كونتينوس موفمنت، بيحصل فيه عندنا رياكشن للتوندنز دي بتتشد وتعمل كده، فبيحصل لها سويلنج، ويحصل السينوفيال شيس اللي حواليها بيتخن، ويحصل عندنا ايه الديزيز دوت. وتشخيصه طبعا تشخيص سهل جدا كلينيكالي كده. لو احنا تنينا الصنب بتاعنا وتنينا الفيست بتاع باقي الصوابع وعملنا انر ديفيشن، اللي هيعمل كده ويحس بالم في الحته تحت الصنب هنا يبقى عنده ديكورفان ديزيز. بالمناسبه الديزيز ده بيجي ناس كتير راديولوجيست. ليه؟ لان احنا طول وقتنا دلوقتي شغالين بنكتب تقارير، تمام، وبنسند على الكيبورد والحاجات دي، فممكن يجي تيست كده كلنا نعمله اسمه فينكلستين تيست. لو عملناه ونعمل بعد كده انجوليشن ناحيه القرنه، لو حد حس بالبين هيجي هيحس بيه كده. طبعا انتوا لو بصيتوا للحاله بتاعتنا دي ليفت هاند، مش رايت هاند، دي ليفت هاند، لان العيانه بتاعتنا كانت ليفت سايدد كده. طبعا التشخيص بتاعه سهل جدا دلوقتي بالالترا ساوند، والناس طبعا اللي حضرت السيشن بتاعت الورك شوب بتاع الالترا ساوند هيعرفوا ازاي يشخصوه. ان في عندنا هيبقى في سيكننج للسينوفيا سيش اللي حوالين التندونز دول، والتندونز هيبانوا زي تو كده ايه يعني ايه بنسميه ايه اللي هو البولز اي كده، يعني تو بولز اي وسط ايه السكند سينوفيا. حاله ثانيه انا اديتكم في الاول كلو بتاعه، قلت لكم نوت افري ديورال تيل از مننجوما، ما حدش يقول لي مننجوما في الحاله دي. طبعا في عندنا هنا ام ار اي تي 1، وفي عندنا ويز كونتراست تي 1 ويز كونتراست. ولو بصينا هنا هنلاقي في عندنا فوكال ليجن في الرايت تمبورال ليجن مع عليها الارو، تمام. بعد الكونتراست هنلاقي ان الليجن دي ابتدى يحصل لها انهانسمنت، وفي جنبها عندنا ساين مهمه جدا كلكم عارفينها اللي هي ايه الديورال تيل ساين، تمام. وبعدين هنلاقي في عندنا ليجن موجوده هنا. طبعا الليجن دي ما كانتش ظاهره، اللي هي موجوده في الايه تقريبا اوكسيبيتال رايت اوكسيبيتال ريجون، لان هي كانت ايزو دنس في الايه في البري كونتراست، ابتدت تحصل في الايزو كونتراست. يبقى في عندنا مالتيبل انهانسنج ريجن موجوده مع الديورال دي. نرجع للهيستوري بتاع العيان ده. الهيستوري بتاع العيان ده عندنا يانج بوي عنده اكيوت مايلود ليكيميا. الاكيوت مايلود ليكيميا ده من الديزيزز اللي بيجي لها حاجه مشهوره جدا انتراكرينيال اكسترا اكزيال، اسمها ايه؟ كلكم عرفتوها ومعظم الاجابات عرفتها طبعا، اللي هي ايه الكلوروما او المايلود ساركوما، تمام. خلاص الكلوروما ده ديزيز بيحصل ايه ليه اسماء كتيره اتغيرت. كان اول اسمه جرانوسيتيك ساركوما، كان اسمه مايلو بلاستوما، اكسترا ميدالر مايلود تيومر، وكلوروما. كان اسمه كلوروما جاي من الكلورس اللي هو اللون الاخضر في الجريك، اللي معناه لان كانوا كروس سكشن لما يجي يقطعوا التيومر كان في كبر فيتاكسد ويبقى ايه لون اخضر، فسموه كلوروما. It is rare solid tumor have been observed in patient with acute myeloid leukemia with 50% survival rate. طبعا التيومر ده بيبقى زي المننجوما في كل حاجه، ايزودنس في تو ذا برين في السي تي سكان. في التي 1 بتبقى هايبو تو ايزو انتنس، بيحصل هيتروجينس انهانسمنت بعد الكونتراست، ويحصل معاه برضه مننجيال قلنا الديورال تير. فهو بيتشخص طبعا هيفرق معانا هنا الكلينيكال هيستوري، الايج هيفرق كتير والكلينيكال هيستوري. وهنا بنرجع تاني ان الديورال تيل ساين دي تيز نوت يعني ايه اكسكلوزيف او نوت ريليتد تو مننجوما اتسيلف. طيب بتحصل طبعا في اي تيومر بيوصل للديورا او بيحصل الابنديز، بيحصل فيه رياكشن او بيحصل هايبر فاسكولاريتي، فبيحصل فيه كده. لو بصينا على التيومرز اللي بيحصل فيها هنلاقيها ايه موجوده في ايه يعني بيج ليست اوف ايه اوف تيومر. طب امتى نقول ان دي الديورال تيل ساين؟ في عندنا كاركترستيك ابيرنس ليها. اول حاجه بتبقى لينير مننجيال سيكنينج، موجوده بريزنت ان 2 اور مور 5 ملم سيكشنز، مش موجوده في واحد بس، وموجوده في مور ذان 1 بلين، يعني موجوده اكزيال ساجيتال اكزيال كورونال بالطريقه دي، تمام. والجريت السيكنس بتاعها جنب التيومر، لان قلنا هي ايه رياكشن للتيومر، تمام. الباترن اوف انهانسمنت بتاعها بتبقى جريتر ذان ذات اوف ذا تيومر ماس، ولو احنا بنعمل دايناميك سكان بنلاقي ان هو بيحصل لها انهانسمنت ايرلي عن التيومر اتسيلف. بتحصل في وايد رينج اوف تيومرز، يعني انا حاجات بناين وحاجات مالجنانت، حاجات انفلاماتوري، حاجات فاسكولار. في عندي انا جمعت كده ديورال تيل ساين لقيتها بتحصل في about 25% of diseases. بتتراوح من الانفكشن والفاسكولار للمالجنسي. ودي اكزامبل لبعض التيومر الماسز اللي ممكن نشوفها ونفتكرها مننجيال، وفي الاخر بتطلع بالهيستوباثولوجي حاجه غريبه خالص غير الديزيز بتاعنا. هنا في عندنا مثلا هنا في ليفت اوكسيبيتال تيومر موجود واخد انهانسمنت وليه ديورال تير، والكاركترستيك بتاعه ان هو باين ان هو اكستر اكزل. بالهيستوباثولوجي بتاعه طلع في الاخر ايه ده؟ ساركويد. ده ساركويد ماس، فاسكولار ساركويد ماس. مريض تاني برضو لو بصينا عليه دوا اي حد هيقول ده من الجيوما اكسترا اكزيال ليجن ديورال بيز، ليها ديورال تيل، هوموجينوس انهانسمنت، تمام. بالهوستوباثولوجي بتاع الايه طلع حاجه ثانيه خالص، طلع ميدالوبلاستوما. ميدالوبلاستوما اللي ايه اللي جابها هنا؟ ده هيستوباثولوجي بروفن الحالات دي. كيس نمبر 5، الناس السونوجرافر والراديولوجيست اللي بيشتغلوا سونار هيعرفوا يجاوبوا الحاجات دي. Which of these techniques can cause ergonomic injuries during sonography؟ طبعا احنا بنشوف هنا في عندنا الراديولوجي شغال بتعمل سونار، في عندنا حاجات بتعملها. هل في عندنا ارم ابدكشن اكتر من 30%؟ موجود. في عندنا في تيلتنج اوف ذا سباين موجود. في عندنا مونيتور لور ذان ذا اي، طبعا ايه هنلاقيه ان هو موجود. يبقى كل الحاجات دي بتعمل لنا حاجه اسمها ايه؟ ergonomic injuries. تمام. يبقى الاجابه هنا بتبقى all of the above. ونتكلم عن علم جديد اسمه الارجونومكس. الارجونومكس ده علم جديد برضو ابتدينا ننتبه فيه في الراديولوجي، ان احنا ناس كتير بنقعد على الكراسي بالساعات، نقعد نعمل انتربريتيشن لكيسز، او بنشتغل حالات انترفنشن، او بنشتغل سونار. طب ايه هو الارجونومكس ده؟ ده study of the human body at work. البرايمري جول بتاعه ان انا انكريز البرودكتيفيتي وهوايل ديكريزنج الورك انجري. لو ان عندنا 80% اوف سونوجرافرز عندهم ايه؟ ergonomic انجريز. طبعا نسبه كبيره، لما 8 من كل 10 سونوجرافر عندهم ergonomic انجريز يبقى ايه ده؟ ايه بنسميه ورك ريليتد ماسكولوسكيتال ديس اوردرز. اسبابها كتيره. اول حاجه ستاتيك ورك بوستشر، يعني واحد قاعد او واقف ما بيتحركش، تمام. تاني حاجه عندنا السكاننج بوستشر اللي هو ايه؟ اللي فيه بيندنج، فيه تويستنج، ابنورمال سكاننج، ايه، وخصوصا بتوع السونار او بتوع الايكو تملي تلاقيهم ايه؟ مايلين ناحيه الايه؟ المريض. الريبيتد موفمنت، تمام، او الفورسبل موفمنت. برولونجد ابدكشن اوف ابر اكستريميتي اللي هو اكتر من 30%. في عندنا ان ابروبريت مونيتور هايت، طبعا واحد بيشوف والمونيتور واطي فلازم بيتني رقبته كده، او العكس واحد قاعد والمونيتور عالي ففارد رقبته، ففي عندنا ابنورمال بوزيشن للسباين. انكوريكت اور كونتينوس جريب اوف ذا ترانسديوسر، في ناس بتمسك الترانسديوسر كده لما نيجي نمسكه كده، عاوز اللي يمسك الترانسديوسر يمسكه كانه ماسك ريشه بيرسم الوان، ما يمسكوش جامد، ما يتنهوش جامد بالطريقه دي. طيب ايه الحاجات اللي تحصل ممكن في الورك ريليتد ماسكولوسكليتال ديس اوردرز ان سونوجرافي؟ ممكن تحصل حاجات يعني سبيكترم اوف ديزيز، بيرسايتس، كاربال تانل سندروم، كيوبيتال تانل سندروم، ديكيرفان ديزيز، ايبيكوندلايتس، روتيتور كاف انجري، بتوصل للديسك ديجنريشن، ممكن توصل للثوراسيك اوتلت سندروم، او بتوصل للتريجر فينجر. كل الحاجات دي ممكن تحصل للسونوجرافر اللي هم ما بياخدوش بالهم من ايه؟ من البوستشر بتاعهم او من الموفمنت بتاعتهم ديورنج ايه؟ الاكسرسايز، ديورنج السكاننج. طب ازاي نمنعها؟ نمنعها زي ما احنا شايفين كده. اول حاجه بنقعد على كرسي، الكرسي ده كومفورتابل، تمام. وفي عند الكرسي ده لو بصينا عليها في عندنا حاجه اسمها ايه؟ فوت سبورت، رجلينا ساند عليها. الكرسي ده ليه مسند من ورا، ظهرنا مسنود عليه وظهرنا مفرود، تمام. الارم بتاعنا يعني نوت ابدكتد، يعني الدرجه بتاعتنا 30%. البوزيشن، التيبل بوزيشن، تمام، بيبقى سيوتابل، يعني انا تملي بخلي التيبل بوزيشن بتاعي تقريبا يعني في نفس الليفل بتاع الايه؟ ماي البو، لا رافع البو ولا منزل الالبو بتاعنا. تاني حاجه المونيتور تملي نعمل خط كده من عند عينينا، لازم الخط ده يمشي مع الاباف ايدج بتاع المونيتور، بحيث ان انا لا يحصل لي ان انا ارفع راسي لفوق او انزل راسي لتحت، فممكن يحصل لي انجرز. في بعض الناس بتعمل برضه حركات في السونار، بيجيب الكيبل بتاع الترانسديوسر ويلفه حوالين رقبته، برضه ده فيري دينجرس، ممكن يحصل لا قدر الله انجرز، سيفير انجرز من الموضوع ده. في حاجه اسمها يعني كيبل سبورت، ممكن يحطه على ايده ويثبت بيه الكيبل بتاع السونار. تمام. وفي حاجه تانية برضو لازم نعملها، ان احنا واحنا شغالين نغير البوزيشن بتاعنا. يعني الواحد اللي واقف يقعد شويه، اللي مايل يمين يمين على الناحيه التانية. وفي عندنا برضو ايه شويه اكسرسايز ممكن نعملها اثناء الفحص او قبل الفحص او بعد ما نخلص الشيفت بتاعنا، زي ستريتشنج للهاند، ستريتشنج للسباين، النيز، النك، تيلتنج للنك، روتيشن اوف ذا شولدر. يعني الحاجات دي كلها ممكن نعملها عشان نقلل الانجريز ديورنج سونوجرافي. كيس نمبر 6 دوا طفل صغير old 3 years old girl mother brought her to ER because she had swallowed foreign body. patient was asymptomatic. بلين راديوجراف was done. وفي عندنا اختيارات. طبعا البلين في عندنا 2 foreign bodies موجودين في الايه في الابدومين. عاوزين report the case and ensure the mother, call the ER doctor immediately. This is a pediatric emergency. Inspect the stool وobserve the patient follow up by X-ray أو do abdominal CT for localization. هنا المانجمنت بتاع الناس اختلف. يعني أنا الناس اللي شفتها كل واحد ليه رأي في الموضوع ده. فعشان نرجع برضو إيه للإيفيدنس بيز ميديسين ونشوف هنعمل إزاي في حالات الإيه السوالوينج أوف فورين بودي. إيه الإمبورتنت لما في يحصل سوالوينج الفورين بودي؟ Where is the foreign body or what is the foreign body? إيه الإمبورتنت؟ What or where؟ What or where؟ اختلاف برضو. هو طبعا what هو الاساس فيه what is the foreign body. قبل where يبقى what is foreign body. تمام. يبقى what is very important. تمام. عندنا two possibilities. الفورين بودي دوا ممكن يكون كوين او يكون ديسك باتري. طبعا لو هو كوين هيبقى ايه دوا عندنا inert foreign body can pass. طبعا ممكن يحصل منه كومبليكيشن بس يوجوالي ات باس. لو باتري في عندنا هنا ريسك وفي عندنا ميبي بروبلم وممكن يحصل لها اوبن ديورنج الباسج في الجي اي تي ويحصل كده. طيب عندي هنا عشان افرق بين باتري وكوين انا صورت جبت الكوينز الايجيبشن كوينز عندي وصورتها بالايه اون فاس وصورتها ايه اون بروفيل يعني كده وشفت الشكل بتاعها. لو بصينا لو احنا صورنا الكوين كده هلاقيه هوموجينس كله هوموجينس سيم دنسيتي. حتى الجنيه اللي هو فيه تو ميتالز مع بعض لقيته برضه عامل هوموجينس دنسيتي في الاكس راي. ولو صورته هو انفاس يعني انا جبته في اللاترال فيو كده بتاعه وصورته هلاقي ان برضه في عندي ايه ان هو ما فيش لا بلج لا يمين ولا شمال باين كانه لينير فورين بودي. طب انا لو صورنا بقى الباتري هنعمل ايه؟ هنلاقي الباتري ليها كاركترستيك ابيرنس. غالبا هم برضو عاملين الحاجه دي عشان برضو الناس تعرفها. بيكون في حواليها بلاستيك انسيوليتور كده فبيعمل لي رينج حوالين الفورين بودي وتمام. وتاني حاجه لو صورتها في اللاترال فيو بلاقي فيه بلج. اي باتري بتبص عليها هتلاقي فيه بلج ناحيه النيجاتيف تشارج. هي بوزيتيف ونيجاتيف فناحيه النيجاتيف تشارج تملي بلاقي فيها بلج ناحيه ايه النيجاتيف تشارج. فدي معلومه مهمه جدا نعرفها. طيب هنا منظر دوا this is battery or coin. تمام. battery or coin طبعا دوا ايه نبص عليه في اللاترال فيو هنلاقي ان هو دوا ايه باتري. دوا باتري اور كوين طبعا هنا ايه واضح ان هو دوا ايه كوين. طيب لو باتري موجوده في الاسوفجاس ايه الريسك بتاعها؟ عندنا يا اما هتعمل لي هي بريشر دايركت بريشر نيكروزس في الحته اللي هي موجوده فيها وخصوصا في الارياز اللي فيها نورمال ناروينج في الاسوفجاس مثلا عند الاورتيك ناكل او عند الكريكوفرنجياس او عند الجاسترواسوفجيال جانكشن ممكن يحصل لها ايه دايركت بريشر وده بيحصل بريشر نيكروزس. الحاجه الخطيره اللي هو الكوستيك انجري بيحصل فيها ليكج للماتيريال بتاعتها لو هو صوديوم او بوتاسيوم هيدروكسيد وبيحصل لها طبعا اريتيشن والعيان ممكن يجي له ايه اسوفجايتس يجي له فايبروزس يجي له ستريكشر بالطريقه دي. او في عندنا حاجه ثانيه بتحصل لو الباتري دي شغاله وفيها تشارج بيحصل فيها بيرن عند النيجاتيف سايد بتاعها بيحصل بيرن ويحصل طبعا ريبيتد بيرن ده هيكون ليه كومبليكيشن. وهنا نفتكر 3 كلمات ناروينج 3 ان ناروينج تمام نيكروزس اند نيجاتيف. اي باتري موجوده في الاسوفجاس لوجد ان ذا اسوفجاس ماست بي ريموفد ما نستناش عليها. طب لو الباتري باست وراحت ايه الجي اي تي راحت الستومك او راحت الانتستين في عندنا احتمالات الخطر ايه هتقل شويه. اول حاجه الانتاج ديست باتريز هتعدي بسهوله مش هيجرى لها حاجه. المشكله كلها لو حصل في دامج للباتري. لو دامج للباتري حسب الكونتنت بتاعتها لو هي ميركوري اوكسايد باتري بيحصل ميركوري اوكسايد والعيانين يجي لهم ايه جاسترايتس وفوميتنج وهايبوفوليميك شوك. لو هي سيلفر اوكسايد تمام بيبقى مينيمالي توكسيك، بس السيلفر اوكسايد ده كوروزيف ممكن يحصل لهم برضه ناروينج وكده. الليثيوم برضه بتعدي بسهوله ما بيحصلهاش حاجه، بس هي خطورتها بره ان هي مع الفاير ممكن يحصل لها ايه اكسبلوجر. طب احنا بنعمل ايه لو شفنا باتري في الاستومك وفي الانتستين؟ اول حاجه سند لو البيشنت ستيبل تمام send him home, instruct the mother to watch for symptoms of toxicity تمام and passage of battery. يقول لها خلي بالك من الولد جرى له اي حاجه في فوميتنج في ابدومينال بين تعالي تمام للاي ار تمام، وبعدين انسبكت الستولز شوفي موجود ولا لا تمام. بنعمل ريبيتيشن للراديوجراف بعد 4 to 7 days ونشوف بعد كده اذا كان هي ايه موجوده ولا لا. لو الباسج ديليد اكتر من اسبوعين لازم العيان ده يتفتح ولازم الباتري دي تشال، يا اما حسب اللوكيشن بتاعها يا اما باندوسكوبي يا اما لاباروتومي يعني. لو نرجع للقصه بتاعتنا الحاله بتاعتنا باتري ولا كوين تمام. باتري عشان حاجتين، شكلها في الايه في اللي هي الاي بي فيو بتاعها، في عندنا في الرينج اللي حواليها، في اللاترال فيو في عندنا البالج اللي موجود في النيجاتيف سايد. يبقى هنا العيان دوا ذيس از نوت ايمرجنسي، هنقول للعيانه الباتري دي انتاكت، نسبكت الستولز، شوف العيان بعد ايه ايام هل خرجت ولا ما خرجتش، ونعمل له اكس راي بعد ايه 4 اسابيع. الحاله دي برضه الى حد كبير مش صعبه، هي يعني متوسطه. نرجع كده عندنا هنا 37 year old female عندها chronic headache, vision disturbance, diabetes, بوليوريا. عندنا سوبرا سيلر ماس موجوده هنا في تي 1، وفي عندنا فلير، وفي عندنا بوست كونتراست، وفي عندنا بوست كونتراست ويز فات سات. لو بصينا على الليجن دي هنلاقيها في تي 1 it is hyper intense، في الفلير ميكسد هايبر مع هايبو انتنس، مع البوست كونتراست هنلاقي حصل لها رينج انهانسمنت. لكن الحاجه المهمه جدا في البوست كونتراست اللي هو ايه مع الفات سات، هنلاقي ان الايه الابيرنس بتاعها حصل له ايه ساتوريشن، حصل لها بقت هايبو انتنس. يبقى انا ده بتكلم على حاجه كونتيننج فات. الحاجه اللي كونتيننج فات في التيومرز دي كلها اللي هو الدرمويد. طب انا لو شخصت درمويد هل هقف على كده؟ لازم اشخص حاجه ثانيه، اقول الدرمويد دوا هل هو كونتين درمويد ولا رابشر درمويد. وبرضو الكلو موجود في الحاله بتاعتنا. لو بصينا في الحاله بتاعتنا نص الشاشه راحت مش عارف ايه تمام كده. هبص على البيزل سيسترن، هنا في الفلير هلاقي في عندي اريا هايبر انتنس هنا، والاريا دي هايبر انتنس هنا. طب في البوست كونتراست مع الفاسات حصل لها ايه بقت هايبو انتنس. يبقى دوا ايه حاله رابشر درمويد تمام. الرابشر درمويد طبعا بيتشخص لو عندي سي تي بلاقي عندي الهايبو دنس ارياز موجوده في البيزل سيسترن او موجوده في الفنتركلز. طبعا هنا بتعمل لي ايه فات فلويد ليفل، عشان في عندي ايه الفات بيبقى لايت فبيطلع عندي زي ما انت شايفين في الفلير كده فات فلويد ليفل. الحاله اللي بعد كده دي حاله برضو عشان احنا برضو لازم نرجع للبيزكس. يعني الحاله دي للاسف الناس جاوبتها غلط، مع انها لو فكرنا فيها ممكن نلاقيها صح، بس هي غلط ليه؟ لان احنا اتعودنا على السي تي، اتعودنا على الام ار، نسينا البلين اكس راي. طبعا في عندي حاله طبعا 47 years old male بيعمل روتين شيك اب والعيان ده اسيمتوماتيك تمام. شفنا كده في عندنا الكاردياك شادو كبير، يعني في عندنا الكاردياك شادو كبير. طب هل ده هو كارديوميجالي ولا بيركارديال افيوجن، ولا ممكن يبقى في عندي ميديال لوب ولينجولا كولابس وجايين على الكاردياك بوردر، ولا ده يكون عنده سايمك تيومر ولا ليمفوما. نرجع لازم اشوف الايه البوردرز النورمال بتاعتي، فين البوردرز بتاعت الهارت. لو انا بصيت هنا يمين وشمال هلاقي عندي البوردر اوف ذا هارت بتبقى باينه عندي تمام. هي طبعا لو الفيلم لو هارد شويه هلاقي ان البوردر اوف ذا هارت موجوده عندي. يبقى بنرجع هنا لساين مهمه عندنا اللي هي اسمها ايه السيلويت ساين. السيلويت ساين عشان اعرف اللوكيشن بتاع الليجن دي لازم اعمل سيلويتنج للبوردرز بتاعتي. عندي البوردر اوف ذا هارت والميدياستاينم، عندي الكوبلا اوف ديافرام، وعندي اللاترال ثوراسيك وول. وبعدين ارجع تاني للليجن. يبقى انا دلوقتي الليجن بتاعتي دي مش لا هي كاردياك ولا هي بريكاردياك، طب هل دي ميدل لوب ولانجولا كولابس؟ مش باينين، التانيين بيبانوا كتريانجلر شيب، ممكن الاقي فيهم اير برونكوجرام كده. يبقى هيتبقى عندي سايمك تيومر وليمفوما. يبقى انا بتكلم على حاجه، وصلنا لو انا بصيت على الايه اللاترال اكس راي هنا هلاقي عندي في اوبليتريشن للريتروسترنال سبيس. هيتبقى عندي حاجتين، هل دي سايمك تيومر ولا ليمفوما؟ ابص للايه للدنسيتي بتاعتها، هلاقيها الدنسيتي بتاعتها هيتروجنس، حتت هايبر وحتت يعني هايبر اتنيويشن او هايبر دنس، وحتت ايه لو اتنيويشن. يبقى ايه الليمفوما تملي بتبان كلها هوموجينسلي دنس. لكن هنا دي ده سايمك تيومر ودي ايه سايمولايبوما، وطبعا ده كونفيرمد بايه بالسي تي سكان بتاعها. طبعا احنا واخدين على الصوره دي، لو الصوره دي عرضتها انا كله هيقول والله سايمولايبوما، دي سايمولايبوما بالطريقه دي. تمام، بس برضو نرجع للايه الاكس راي. كيس نمبر 9 برضو عاوزين دايجنوزس. هنا 23 الوقت خلص. خلاص تمام الوقت خلص، هنسرع بقى بس نعرف كده. عندنا 23 years old male عنده ساينوسايتس وعنده تيومر. في عندي تيومر موجود في الماسكولار سبيس بتاعتي هنا. التيومر ده هو هايبو انتنسيف في تي 2 وهايبو انتنسيف تي 2 في تي 1. اي ليجن هايبو انتنسيف تي 1 وتي 2 بفكر في حاجه اسمها ايه الفايبرس تيومر او الكولاجين كونتيننج تيومر، وده حاله ايه ماسكولار فايبروماتوزس. الحاله دي سهله، حاله كلكم جبتوها، اللي فيها عندي ايه ليفت اكسترنال الياك فين، وده طبعا بيكون في سندروم اللي هو اللي اسمه المي تيرنر سندروم. بيحصل كومبريشن بتاع على الليفت انترنال الياك فين بالرايت انترنال بالرايت كومن الياك ارتري، الليفت كومن فين. ده المي تيرنر سندروم. مش هطول فيها كتير برضو عشان دي كل الناس عرفتها. طبعا الصوره دي فاني بنجيبها كده عشان ده مشهوره الصوره دي في فيلم طبعا اللي بالك، وطبعا شايفين ان احنا بايه بتعمل انتربريشن للفيلم ابسايد داون. تمام. هنا الصوره دي برضو كان فيها تركه صغيره، يعني العيان عنده هو ايه بروستات كانسر وبيعمل ايه تشيك اب بري اوبراتيف اسسمنت. طبعا بروستات كانسر فالناس كلها هتفكر في التيومر، لكن احنا في عندنا هنا 3 ويل ديفايند دنس ليجن موجودين في الليفت سايد ليفت لانج. لو بصينا عليهم كده هنكبر عليهم كده هنلاقي الاوباستي دي ويل ديفايند راوندد مرسومين شبه بعض قد بعض بالحجم، بعضهم في حواليها كريسنت اوف جاز حواليها كده. تمام. لما نلاقي الصوره بتاعت الباثولوجي بتاعتي انا جيومتريكال، يعني ما تمشيش باثولوجي افكر في الارتيفاكت وافكر في الفورين بوديز وافكر في ايه الحاجات اللي هو استوديو كده. الليجن دي طبعا طلع ان دوا في الاخر دوا شريط ستيبلس موجود عند العيان، ودي حاجات بنسميها البلمونري سودو نديوز. الحاله الاخيره برضو حاله معظم الناس جايبتها، طبعا عيان دوا عنده ايه جونادال فين ثرومبوزس. باين عندي لو بصيت على الاي في سي هلاقي في عندي فيلنج ديفكت موجود هنا. تمام. ولو بصيت عليه في اللونجيتودينال هلاقي ان في عندي ايه. فالحاله دي طبعا ايه اوفيريان فين ثرومبوفلوبايتس، وحاله ايه ايزي وكل الناس جابتها. كده يبقى احنا خلصنا الحالات بتاعتنا. وطبعا هنا بس بقول لكم حاجه واحده، بصوا على الصوره دي مكتوب عليها تيش، والميرور ايمج بتاعها ليرن. تيتش اند ليرن. تيتش تمام، يعني if you want to learn you have to teach, and if you teach it you have to learn. So it is mirror image، لازم طول عمرنا هنفضل فيها. وشكرا لكم. الله يخليك. الاجابات طبعا احنا جمعنا الاجابات كلها طبعا ايه في بعضها اباف افريج وفي حاجات افريج وفي حاجات بلو افريج. احنا اكسكلود البلو افريج والافريج وخدنا الاباف افريج. لقينا عندنا ان في عندنا الاباف افريج 7. السبعه كلهم جايبين 8 اجابات صح من 13. تمام. طبعا مختلفه ايه كده، بس احنا خدنا التوتال بتاعهم يبقى كله جايب 8 من 13. ال8 دول مع الدكتور طارق هنختار منهم الفيرست بالقرعه، هنختار الفيرست وينر. ما فيش اطفال هنا ها. دكتور اشرف. دكتور اشرف. بسم الله الرحمن الرحيم. And now the first winner is first female winner نهال حازم حلمي. طبعا يا جماعه انا يفضل اللي يفوز يكون موجود عشان يستلم جايزته. انا اعتقد نهال حازم حلمي، طبعا دي من المنصوره يونيفرسيتي من النفرولوجي سنتر، والله بالصدفه يعني كده واللي اختار فنهال دي الفيرست وينر، وطبعا الجائزه بتاعتها بتتقدم من شركه نبراس، بيجيبوا كده اي نوت كده، هو هنسلمها للدكتور طارق بقى، هيستلمها منك في الاخر. نختار السكند وينر، هو الشركه عاوز بس يسلم وياخد صوره بقى. عاوزين ميل بقى عشان يبقى فيه الدنيا فير. بسم الله الرحمن الرحيم. كتبت نهال.
انا كتبت نهال.
تمام. برضه في ميل، شكل برضه الفيميل شطاره عندنا. آية عاطف محمود وردة، طبعا من عندنا لا من يورولوجي برضه، من النفرولوجي سنتر برضه.
ما فيش اي بايظ والله، ما فيش، احنا الدكتور محايد اللي اختار.
من المنصوره.
ايه هنا ولا ايه؟
الدكتور من المنصوره برضه اختار.
انا من المنصوره.
طيب يبقى عندنا البيست اونر.
طيب خلاص، احنا لو ما عندوش مانع يستنى معانا الكلوزنج سيرموني ونجيبهم يحضروا يبقى احسن. طب خلاص، يبقى هو ان شاء الله هنسلمهم الجوائز في الكلوزنج سيرموني. وانا بس لحظه واحده اقول لحضراتكم بقيه الفايزين.
طب نقول باقي الاسماء الفايزين
اللي هم هيجوا في الكلوزنج يحضروا ياخدوا الجوائز بتاعتهم. احنا دول الاثنين خلاص بتوع البيست انسر. في عندنا كان في جايزتين للبيست بابلشد بيبرز في الايجيبشن جورنال خلال السنتين اللي فاتوا 2020 و2021. اللي فازت بالجائزه الاولى دكتوره رباب ياسين من وفيه يونيفرسيتي، واللي فازت بالجائزه الثانيه الدكتوره رشا مصطفى كايرو يونيفرسيتي. ده البيست بابلشد بيبر. وفي عندنا البيست اورال برزنتيشن للساينتفك ريسيرش اللي فازت بيها الدكتوره دنيا صبح منصوره يونيفرسيتي. شكرا، ونشوفكم بقى في الجلسه اللي جايه ان شاء الله.
الزوم جه اللي كان هيطلع زوم جه. كيم كالي.
بسم الله الرحمن الرحيم. يسعدنا ويشرفنا الحضور الممتاز ده، يعني واحدة من السيشن الأخيرة. My name is Yasser Abdulazim. I am professor of radiology at Ain Shams University and head of neuroradiology section. And I'm honored to head and moderate this session. And I also prepared this program, and I hope you will like it. Our first speaker is a dear guest of us, Professor Kali from Turkey, Eng University Hospital of Izmir, and he's going to talk to us about interesting cases in neuroradiology and importance of relaxivity. And actually, I heard Professor Kali before in Dubai, if he remembers, maybe 2 or 3 months ago, and he has a fantastic talk. So please, all of you, concentrate in it, and let's start because we are already a bit late. Professor Kali.
Thank you, dear professor, dear moderator, for this nice introduction, and hello everyone. I hope you're all fine and you enjoyed the Congress. And also I want to thank the Egyptian Radiological Society for giving me this honor to be here, and also the Bayer company for this talk. So in the next 30 minutes, I will actually try to be fast. I'm going to mention a little bit about the contrast material, especially the gadolinium contrast material. I'm going to share some cases with you that we can miss in our daily life. And also at the end, I will talk a little bit about the dynamic susceptibility contrast perfusion, which I like the best. It is like my right hand during my daily work. So these are my disclosures. And as I already mentioned a little bit, I'm going to mention about the gadolinium-based contrast, the differences between them, and also the importance. I'm going to discuss the importance of gadolinium-based contrast agents in our routine daily life. So when you look at the gadolinium, actually, it's a rare earth metal, and it's cytotoxic, actually. That's the reason it should be chelated with other forms, and that is coming from the differences from the gadolinium-based contrast agents is mainly coming from there. And as you all know, it shortens the T1 and T2 relaxation times. The dose, why I'm sure that you all know the dose, but also in my country, in Turkey, actually, some people prefer to give less doses. Well, I must tell you that this is not true. You can miss a lot of cases if you don't inject the amount needed for those patients. So I'm going to talk a little bit something different, but the current ones that we have is that most of them is 0.5 molar gadolinium chelates, and if you have a 70 kilogram patients, you should at least inject 14 milliliters of gadolinium to those patients. But don't forget, there were a lot of publications talking about the double dose and even the triple dose. I'm going to mention a little bit about it. We are not doing it in our routine life, but I will talk a little bit about it, what happened. So in 2017, European Medicines Agency actually suspended the use of the linear contrast agents. And my country, Turkey, also followed this just 15 days later on. The use of the linear contrast agents has been suspended. What we have now, we have the gadobutrol and also the gadoteric acid, gadotexic acid, which is actually is not used for the CNS, and also gadoteridol, as you can see here. So are there any differences? Yes, there are a lot of differences. Some of them is ionic, some of them is non-ionic, some of them linear, and some of them microcyclic. The osmolality differs, the viscosity differs, but I'm not going to mention, of course, I am not going to mention all of them, but I'm going to mention about the relaxivity of a gadolinium-based contrast agents. So when I was searching, so what is relaxivity? I asked Professor Google, and then I was just hoping that it can give me an answer. Well, it didn't give me an answer. It just gave me this photograph here. So it's relaxivity is really coming, the word relax, actually. But for a gadolinium-based contrast agent, the relaxivity is a measure of its ability to increase the relaxation rates of proton in a solution it is added. So what does it mean to us, radiologists? So I'm not a chemist. Actually, what happens, there are values, T1 relaxation values and T2 relaxation values, and these are the relaxivities. It's called R1 and R2, and what happens then, there are also some factors, but what they do, what is the importance of relaxivity, is that if the relaxivity is high, you get much brighter signals when you inject the contrast. If the relaxivity for T2 is high, then it should actually, of course, when you do T2, normal turbospineco, fast spineco T2 in the brain, and you inject contrast, you don't see anything. But there are some sequences which, like I'm going to mention, perfusion-weighted imaging, dynamic susceptibility contrast, and then they use their T2 star sequences, and what we want is a prominent signal drop. So it is important if the relaxivity actually is high. So looking at the ones that have been used in Europe now, the relaxivity of Gadovist actually is much higher when compared to the other ones. Well, I wrote 2 times gadoteric acid here. The reason is that one of them is from one company, and the other one is from one of them is Dotaram, and the other one is Clariscan. That's the reason why I wrote them 2 times. So how this relaxivity affect our images? So there was an animal study from Munich, Ludwig von Maximilian's University. I know them very well, and then they started actually many years ago, 2009, with this animal study, and they said that actually what they did, they said that when you use the Gadovist, you have much better brightness on post-contrast images when compared to 0.5 molar gadolinium-based contrast agents. And then came the human studies saying that actually if you use at the same dose, so this is the single dose that we use for every patient, and it's 0. millimole per kilogram body weight. And then there were some studies showing that if you inject gadobitrol, because of its high relaxivity, you get much better enhancement when compared to the 0.51. And also those studies continued, and this is actually from the same study, that you have much better brightness when you use the Gadovist at the same dose. And also for cerebral metastasis, there came out some studies and then saying that, showing this actually, this is with Gadovist and this is with 0.5 molar GBCA, and then you see the enhancement is much better, and even in those cases you don't see it on the left frontal lobe, but here you can see it. And this is also the comparison that because of the higher relaxivity of the Gadovist, you see a better enhancement, and even here you don't realize it with this 0.5 GBCA, but with the Gadovist you realize that there is another one. You may tell me if the patient, and also here another study showing that you don't see this small one with the 0.5 molar, but there is another one. You can tell me that, hey, there are metastases. What is the important that I see another additional one? Well, it is important now. It was not before, but it is important because the whole brain radiotherapy is almost, nobody wants to do it anymore because it causes cognitive decline in years. So what they do now, actually, they do stereotactic radiosurgery for each of these small lesions. So if you miss one, then it means that you will not treat it, and then it will come up afterwards. So now it is really important. And also there are some double-dose studies with gadobitrol showing this is an MS patient, showing that there are actually, you can find additional active inflamed plaques in some cases, and this is a case from my side. So the neurologist sent me the case and said that the patient had, well, we did the examination, we didn't see any enhancing MS plaque, but then she called me back and said that there must be something because the patient has an acute neurological deterioration. So what I did, I said, okay, send the patient back, I will give the double dose. And when I gave the double dose, I saw 2 lesions here that are enhancing. So this was really, in some cases, you may use the double dose. If there is any question in the end, I can also answer it with pleasure. For the Gadovist, actually, there is something which makes it different from the other contrast agents. It's actually its concentration. It's a 1 molar contrast agent when compared to the other ones in the market. So this also has an advantage for it. So what I call it, because you inject the less volume, the half volume actually. So when I look at this and when I think of this, I always think that this Ant-Man film, I don't know if you watched it, but it came to my mind. Because normally, Ant-Man is a normal human and with a special suit. When he pushes the button, he makes smaller. And then, but he is much more powerful than a normal human. So actually, you inject less volume, the half volume, because, and also you have a higher relaxivity, you have much powerful contrast agent. And so what is the dose now? So why you can ask me why 85 kilograms? Because I'm 85 kilograms. If you want to inject me a 0.5 GBCA, you should inject me 17 milliliters. But if you inject me an agadovist, you will inject me the half of it. And the injection rate, I don't know how many of you use MR-compatible injectors, but the injection rate is like this. And then because you have less volume, you have a faster injection of this volume, and you have a higher concentration, especially in dynamic studies like contrast-enhanced MR angiography, perfusion, dynamic susceptibility contrast perfusion, and so on. So you have a more concentration at one time point, which will, and then it is shown out that when you sample the signals at the case space, you have much concentration, and this also gives you a more contrast to noise ratio. And there were studies for the contrast-enhanced angiography comparing Gadovist with the other ones, and then you see the signal-to-noise ratio and also the contrast-to-noise ratio is high. And even visually, you see much more brighter images when compared to the others, because that I already told you. Although I'm a neuroradiologist, I don't understand anything from the body. Well, actually, although I saw this one, and they were saying for the multiparametric prostate MRI, and then they were saying that the accuracy, sensitivity, specificity is much more higher when you compare the 1 molar contrast agent to 0.5 molar GBCA. And also, there were some studies for the perfusion imaging, and then when you do the perfusion imaging, I'm going to show you cases, and then you get much better signal drop, which causes that you see if there is an increase in perfusion in a tumor like this. When you compare this one and this one, in the tumors, we are looking for these red areas, actually. So this is something which is useful. And this is 2009. Some researchers from Japan, they found out that if you don't have an automatic injector, if you have a thin vessel, and if you are unable to inject fast, and they realized that with the Gadovist, the minimum signal drop was larger when compared to the other one. So this is also another one. So let's come to the interesting part. Why do we need gadolinium-based contrast agents for CNS imaging, actually? Okay, so we have a patient with hydrocephalus, okay? So what is the reason for this? If you don't, when you inject contrast, you see this leptomeningeal enhancement here, and also around the brainstem. So now you understand why the patient had an hydrocephalus. Otherwise, you would not. Probably these are metastases from, let's say, breast cancer or lung cancer. But this is important. Without this, you would not see it. So just look at these 3 images. You see 3 images here, and there is a lesion over there. Can you see? Anyone can see the lesion? You know, we are not looking as radiologists, we are not looking only 3 images in our life. We see hundreds of images, and we have to do it very quick. And can you miss it? Yes, you can miss this. Did anyone see anything? No, okay, here it is. So with the contrast, it's obvious that you have actually here a meningioma, and if you don't realize it at this moment, it may grow and compress the optic nerves in the future. So you have to diagnose it, and with the contrast, it's much more easier. And there's another patient with facial nerve paralysis, and when this is the flare, you see hyperintensity, and this is T2, we have an hyperintensity here, hypointensity or isointensity, but on diffusion-weighted imaging, there is a diffusion restriction. So why this is happened actually? So we don't see anything on the normal non-contrast T1 weighted images. So I could say that is this an acute infarction or something else? Well, I would report it as an acute infarction, and looking at the homunculus, perhaps it's in the location of the face, so that's the reason for the facial nerve paralyzes probably. Well, if you actually inject contrast, then you see that this lesion shows ring enhancement. So it is not actually an infarction. So what is it? So a ring enhancing lesion, and then you I have to wait because you have to see what's going on down there. So this ring enhancement actually is not typical for an acute infarction. If you didn't inject contrast, then you will think that it was an acute infarction. But also in the basal area, there are leptomeningeal enhancement, not only around the brainstem, but also inside the internal auditory canals. So actually this turned out to be a breast carcinoma metastasis. So you would miss it without the contrast. In our daily life, I'm sure you are seeing a lot of elderly patients that is showing T2 hyperintensity, as you can see, nothing on T1, and I would report them that the chronic ischemic changes in the brain. Well, actually, the patient had a lung carcinoma, and when you inject contrast, you see a lot of metastases over there. So without contrast, so you know that some metastases, they come first with the brain metastasis, and then you do a whole body PET CT, and you find the primary tumor. Well, actually, this is something. And this patient was only 15 days ago came to me. And then I am lucky. I don't know if you see anything on T2. This is 3D flare, and this is a 3D non-contrast images. Nothing is there. I would just report it probably as normal. Well, it turned out to be the patient has a melanoma, and then you inject contrast, and you see these multiple enhancing metastases. So without contrast, we would miss it. And one more thing that I must tell you, that you should actually, when you deal with the pituitary gland, and if you are looking for a microadenoma, look at this T2 image and also look at this post-contrast image. Do you see any microadenoma? Well, difficult. But if you do dynamic imaging, it is there. You see it. So we should always do the pituitary imaging looking for a microadenoma in a way of dynamic contrast enhanced imaging. Otherwise, you will miss the diagnosis. And of course, every patient coming referred to us for acute or neurological hearing loss, neurosensorial hearing loss, should also be examined with this, because you may miss these small acoustic schwannomas in cases. This is a very interesting case. Look at this, T2, flare, and T1. Please let me, I'm asking you the question. Who says there is no lesion? There is a lesion on the right side. Who says? There is a lesion on the left side. I believe there is a lesion, but I don't see it. Okay, just wait. Okay. I'm just telling you the diagnosis. There is a schwannoma here. There is a schwannoma. And I'm asking, is it on the right side? Left side? Left side. I have voices here, left side. Any other? Okay. Here it is a schwannoma. You miss it. So if you don't inject contrast, this is what you are going to miss. So the patient was operated and turned out to be a schwannoma. Well, and also, rather than the contrast, I just want to give you two technical tips, which is, I believe, is very important in my daily routine, is that one of this. I know this patient has a breast carcinoma. What we do, we also have 2D post-contrast sequences and 3D post-contrast sequences. 3D MPRH, we always do it. I'm asking you, this patient has a breast carcinoma. Who says there is no metastasis? This is only one slide. In your routine daily life, you look at 25, 30 slices only for post-contrast. Just be careful. So who says there is no metastasis? You will change the life of this lady if you say there is no metastasis. Who says there is one on the right side? One on the left side? On both sides? No? It's staying there. You don't see it. Okay, this is the three. I don't have much time. So actually, if you do 3D post-contrast, sorry for that, then you will realize that there is one here and there is one here. Then if you go back, you can see them, but really it's difficult to make the differentiation. So for the very small ones, you should always use the 3D ones. So this lady was a good friend of mine, and then she gave birth. She helped my wife to give birth of my children, and then unfortunately she never smoked before, but she had a lung cancer, and she had cerebral metastasis. And what happened then, she had a whole brain radiotherapy, and then this is because of the radiotherapy, and we were following her. And then what happened, one day she came with a headache, and this is axial post-contrast T1. She had leptomeningeal metastasis, as you can see, and this is the post-contrast. This is the post-contrast flare. I'm going to give you a technical tip too. So, going to the up, this is the post-contrast 3D T1 weighted images. I'm asking you, is there any leptomeningeal metastasis, or what you see around here, all of them are normal vascular enhancement? Who says there's a metastasis? Who says these are normal vascular enhancement? Hey, you don't need to think so much. Do post-contrast flare. It's very easy. When you do post-contrast flare, the normal vessels, they do not enhance on post-contrast flare. Only the leptomeningeal pathologies, only they enhance. So what we do now, if we are going to inject contrast to any people, any patient, we always do the flare post-contrast. We don't get the pre-contrast. There is no need for that. But this is very important. And what happened then, she was treated. Still, we have here a leptomeningeal enhancement on 3D T1 and post-contrast flare also. But in this area, you don't realize it here, but there are also more leptomeningeal residual enhancements. So the patient has a diplopia, and who says there is a lesion here? There is no lesion. Lesion on the right side, lesion on the left side. There is something in the pons, or you say, I believe there is a lesion, but I don't see it. Any lesion? Okay, here it is. This is the SWI and this is the post-contrast. There is a huge developmental venous anomaly where you don't realize without the contrast actually. Okay, any other question is this one. So we have something soft tissue here on the left side, here it is, and I'm asking you, is this a disc herniation or schwannoma? Schwannoma. Okay. I don't have much time, I'm going. So this is the pattern if you inject the cotton, the gadolinium. You see there's peripheral enhancement which is compatible with sequestrated disc herniation. It's not a schwannoma actually, because we would expect schwannoma to show homogeneous enhancement. And also 4-year-old male with acute weakness in the lower limbs, and this is T2, T1. Any pathology? No. When you inject contrast and you see this type of enhancement, and this is typical for Guillain-Barré syndrome. So without contrast, you would miss it. So coming to the perfusion, I'm going to be very fast. You know there are some types. I'm not going to go into detail, but with the dynamic susceptibility contrast, this is the most common one we use, and it's very routine in our daily routine. And you all know that we have CBF, CBV, and mean transit times. And there are clinical applications, and I can say that in my department, at least between 8 and 12 perfusion imaging are done because we like it very much. It doesn't take time. It's only 1.5 minutes. So that helps us very much. And we were not using it for acute stroke, actually. But then we started using it. We have to start. We must start using it because the American Stroke Association in 2008 showed in the guidelines that with the mechanical thrombectomy, what was before, it was said that if the patient has an acute stroke in the first 6 hours, you treat either with TPA, intravenous TPA, or you treat it with mechanical thrombectomy. From 6 hours to 24 hours, they said that now you can do it, yes, but only with one condition, you have to do perfusion. The reason is that to find out if there is a penumbra or the lesion, what you see is an ischemic stroke. So this is a patient. You see there's an occlusion of the right internal carotid artery and middle cerebral artery. You see the diffusion restriction over here. The question is that it's the 12th hour, so we have time. The question is there a penumbra or not? So this is the mean transit time maps of perfusion MRI, co-registrated, fused together with the diffusion. And then you can see here actually it's all the same. So there is no diffusion deficit bigger than the infracted area on diffusion weighted imaging. So there is no benefit to do any mechanical thrombectomy to this patient. But coming to this one, we see also in the middle cerebral artery, there is an occlusion. Yes, on the diffusion, we have this acute ischemia over there. And when you do the co-registration images, the lesion on diffusion weighted is small, but on the middle cerebral artery territory, you see there is a big deficit. So it means that there is penumbra, and they treated the patient. Here you can see this is before and this is after. The mechanical thrombectomy has done, and these are the thrombi. And after 10 days later, the modified ranking score is 0, no deficit at the child. This is important. Where we use perfusion also very commonly, if there is any lesion enhancing, and if we do not know if it's an infectious disease, a demyelinating disease, or a neoplastic disease, then we do it. And if we see for the enhancing lesions, we always look at the CBV, cerebral blood volume map, and if we see increased perfusion, we say that this is almost more than 95%. This is actually a malignant lesion. And here's a lesion. There's a ring-enhancing lesion with the edema around it, okay? There is no central diffusion restriction. It's not a pyogenic abscess, because we would expect this. So it looks like a metastasis to me. So they ask if this is a metastasis or if it is something else. It's very easy. Then you do the perfusion and look at the CBV map. There is no increase in CBV on this image. So I said that this is not a malignant tumor, and it turned out to be a tuberculoma. And also differentiation of primary central nervous system lymphoma from a glioblastoma is very, very important, because if it's a glioblastoma, the neurosurgeon should try to take out as much as possible. But if it's a lymphoma, before the surgery, as a radiologist, you say that this is a lymphoma, only a small biopsy or a small resection is enough, because it responds very well to the chemotherapy and radiotherapy. So there are two things that it helps you, is that one of them is the diffusion restriction and homogeneous enhancement, as you can see, no necrosis inside. And also you see the diffusion restriction on ADC map. And when you look at the CBV map, there is a little bit increase, but not as much as glioblastoma. So these findings are very typical for a lymphoma, actually. And one more very important thing is to follow up of these patients. So patients operated for glioblastoma. So every 3 months we follow up those cases, and in our protocol, perfusion is always there, because without perfusion, it's impossible. So I'm asking you the question, is this is after radiotherapy, chemotherapy, and there is an enhancing lesion now. Are you going to report it as a recurrent tumor? I would never do that without perfusion. I would never do that, because with the perfusion, this is the DSC perfusion, and this is the T1 perfusion, which I didn't mention much, but there is no increase of CBV and also the K-trans in this lesion. So this is just a radiation necrosis. Just follow it. There is no need for the second operation, actually. And this is a very new case, also came to me. The patient was operated again for glioblastoma, surgery, radiotherapy, chemotherapy. And what we see now, we see two lesions. One is up there, and the other one is up there. And they ask me if both of them are glioblastomas or both of them are radiation necrosis. It's easy. Look at this perfusion image. again co-registered with the post-contrast image. There is no increase here in the enhancing area, but we see increased perfusion in this one. So you may not believe me, this is the same patient, but this is the same patient. Actually, one of them is the radionecrosis. You don't need to touch it, but you have to reoperate the patient to take this one out. And for the infections, what happens? Okay, now I'm finished. Okay, thank you very much. No, 2 minutes, 1 minute? Oh, okay, okay. So this is very easy for you. I'm very sure about that. So we have a lesion here, ring enhancing lesion, yes? And we have diffusion restriction in the center. This is typical for abscess. Okay, I just want to give you how abscess on perfusion weighted imaging. So actually we did this, the CBV, and we see there is no perfusion increase, yes? And even if you measure, you can see this enhancing area when compared to the normal contralateral white matter has less perfusion. So the walls of the abscess show very low perfusion. This is just, and this is my favorite case, and I'm finishing with this case. You see both cases. Okay, irregular enhancing lesion, there is central diffusion restriction, yes? And also another case with irregular enhancing lesion, and when you look in the central part, there is also diffusion restriction. So just the same. Am I right? Okay, so my question, both of them are glioblastomas, both of them are abscesses. A is abscess, B is glioblastoma, A is glioblastoma, B is abscess. Both of them abscess. Well, what would you like to do? Perfusion. With the perfusion, you see clearly that there is an increased perfusion of this enhancing lesion. But with this one, there is no. This is a premature abscess in the early phase because there are phases of infection. First is encephalitis, then the premature abscess, and then comes the abscess that I showed you before. But both patients were operated. Well, actually, for this patient, they should not probably operate, and they should have done the antibiotic therapy first and to see, but they operated it. What I'm going to tell you that is, I'm finishing, relaxivity of a contrast material. There are a lot of studies now. You can look at the literature. Every company and everybody is trying to increase the relaxivity of the contrast material. And I am sure at least from 2 companies that we know, in 2 years' time, we will see new contrast material which has at least 2 or 3 times more relaxivity than the ones we are using now. But currently, at this point, we only have this Gadovist, which has the higher relaxivity, and this, I believe, is important for us as the radiologists to make the diagnosis. So, you know, we cannot live without the gadolinium. So I showed you many cases we would miss a lot of pathologies if we didn't use it. And we must not forget that on post-contrast images as a radiologist, what we like to see, a brighter signal for a better lesion detection. So thank you very much. I'm so sorry if I'm a little bit late. Thank you.
Okay. Thank you very much, Professor Kali, and I cannot let you leave the podium without a couple of questions, if I may.
Yes, please.
For the multiple sclerosis cases, with the macrocyclic contrast agents, we always find it difficult to detect enhancement in spinal cord lesions. So unlike brain lesions. So do you advocate giving more dose, or what's your strategy with these new contrast agents for activity of cord plaques?
For the spinal cord, normally it is really difficult for many years to see if there is an active lesion in the spinal cord. If you ask me, if you want to show me a case, you know, we are 3 people who are dealing in neuroradiology in my university. if I see a difficult case, I skip this case and leave it to the others. Because, you know, it is most likely that you may make a misdiagnosis. And also for the enhancement, it's very difficult to detect. But now there is a new technology which has arrived, which is called the deep learning reconstruction. It is coming from the companies. It's a software, artificial intelligence software, and it constructs the case space data with the artificial intelligence and brings it as a visual. So I have some experience with it, and I believe that such innovations also from the software side will help us to make this. But you are totally right, it's really sometimes difficult.
Yeah, maybe the new contrast agents can help a bit, or
Yes.
having delayed enhancement, delayed time of imaging or something.
I totally agree, sir.
Yeah, as a follow-up question on the use of contrast agents also in MS, the neurologists, and in recent literature, it's about T1 FET-SED delayed or FLAIR delayed imaging to see the leptomeningeal enhancements, because this has cross-correlation with cognitive decline. So have you done this? You have experience with it?
Sir, it's a very nice question. When you look at the literature, they say that you may see also leptomeningeal enhancement in MS patients. I've never seen one. I see a lot of cases, but I've never seen myself. But what I can offer to my colleagues, what we try to do, if we are dealing with MS, because late enhanced images are very important, we put the patient inside. We get pre-contrast T1, for the brain I'm talking, and then we inject the contrasts. And then we take the T2. We take the diffusion-weighted imaging. We take the FLAIR. We take the SWI. And then, because you know, you don't need to wait, because you waited. And then you take the post-contrast images. So I strongly advise it, because it doesn't affect the other sequences. So we are doing this, and so I also propose this. Because late enhancement, sir, you are right, it's very, very, very important for detection of active inflammatory plaques.
Right. Okay, last thing, just before I want to second your opinion about MR stroke protocol in acute stroke. We see a lot of stroke cases in my hospital, and I'm sure you do the same. And I'm always telling our interventional neuroradiology colleagues, please get information from the MR stroke protocol. So I liked very much what you said, instead of like doing a case that doesn't need it, like the first case that you showed, that there is no penumbra. So why there is no benefit? There is benefit only for their money.
Money, yeah, that's true, sir.
Yeah,
That's true.
but not
That's
for
true.
this. So I second your opinion. I like MR stroke protocol a lot in the acute stroke, and I thank you very much for
I
your
thank you,
wonderful
sir.
talk.
Thank you for the
you.
invitation also. Thank you.
Now let's move to the next speaker, my dear friend and great professor and educator and researcher, Professor Dr. Ihab Reda from Alexandria University, who always has something new and innovative to add to us. And I'm sure you'll all be glad to listen to his talk about advanced MR diffusion techniques, diffusion keratosis and IVIM, which are in the domain of, like, you don't need to inject contrast media and you get a lot of information. So this is something innovative, and Dr. Ihab, I'm sure will do a good job. Thank you very much.
ما جاتش. طيب فين هنا؟ بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. I thank Mr. Chairman for all what he said. I think it's too much for me. Our topic today will be the advanced MR diffusion sequences, and beginning by the kurtosis. Remember that in free diffusion, like if you are dealing with a cyst, there are free movement of the protons on the extracellular space, and this will result in high ADC and will see the cyst as hyper-intense. Now, in restricted diffusion, let us say a case of lymphoma, plenty of cells, there is hindered movement, and there will be a low ADC. Just
remember how we are dealing with this ADC. We have the B curve, the B value. Increasing this B value will result in drop of the signal. And this is the curve. This is the curve that you will see only in this presentation, the ADC curve. As we increase the B value, there is drop of the signal. Now, if we are returning back to the free movement of the protons, we are assuming that they are in a homogeneous medium. In a homogeneous medium, the diffusion depends only on viscosity and temperature. Viscosity and temperature. So in this condition, the protons will move according to what we call Gaussian distribution, and the movement will be presented by a bell curve. This is the bell curve. In a cyst or free diffusion, there is a wide bell curve. In lymphoma or restricted diffusion, there is a narrow bell curve. This width represents the ADC. So in a cyst, there is wide bell curve or high ADC. In lymphoma, there is a narrow curve and low ADC. Actually, in vivo, they are not homogeneous medium. They are heterogeneous medium. I mean, there are cells, plenty of cells, microcapillaries, etc. So the movement will follow what we call a non-Gaussian distribution. And the movement will be presented not by a bell curve, but by a peak curve. So there is a bell curve and a peak curve. The difference between the bell curve and the peak curve can be mathematically calculated by what we call kurtosis. So what's kurtosis? Kurtosis is just the difference or deviation of distribution from the Gaussian to the non-Gaussian curve. Now, if you have a free diffusion, assuming a non-Gaussian distribution, there is free movement of the proton. We said there is high ADC. But the peak curve is so close to the bell curve. The difference is very small, so we have a low kurtosis. Now, in free diffusion in a cyst, we have high ADC, but low kurtosis. On the contrary, in a case of lymphoma with restricted diffusion, there is low ADC, but the peak curve is higher and different from the bell curve. The difference between both curves is great, so there will be a high kurtosis. And this is the curve that you have seen of the ADC curve. The green line is the conventional ADC, and the black one is the diffusion kurtosis. Look, there is a difference only when we reach more than 1,000. This small difference, does it really matter? Does it really change the things? Look here. This is a test that was done. These are cubes filled by sucrose of different concentration, and the F1 is filled by a paste of asparagus. On conventional diffusion, no such difference to discriminate between them. Now, using kurtosis nicely differentiate the asparagus from the sucrose. So that difference really matters and can help. The sequence of diffusion kurtosis is just like the difference of DTI, just to add 2B values more than 1,000 and to evaluate more than 15 direction. It takes about 7 minutes. What are the factors or the parameters of kurtosis? We have the diffusion kurtosis or decay, which corresponds to ADC, and we have the mean kurtosis, which MK, which is a unitless measure. It's a number, a unitless measure, which reflects tissue heterogeneity. It will increase in complex tissue and decrease in neuronal loss. In some machines, there are additional factors like radial kurtosis and axial kurtosis. Radial kurtosis, interested in myelin integrity, it will decrease in myelin breakdown. Axial kurtosis reflects axonal integrity, it will increase in stroke. Now, what are the clinical applications of diffusion kurtosis? There are many, and beginning with stroke. In large lesions in stroke, the final lesion size, as we can see it on T2 after 1 month, is really matching with the initial mean kurtosis. This is a case of acute infarction on diffusion on ADC. We can see that the lesion size on the acute stage is double that what we can see on T2 after 1 month, while the mean kurtosis is matching with that size after 1 month. Also, in small lesions, the final lesion number that we can see on T2 after 1 month is really matching the original mean kurtosis. They did a long study with many patients. On the ADC map, the acute lacunar infarction number was nearly double that what we can see after 1 month. And the mean kurtosis, the initial one, was nearly similar to it. Another point that we better understand the changes that are actually going on during stroke. There is what we call the marked increase of axial kurtosis due to axonal beading. Let us see. These are the normal axons. During stroke, there are multiple swollen area along the axons called axonal beading, and these result in increased axial kurtosis. Another entity is the traumatic brain injury. Sometimes with mild traumatic brain injury, the conventional MRI is totally normal, but actually there may be some areas of increased mean kurtosis due to what we call glial skull formation. Let us see this example. These are coup and contre-coup hemorrhagic contusions on FLAIR, on T2, on SW. Look to that area between the ventricle and the hemorrhagic contusion. It appears as a normal appearing white matter. Look on the mean kurtosis map. It is surrounded by a hyper-intense ring of high mean kurtosis that reflects astrogliosis not seen by any other sequence. In neoplasm, also we can differentiate between high and low-grade glioma using mean kurtosis. The mean kurtosis is high in high grade, low and in low grade. We can see here, this is the mean kurtosis maps, grade 2, grade 3, and glioblastoma grade 4. In the map, the mean kurtosis is low, hypo on grade 2, hyper or high in glioblastoma, and intermediate in grade 3. We are working on that, trying to reach cutoff values. Also, it can differentiate between recurrence and post-irradiation necrosis. It's higher in recurrence than post-irradiation. Actually, this is one of our cases. There is enhancing nodule along the paracentral lobule. With the spectroscopy, the choline Na is 2.6. So it is malignant, and this is a recurrence. After a full course of irradiation, still the enhancing nodule is there. But the choline Na dropped to 0.75, and it is hypoperfused, considered as irradiation necrosis. Look now to the magic mean kurtosis. Here on the recurrence it was 1,000 or more, and on post-irradiation it drops to 244. So again, we are working on that, trying to reach a cutoff values. In neurodegenerative disease, we are in bad need for an early biomarker to begin therapy very early before neuronal loss. Cases of Alzheimer and mild cognitive impairment, there is very early decreased mean kurtosis in all these areas versus control, while there are no changes at all in conventional MRI. Same thing in Parkinsonism, where 80% of the dopaminergic neurons are lost before clinical appearance. But very early, there is decreased mean kurtosis in substantia nigra, red nuclei, and globus pallidi. In demyelinating diseases, there are decreased mean kurtosis and radial kurtosis in normal appearing white matter, as well as in the normal appearing gray matter and basal ganglia. Here we can see the mean kurtosis. Its value differs from the healthy normal appearing white matter, MS patient with normal appearing white matter, enhancing lesion, flare lesion, and even black holes. While on ADC, the values are nearly similar for all of them. Beginning the second part, which is IVIM, it's not intravenous, intramuscular. Actually, it is intravoxelar incoherent motion. In any voxel, there are protons moving in the extracellular space, but also there are macrocapillaries and there are flowing blood. This flowing blood contains flowing moving proton, so that diffusion measuring this movement, there will be these protons moving, which we'll call cellular diffusion, or the true one, or what we consider, and the proton moving inside the vessels are called perfusion or pseudo-diffusion. If you are using low B values, so we can see or we can measure the perfusion only. If you are using higher B value, we can see or can measure both cellular and perfusion. In case of free diffusion in the cyst, there are small blood vessels only, so the perfusion will be low. In the case of lymphoma, there will be multiple cells, multiple blood vessels, and we will have high perfusion. So in free diffusion in a cyst, there is high diffusion, high ADC, but decreased amount of blood vessels, so there be low perfusion. And this high and low are the origin of this word incoherent motion. Same thing in restricted diffusion. Multiple cells, we have low ADC, low cellularity, while plenty of vessels, plenty of blood flowing, so we have high perfusion. Now, the sequence for IVIM, it reads only 3 B values less than 200. This is the ADC curve. If we are using B values less than 200, it will be IVIM. If more than 1,000, it will be investigating the kurtosis. Between both of them, it is the ADC. The parameter that we can use, we have the ADC that all of us, we know it. It is related to both cellular and perfusion, while diffusion coefficient is related to the ADC for the cellular part only and called slow ADC. The pseudo-diffusion coefficient, or DS, or fast ADC, is the ADC for the perfusion part. It reflects rate of microcapillary blood flow. And lastly, we have the perfusion fraction. It is a percent representing the volume of blood inside the voxel. Now, what we can get as clinical application, very rapidly in stroke, there are decreased F and D star perfusion in ischemic core, but the important point that we can reach penumbra. If we compare the ADC with the perfusion map, we can get the penumbra, which is the difference between both of them. In cerebrovascular disease, in small vessel disease, there are autoregulation of the brain resulting in vasodilatation and increased cerebral blood flow in normal appearing white matter to prevent cognition loss. So this area of normal brain, there are normal perfusion map, while in arteriosclerotic encephalopathy, we can see this suffering area, damaged area shows normal perfusion, while in the normal appearing white matter, there are patches of increased perfusion due to vasodilatation. In tumors, again, we can differentiate high and low grade by increased F and D star along the enhancing part and the nodule, and even in the vasogenic edema, there is increased perfusion. We can see we are working on that, trying to reach cutoff values. Also, to differentiate recurrence from radiation necrosis by increased F in recurrence. Look here, increased F values, it's green to orange, while in low F values in radiation necrosis, it's green to blue. Again, we are working on that, trying to reach cutoff values. And lastly, they found that in glioblastoma, perfusion is higher than primary CNS lymphoma, and also monitoring the treatment follow-up, successive follow-up of the decreased perfusion and D star will point to better therapeutic response. And I'm very glad I succeeded in time. I thank you very much.
Thank you, Professor Ihab, for such a wonderful talk and eloquent explanation of the physics and all of it. And I advise you all, if you want to understand it, this is a very good summary to go with it. So I have a question for you. Have you tried to use IVIM, for instance, for gamma knife treatment, like small meningiomas without?
No, actually, I begin using this since about 1 year, and just in tumors only. Or honestly, not tumors only, all space-occupying lesions. I passed by infarction, I passed by abscesses, but I didn't met meningioma until now.
Right.
I didn't try it in meningioma.
Right, because we tried it in meningiomas and schwannomas, especially the small ones, following gamma knife therapy, because the gamma knife
Yes.
people told us that all the time you tell us it's stationary in size, and the patient is not happy.
Yes, and when you report this, they are very angry.
Yes.
But actually, I think I may suggest that there may be decreased perfusion that they are aiming to do. I think that it will be better monitoring for this for that gamma knife to suggest decreased perfusion values
Right.
after gamma knife.
And maybe also you will find that true diffusion is rising, so
The ADC values may be
ADC
rising,
values
yes,
may be
but
rising, so-
not in every patient anyway.
Right, right. And for the keratosis part, have you tried it in other places outside the brain, or?
No, actually, there are papers regarding kurtosis in prostate and kurtosis in the liver. But actually, I have the software for the which can be used on brain coil only. So I didn't use them. But there are definite uses in prostate.
Right. Okay, so I thank you very much for the wonderful talk, and we can thank you very much.
I thank
for
you very
being
much.
here. And we can move to our next speaker, Professor Dr. Shaima Abdel-Sattar in Shams University. I will be very biased when I present Shaima. Shaima is my former student, my favorite student, every favorite. She is our best researcher in Shams University. I cannot give her what she deserves, so I'm sure you will like her talk. It's about phase contrast and the 3D high-resolution T2 sequences in the management of pediatric hydrocephalus. Actually, I have one word to say about Shaima. I was asked this question once. Who is the best candidate that you examined in the MD all over your 20 years? And always the answer, Shaima Abdel-Sattar. Okay, Shaima.
Thank you very much, Dr. Yasser, for these nice words. And you are always my professor, and I have learned and still learning a lot from you. Thank you very much. Today I will talk about phase contrast and 3D high-resolution T2 sequences in the management of pediatric hydrocephalus. By the end of this talk, you will be able to know the anatomy of ventricular system, MRI protocol for evaluation of CSF disorders, and the value of different sequences in the assessment of common clinical presentations. We are all know the anatomy of a ventricular system. These both lateral ventricles and third ventricle through the foramen of Monroe CSF pass, and then aqueduct of Sylvius down to the fourth ventricle, and this exit foramen of Luschka and McGinty. And we can see here the choroid plexus within the lateral ventricle, third ventricle, and the fourth ventricle. After formation of CSF, it passes along the subarachnoid space to be absorbed through arachnoid granulation, and this is the basic and traditional form of CSF pathway. MRI protocol starts with the conventional T2 axial T2 sequences, and FLAIR. FLAIR is the superior in demonstration of the white matter signal intensity, as in this case we can see transepidermal CSF permeation in case of acute hydrocephalus. Coronal T2 is important for demonstration of the hippocampal position and the size of the temporal hole in relation to the body, as we can see in cases of hydrocephalus. Also in sagittal T2 sequence, we acquire, I will compare between the conventional 2D sequence and the 3D heavily T2 sequence. We can see here in the 3D sequence that it has a better resolution, as we can see here as a Lake West membrane, which is a congenital arachnoid membrane. It is an important point to be mentioned for neurosurgeons prior to performing endoscopic third ventriculostomy. The anatomy of the midline here is very important also. We can see here clearly the aqueduct of Sylvius and the anatomy of the third ventricle. This is a supracellular and chiasmatic recess, anterior recesses of the third ventricle, and that supracenarium and the lamina terminalis, it should have the appearance like this, a concave upward and Also, the lamina terminalis here appearing as a nose of a head of any animal, dog here, and the posterior binary recess here, the superior and inferior binary recesses. It has appearance as to be remembered. Advantages of 3D sequence is a bright fluid signal intensity enabling visualization of any adhesions or arachnoid bands within CSF. It has a high spatial resolution, useful for evaluation of cisternal portion of cranial nerves and cisternography, as we will see. 3D sequences have different nomenclatures according to the physical principle of its acquisition or according to the vendors. We in Ain Shams University use a balanced Philips machine, a balanced fast field echo, and drive or Vista sequence. In our daily practice, we use the drive or balanced fast field echo. I will show the difference between the sequences here. This is a 2D conventional fast spin echo sequence. We can see here in a patient we underwent endoscopic third ventriculostomy. This is signal void denoting functioning third ventriculostomy. The signal void is highly appreciated here in conventional 2D sequence. In a drive sequence, we can still see the signal void, but it's not more obvious as not obvious as in 2D sequence. And BFFE is very nice in demonstration of the anatomy without the appearance of the signal void. So if we want to see the anatomy without any signal voids, I advise you to use the balanced fast field echo, or it's any sequence of the modified Fourier focused steady state sequence, either CES or FIESTA. Regarding a phase contrast sequence, a phase contrast, after acquisition of phase contrast sequence, the image appears with 3 types of phases. This is a rephased image as an anatomical image with no any resolution. The magnitude image, the moving structures appear as bright signal here. This is the CSF within the pre-pontine cistern. And in 2010, the International Hydrocephalus Workshop endorses the consensus definition by the International Society of Pediatric Neurosurgery. Hydrocephalus means a condition characterized by dynamic imbalance between formation and absorption of CSF, resulting in increase in size of fluid cavities within the brain. Also, it's ventricular enlargement with gyral effacement against the inner table of the skull. This suggests strongly hydrocephalus. However, if this is not present and the sulci and cistern are also large, this suggests ventriculomegaly X value. We will see here. So ventriculomegaly can be ventricular enlargement with elevated intracranial tension. This is hydrocephalus. It can be congenital infection or hemorrhage or whatever the cause, or tumors. It can occur without elevated intracranial pressure. So when I see ventricular dilatation in a CT or MRI, I put the term ventriculomegaly, not right hydrocephalus. It's first ventriculomegaly. Then think, is it really hydrocephalus or ventriculomegaly to other causes, which can be ex vacuo as a result of atrophy, or mild ventriculomegaly associated with benign dilatation of the extra axial CSF space of infancy. So this is a case of ventricular dilatation. It's a ventriculomegaly. Is associated with effacement of the gyri against the extra axial CSF space, so it's mostly probably hydrocephalus. Second case, this one associated with ventriculomegaly, associated with dilatation of the extra-axial CSF space, but with thinning of the gyri. Most probably, this is ventriculomegaly ex vacuo as a result of atrophy. The third one, this is a ventriculomegaly, no evidence of microcephaly clinically, female dilatation of the extra-axial CSF space, so it's a case of a benign external hydrocephalus. So how can I confirm these 3 types with confidence? How to differentiate? There are diagnostic clues for differentiation. It's enlargement of the anterior or posterior recess of the third ventricle with downward convexity of the floor of third ventricle. And these are the 2 most important clues. There are other clues, proportion dilatation of the temporal and whole and body of the third ventricle. All measurements, and the measurements are proved to be not accurate in differentiation between hydrocephalus and ventriculomegaly ex vacuo. So the most important clues are the first two: enlargement of the anterior or posterior recesses of third ventricle with downward convexity of the floor of third ventricle. As we can see here, the recesses, you remember the normal recesses of third ventricle, these dilated recesses with convex appearance of the lamina terminalis here. This is a normal for comparison. Also, in coronal sections, we can see here a proportional dilatation of the temporal horn and body of lateral ventricle with medial deviation of the hippocampus. Compared to in case of atrophy, the hippocampus is relaxed laterally with no pressure upon it by the temporal horn to be deviated medially. So this is a case of hydrocephalus, and this is a case of ventriculomegaly ex vacuo. The measurements are proved to be not accurate in differentiation or events index. It may be of value in follow-up, like not for diagnosis. So this case, is it hydrocephalus or atrophy? Think about the recesses here. What about this and what about this? In first case, the recesses here has a normal appearance with concave appearance of the lamina terminalis and tuber cinereum. So is most probably the case of atrophy in accordance with the clinical scenario with microcephaly delayed milestones. This case, there is dilatation of the anterior recesses of the third ventricle, and this more dilatation. So these are two cases are hydrocephalus. So we diagnosed hydrocephalus. The second step to determine the type of hydrocephalus, either it's communicating or non-communicating. Communicating hydrocephalus, there is free flow of CSF through the lateral ventricles through the aqueduct into subarachnoid space with no evidence of bands or adhesions or obstructions. Signal void here appear in conventional 2D sequences. However, in CES sequence, we can see here no flow artifacts. So it's important to clearly see the patency or to confirm the patency of the aqueduct in balanced fast field echo or CES sequence. However, we should take of this pitfall. This case, a conventional 2D sequence showing the signal void passing through the aqueduct and passing through the foramen of Magendie of the fourth ventricle. Are these structures patent? Is this aqueduct patent or the foramen of Magendie, is it patent? We should look to the CIS sequence or balanced fast field echo sequence. We can see here there is adhesive band here, causing partial obstruction to the foramen of Magendie, causing this artifact. So the anatomical image is very helpful for better assessment and for accurate demonstration of the CSF spaces. Also, a site obstruction, this case, in the coronal image we can see here there is dilatation of the temporal horns and body of lateral ventricle. However, in thin sections here, we see there is the foramen of Monroe is obstructed by adhesive or band. So the site obstruction here in the foramen of Monroe. Also here is in thin sections showing adhesive band within the aqueduct of Sylvius here. And phase contrast image showing the flow within the anterior and the posterior spinal subarachnoid space with no evidence of flow within the aqueduct of Sylvius. Other types of aqueductal obstruction here in the aqueduct, the typical congenital funnel-shaped appearance of the distal aqueductal obstruction, also marked adhesions in the aqueduct of Sylvius and in the fourth ventricle. Also, as we see the fourth ventricular exit, when we performed our research on the value of these sequences, we found that infra-aqueductal obstruction causes increased flow velocity and turbulence within the aqueduct, as we can see here, similar to the case of communicating hydrocephalus. We can see here the adhesive bands within the prepontine CSF spaces and obstructing the fourth ventricular exit. Like the sequences showing the foramen of Luschka is closed by adhesive bands. Also here we can see no flow within the posterior spinal subarachnoid space and pericerebellar CSF spaces. No flow evident. However, there is only flow in the anterior spinal subarachnoid space. This anteriorly flow, there is no flow posteriorly. As we mentioned, if there is acceleration of flow within the aqueduct, when there is infra-aqueductal obstruction, as in this case, the velocity here approaching 12 centimeter per second. Prior to third ventriculostomy, meticulous inspection of the prepontine CSF spaces and third ventricular floor is very crucial. As I told you, there is a conventional 2D sequence showing clear CSF space. However, in 3D sus, we can see here this aqueduct, the Lilliquist membrane, which is crucial for neurosurgical knowledge. Also, we can perform a coronary format. The aqueduct here is closed. There is multiple adhesions in the third ventricular floor, and with coronary format, we see here multiple adhesive bands within the prepontine CSF spaces. Following third ventriculostomy, the flow here is denoting patency of the third ventriculostomy, and having a flow here in phase contrast image. This case, is this ventriculostomy patent or not functioning or not? This is a conventional 2D sequence here. However, in anatomical image BFFE without the artifact, we can see here multiple adhesions in spite of the apparent patency of the third ventriculostomy. These patients, after 3 months follow-up, there is no flow even in conventional images and proved to be a non-functioning shunt. So back again, the high-resolution images is very crucial, CIS images. Adhesions again, case of adhesions, functioning ventriculostomy, non-functioning. VB shunt assessment can be based on anatomical image ventricular dilatation or not. However, ventricular dilatation can even persist with resolution of hydrocephalus. So we can perform phase contrast image showing the flow within the VB shunt here. We recently introduced a technique, also the high-resolution T2 images. We can see here the lumen of the VB shunt clearly demonstrated with demonstration of the side holes. Again, another case. Malfunctioning shunt can be demonstrated by a hyper-intense signal surrounding the shunt within the brain parenchyma or within the reservoir here, as in this case. This interesting case, we can see here a patient complaining of headache and blurring of vision. And despite the conventional imaging reveals apparent accepted size of the lateral ventricle with no even any abnormality of the white matter, when we performed the high-resolution images, we can see here hypo-intense signal filling the aqueduct, the shunt tube here. And this, we can see here this shunt tube is very near to the choroid plexus. Choroid plexus can have access to the with ingrowth within the tube. So this shunt is actually removed, and the patient is improved after surgery. Also, sense sections can demonstrate adhesions filling within the shunt tube here. These are multiple adhesions within a case of Dandy-Walker malformation, and within the ventricular system adhesion here. The adhesions has pathway into the shunt tube, causing its obstruction. So my take-home message, sagittal 3D sequence is crucial for the assessment of the anatomy of CSF pathway. 2D phase contrast in mid-sagittal sections is important for functional assessment, detection of flow with velocity measurements. MRI is important to determine if the hydrograph is communicating or not, and to detect the site of obstruction. Also, MRI is valuable in preoperative and post-operative assessment of third ventriculostomy, as well as detection of shunt malfunction. And these are, for further reading, these are our publications regarding this topic. And thank you very much.
Thank you, Professor Dr. Shamaa, for such a wonderful talk and all these nice pediatric cases. I have a question. You mentioned about the importance of the membrane for the third ventriculostomy. So how do you comment upon it for the neurosurgeon?
I will say it's present. There is arachnoid membrane. The Lilliquist membrane is present. That's during surgery after with endoscopic third ventriculostomy. If it's functioning, they will see a gush of CSF coming during surgery. In the presence of lytic waste membrane, they will not see this gush of CSF. But when I mention it before the surgery, they can expect its presence and can manage according to this situation.
So they need to pierce it during the
Yes.
growth of cell. Okay, and I have just one comment for the differentiation between the arachnoid choroid plexus from debris. Because I use this, as you know, in the adults, and we give contrast media, and we found that also by the 3D thin cuts, that with the choroid plexus it enhances, while with debris it does not. So I don't know, maybe you would like, if you have a question about whether you're dealing with debris or arachnoid.
I don't want to extend the study for children under anesthesia and maybe under emergent situations in a case of acute hydrocephalus. So whatever the case, in the literature they published that the finding is can't matter is it choroid plexus or debris, they will remove. But the difference is in they can expect it's choroid plexus, so they can expect bleeding during surgery. From my cases, I performed choroid plexus appears as choroid plexus itself is moving towards the shunt, or the shunt is within the choroid plexus. However, in adhesions, as we can see, of the case of anti-ocular malformation, we can see the multiple adhesions surrounding the shunt tube.
Right. Okay. Thank you very much for such a wonderful talk. And moving on.
Yes, I tried the phase contrast sequences, yes, but I have done actually few cases of this study. And I till now I didn't find a difference between the flow within the obstructed or non-obstructed shunts. Maybe because the flow is very weak.
Aqueductal stenosis with membrane. The quantitative method is that we take the axial image below the membrane. Yes, if we find hyperdynamic circulation below the membrane.
From my experience, I didn't find this being of value. If the aqueduct is obstructed, it's obstructed. So they will search for a management, either a shunt tube or endoscopic third ventriculostomy. What I found is what was helpful is the presence of hyperdynamic flow within the aqueduct. It may lead me to the diagnosis of either intra-aqueductal obstruction or it's a communicating hydrocephalus. Yes. And it can differentiate between, help me also in differentiation between the ventricular dilation ex vacuo and communicating hydrocephalus.
Sometimes the membrane is fully fenestrated. Who actually in a conventional image is a membrane, but it is much more fenestrated to push CSF and diagnose communicating hydrocephalus. انا هقول لحضرتك ببساطه انا بتلخبط ما بين التايت ستينوزيس ان هو يعمل لي هايبر دايناميك سيركيوليشن وانكريز الفيلوسيتي تحت الممبرين وما بين الكوميونيكيتنج هيدروكيفلاس من فولي او ماركت فينستريتد ممبرين.
Okay, this will appear also with thin sections anatomical images. In anatomical images, we will see the membrane with the flow.
Don't show the fenestration inside the membrane.
Yes, I can see the fenestration. I will see I can see the membrane. However, in communicating hydrocephalus, I can't find any obstacle through the pathway of the CSF.
يعني أنا شفت حالات ممبرين مع communicating hydrocephalus.
طب
so it's not communicating.
هو اللجنه المنظمه عايزانا نوقف الاسئله ونخليها في الاخر.
طيب تمام.
فاحنا في المحاضرات بقى القادمه خلاص هنعملها من غير اسئله ولا مني ولا من حد عشان هم عايزين يتعشوا باين ولا حاجه اي حاجه مش عارف ايه. طيب اوكي. So thank you Dr. Shaima. Moving to our next speaker, my dear friend Dr. Abdelaziz Nekedi, professor of radio diagnosis from Alexandria University, who always enlighten us with his talks, which take always an educational learning pattern. So I like his style very much, and I'm sure you will enjoy his talk.
بسم الله الرحمن الرحيم. Thank you, Dr. Yasser, for this introduction, and actually I would like to thank you and Professor Ihab Samireda for this kind invitation to this wonderful conference. I will present imaging of the metabolic encephalopathies in adults. In the coming few minutes, you will know some about the definitions and the classifications, neuroimaging findings in metabolic encephalopathies, and finally, we will try a simplified approach in these conditions. Encephalopathy has been described as a general alteration in the brain function manifested as attentional disorder anywhere in the continuum between hyper-alert, agitated state and coma. The patient usually present with altered sensorium associated with seizures, focal neurological deficits, brainstem signs, and extraaxial extrapyramidal movement disorders. Sometimes the clinical evaluation is unsatisfactory, and the imaging may provide the only clue in this condition. If we classify encephalopathies according to the cause, metabolic encephalopathy, sure, they may be malfunctioning organs such as kidney or liver, or ammoniacal encephalopathy, electrolyte imbalance such as osmotic demyelination, hypoglycemia, non-ketotic hyperglycemia, vitamin deficiencies, B1, B12, isoniazid or metronidazole. Isoniazid is a drug, and miscellaneous such as heat stroke and hypoxic ischemic encephalopathy. Actually, on imaging basis, we have tried to classify them into 4 groups, as you see. The first group, where there is mainly cortical and subcortical affection with or without basal ganglia involvement or deep white matter changes. The first one, hypoxic ischemic encephalopathy. The cause in adults, cardiac arrest, cerebrovascular stroke, drowning, or asphyxia. In severe hypoxic encephalopathy, usually it affects the gray matter, including the cerebral cortex and the basal ganglia. The thalamus and cerebellum may be affected, and remember this point. If the CT is done very early, it may be normal, especially in mild cases, or we can see some sort of edema and smudging of the basal ganglia. Also, the distinction between gray and white matter is difficult. In more severe cases, as you see, there is a sign called reversal sign. The gray matter, white matter, gray and white, they are reversed due to the presence of edema in the gray matter. And in more severe cases, we can see what is called white cerebellum sign. The whole brain is cerebral hemispheres are hypodense, while the cerebellum is still maintaining his density. The most sensitive sequence is the diffusion-weighted imaging. It can be positive as early as 1 hour, even 30 minutes, and it can be very mild like this, or very frank like this. And it is very important to not to miss a phenomena called early cortical laminar necrosis, which is presented by bilateral diffuse cortical diffusion restriction. And take care not to miss this finding due to a phenomena called superscan. You know superscan in nuclear medicine. If you don't adjust the window and you don't look for the EDC map, you may miss this diffusion restriction in the cortex. Please look for these images, and if you adjust the window and look for the EDC, you will discover that we have gyriform pattern or superscan diffusion restriction. Later on, it will present by the typical T1 hyperintensity without SWI abnormality and CT hyperdensity. There is a phenomena which is called delayed post-anoxic leukoencephalopathy. It can be seen in after 2 to 3 weeks in the form of diffuse white matter hyper intensity and restricted diffusion, and may be reversible. The second one is hypoglycemic encephalopathy. We see it in diabetics with due to accidental overdose, pancreatic insulinomas, and some herbal preparations. Hypoglycemia can cause selective cortical and caudoputaminal injuries. It is similar to hypoxic ischemic encephalopathy, But the clue here that in hypoglycemic encephalopathy, the cerebellum, brainstem, and especially the thalami are spared. Also, it can present by cortical laminar necrosis, as you see, and Ticker, the same can occur in the basal ganglia. If you find T1 hyperintensity in the basal ganglia, later on it is also a laminar necrosis. The same also regarding the white matter, and it can be reversible, and a very characteristic feature of hypoglycemic encephalopathy is what is called the reversible splenial lesion or the cytotoxic lesions of the corpus callosum, which may disappear on follow-up. A differential diagnosis here is vitamin B12 deficiency. We can see it in vegans, atrophic gastritis, pernicious anemia, and usually it presents similar to the delayed post-anoxic changes where we can find deep white matter T2 hyperintensity. It can be minimal, even to be mistaken with MS. Ammoniacal encephalopathy. Please remember the following. Hyperammonia is not only seen in advanced liver disease. We can see it in multiple myeloma, urease-forming bacteria, urea cycle enzymes, bone marrow transplantation, and so on. So hyperammonia is not only just liver. It is characterized by the following. Selectivity for the cortex by diffusion restriction, especially the ansular cortex and the cingulate gyres. Okay? The thalami may be involved. And the very characteristic feature is the sparing of the peri-Rolandic cortex, as well as the occipital cortex. This is a clue to the diagnosis, sparing of the occipital and the peri-Rolandic cortex. I know all of you know about PRESS, posterior reversible encephalopathy syndrome. We know the causes, not only just acute hypertension, but there are a lot of causes that can cause PRESS. In typical cases, about 75%, there is no restricted diffusion. And if you do MRA or CT angiography, you can see areas alternating of vasoconstriction and vasodilatation, or even diffuse vasoconstriction. This is 3 typical patterns. The first one, which all of us know, is the dominant parieto-occipital pattern. The second type is the superior frontal sulcus pattern, and the third one is hollow hemispheric watershed pattern. But please remember, he has many faces and many atypical presentation. It can affect the cerebellum, the brainstem, even the spinal cord. It can be unilateral. It may be associated with restricted diffusion, and this is a bad sign. Hemorrhage, enhancement, leptomeningeal enhancement. So these are the many phases of PRESS. Actually, they are rare, but they are variants. The second group is mainly basal ganglia involvement, non-ketotic hyperglycemic encephalopathy. We see it in diabetic patient with uncontrolled diabetes, high glucose level, non-ketotic, presented by chorea hemipalismus on the contralateral side. We see it in CT, like hyperdensity in the basal ganglia, on MRI, on T1, hyperintensity in T1, and you must take care about this finding. You should ask about the clinical, because this may be just hemorrhagic infarction, but if the patient is hyperglycemic and presented with choreal movement, it is non-ketotic hyperglycemic encephalopathy. The signal is variable on T2 and on FLAIR. Sometimes it may be bilateral, but this is very rare. Regarding hepatic encephalopathy in chronic hepatic disease, we can see hyperintensity in T1 involving the globus pallidus and the crura cerebri and substantia nigra. This is very characteristic and may be reversible. Sometimes you can see white matter changes. Uremic encephalopathy, usually the MRI is normal, but typically we can see this finding. Basal ganglia T2 hyperintensity and T1 hypodensity, taking the appearance of what is called as a lentiform fork sign. The stem is formed by the meeting of the external capsule and the internal capsule. The outer arm is the external capsule, hyperintensity, and the two inner arms are between the two laminae of the medulla oblongata. Don't forget this sign. And it will proceed to bilaterality like this. And you can see lack of diffusion restriction, just ADC map along the fork, but the core may be restricted. Take care that the fork sign is seen in any metabolic acidosis due to any cause. The third group is mainly affection of the brainstem with others. Vernix encephalopathy, thiamine deficiency P1. We can see it in alcoholics and non-alcoholics. It is characterized by the preferential involvement of the perivertebral regions because they are thiamine-dependent metabolism in this region. They involve the medial aspects of the thalami, the mammillary bodies, periaqueductal area, the posterior surface of the medulla, which is the floor of the third ventricle. Sometimes we can see basal ganglia and perirolandic restricted diffusion. We can see enhancement in these areas. But take care, this is very important. These are the same areas involved in neuromyelitis optica where the aquaporin 4 is rich. These are the same areas, but we can differentiate by the clinical, the presence of myelitis and optic neuritis. Osmotic demyelination, which was previously known as central pontine myelinolysis. This is the typical hyperintensity in the bones, sparing the corticospinal tracts and the periphery of the bones, giving what is called Tradian sign due to sparing of the corticospinal tracts. It may show restricted diffusion, peripheral enhancement, with concomitant or independent involvement of the basal ganglia and the perirolandic region, the external capsules, and the splenium of the corpus callosum. There is a variant of this called postpartum hypernatremic encephalopathy with osmotic myelinolysis. It is characterized by selective affection of the corpus callosum and the corticospinal tracts, giving in the coronal image what is called glass of wine sign, which is along the corticospinal tracts. The last group is the mainly dentate nuclei affection, heat stroke. It is usually characterized by bilateral dentate nuclei and cerebellar white matter affection, hippocampi affection with enhancement or not, and characteristically it may involve the external capsules with hyperintensity along the borders of medial borders of the thalami. Metronidazole, which is flagyl, it is characterized also by similar appearance to the Vernix encephalopathy, but the clue here is that the mammillary bodies are spared. Dentate nuclei affection, as you see, dentate nuclei affection, if they are present, we may think of Vernix encephalopathy because flagyl as a thiamine antagonist. The clue here is look for the mammillary bodies. Isoniazide is a treatment of tuberculosis, and when it is associated with renal impairment, the patient may present with cerebellitis, especially affecting, as you see, the dentate nuclei. This is a simplified approach, but it is not true in truly simple. It may be more complicated. The first step, toxic drug-induced encephalopathy or conditions causing toxic or drug-induced encephalopathy, inflammation and sepsis should be excluded because they may give the same appearance as you see in all these cases. You should know about the clinical of the patient, suicidal attempts, cardiac arrest, diabetes, renal, blood sugar, liver, and so on. This is very important. The second step, look for the pattern and look for the specific signs. If you see symmetrical cortical diffusion restriction with or without basal ganglia affection, if they are sparing the perirolandic area and the occipital lobes, think of ammoniacal encephalopathy. If not, it is hypoglycemia or hypoxic ischemic encephalopathy. Usually, the thalami are spared in hypoglycemic encephalopathy, but may be affected in hypoxic ischemic encephalopathy. If you see the typical symmetrical cortical and subcortical edema in the parieto-occipital region without restricted diffusion, this is PRESS. Regarding the basal ganglia, unilateral CT hyperdensity and T1 hyperintensity in hyperglycemic patient presented with chorea, you should think of hyperglycemic non-chototic encephalopathy. T1 hyperintensity in globus pallidi and extending to the substantia nigra hepatic encephalopathy. If you see this characteristic uremic lentiform fork sign, think of metabolic acidosis and uremic encephalopathy. If you see bilateral basal ganglia high signal, you should think that it could be a hypoglycemia, hypoxic ischemic encephalopathy, or osmotic demyelination. But if you find this specific trident sign in the bones, you should go for osmotic demyelination. Regarding the medial thalami and periaqueductal region, if the corpus callosum, optic nerves, and spinal cord is affected, think of neuromyelitis optica. If not, it could be Wernicke, it could be metronidazole, but dentate nuclei are affected in metronidazole while the mammillary bodies are spared. Regarding the dentate nuclei, ask about the history of treatment, isoniazide with renal impairment. If we have periaqueductal and posterior brainstem, think of metronidazole, but here the mammillary bodies are spared. If not, atypical Wernicke should be considered. And if you find bilateral deep cerebellar and dentate nuclei signal, external capsule, and hippocampus, you should think of heat stroke. I would like to thank you very much for your attention.
Thank you, Dr. Abdelaziz, for this wonderful talk. As usual, I'm sure we have a lot of questions, but we are obliged to move on. And I really liked your heat stroke slide. So something new. Thank you. So moving on, our next speaker is Professor Dr. Rasha Shafi from Tanta University. Dr. Rasha is well known for her interest in all innovative work and the high-end techniques of neuroimaging, and today she will talk to us about pediatric MR spectroscopy.
Thank you. Thank you. بسم الله والصلاة والسلام على رسول الله. هنتكلم النهارده عن التيبس اند تريكس ان pediatric MR spectroscopy. المحاضرة النهارده from our work, nearly from our work. معظم المحاضرة كلينيكال، يعني هنستفيد بيها في شغلنا. دي الحالات اللي دايما بتيجي في الاطفال بغض النظر عن التيومرز. دي دايما الحالات اللي بتيجي يا اما من نيكيو الهايبوكسيك اسكيميك انكيفالوباثي او البيليروبين انكيفالوباثي، او بيشنت ويز ديفلوبمنتال ديلي، او ميتابوليك ديزيز، او ابيليبسي. نبدا بالنيكيو ريليتد ديزيز، نيونيتال بيليروبين ديس اوردرز. يعني الطفل كان في الحضانه والبيليروبين بتاعه ارتفع وغيروا له دم ومش عارفه ايه وعنده شويه مشاكل، فبيقولوا لنا قولوا لي مشكله المخ وصلت لحد فين. دلوقتي لما الطفل ده يجي لي لازم افرق ما بين 3 حاجات، يا اما نورمال، يا اما نيونيتال هايبر بيليروبينيميا، يا اما نيونيتال بيليروبين انكيفالوباثي او الكيرنيكترز. هيفرق جدا مع الدكتور. هايبر بيليروبينيميا زي كل الاطفال البيليروبين بيرتفع عندهم وما بأثرش على المخ، انما نيونيتال بيليروبين انكيفالوباثي او كيرنيكترز لا، المخ بدا يتافكتد وده ممكن يسيب ريزيدوال للبيبي. البرين عندي في معظم الاحوال بيبقى نورمال او هايبر انتنس جلوبس باليداي من الديبوزيشن بتاع البيليروبين. الام ار اس الفوكسلز، انا في كل ديزيز لازم اعرف الريجن اوف انترست. ريجن اوف انترست في البيليروبي في الهايبر بيليروبينيميا هي البيزل جانجليا، ودايما في الاطفال اللي هم نيونيتس دايما هنركز على البيزل جانجليا لان هي دي الحاجات اللي فيها ميتابولايتس كونستانت شويه. الفرونتال الاوكسيبيتال الحاجات دي بيبقى فيها هايبومايلينيشن، ما اقدرش اخد منها نتائج واضحه. ده اللي هيفرق لي جدا ما بين ال3 ديزيز. في كل ديزيز في ميتابولايتس بتزيد وفي ميتابولايت بتقل ومش عارفه ايه، بس دايما بيبقى عندي جولد ستاندرد ميتابولايت هو اللي دايما اللي بعتمد عليه في التقرير. في الهايبر بيليروبينيميا بعتمد دايما على الان ايه على الكرياتينين، الباقي هستخدمه بس ده اللي هاكد عليه قوي. بالتقريب كده طول ما هو اعلى من 1 فهو كويس، طول ما هو اقل من 1 يبقى احنا دخلنا في النيونيتال انكفالوباثي. زي ما قلنا في ميتابولايتس ثانيه بتزيد بتنفعني برضو، التورين، الجلوتامين، جلوتامات، المايو انستول، اللاكتيت، ودي بتعمل لي مشكله ان في اطفال بيجوا لي عندهم تو باثولوجي، في عندهم هايبوكسيا وعندهم هايبر بيليروبينيميا، وبالتالي انا مش هعرف احل المشكله من الاثنين مع بعض، اقول له انه عنده هايبر بيليروبينيميا وعنده مثلا هايبوكسيك اسكيميك، لان الاثنين من الباثولوجي بتاعهم اللي بيزيد اللاكتيت. التورين ميتابولايتس باخد بالي ان هو بعد الكولين على طول، اول ما الكولين ينزل التورين ميتابولايت بيرتفع. تاني حاجه في النيكيو هو الهايبوكسيك اسكيميك انكفالوباثي، ده برضو الريجن اوف انترست في البيزال جانجليا، بناخد مالتي فوكسل وبناخد في البيزال جانجليا ونشوف الميتابولايت او الجولد ستاندرد ميتابولايت عندي تبع الاوروبيان جورنال اوف راديولوجي سترونج بيبر، قالت لنا خدوا اللاكتيت على الكرياتينين ميتابولايت، هو ده اقوى حاجه، ما هو اقل من نص فهو مايلد، من نص لواحد ونص فهو مايلد تو مودريت، ما هو اكتر من واحد ونص فهو ماركت. يبقى انا الدكتور هيبقى مهم عنده جدا اقول له احنا في انهي ستيج من الانكفالوباثي، لان ده بيتحدد عليه التريتمنت والهابيليتيشن بتاع البيبي. دي ستيج اوف سيفير هايبوكسيك اسكيميك انكفالوباثي، وحتى الكونفنشنال فيها جيرمينال ماتريكس هيموريدج، والسبكتروسكوبي طلعت اللاكتيت على كرياتينين ريشيو 2.6 زي مور ذان 1.5 سيفير هايبوكسيك اسكيميك انكفالوباثي. الحاجه اللي بعد كده الديفلوبمنتال ديلي، الطفل بيجي لي ما بيمشيش، اقل من زمايله، عنده صعوبه في التعلم، فبيجيبوا لي يقولوا لي طب شوف لنا هل المشكله من المخ ولا مشكله من التعلم او مشكله من اي حاجه ثانيه. الريجن اوف انترست هنا هنكبر شويه لان الطفل ده هيبقى كبير شويه، هناخد فرونتال اوكسيبيتال بيزال جانجليا. ناخد بالنا ان الاطفال في نورمال تشينجز في الوايت ماتر ميتابوليزم ويز برين ديفلوبمنت، يعني ما اقدرش اقول ان ايه على كرياتينين ريشيو في طفل عنده سنه زي عنده سنتين زي عنده 3 سنين. الان ايه كرياتينين ريشيو increased rapidly from 1 month to 1 to 2 years. الكولين على كرياتينين decline rapidly from 1 month to 1 year then decline more slowly until 2 years. So take home message, don't diagnose developmental delay before 2 years. The abnormal MRS finding denote healthy children much younger than 2 years. لو لقينا الميتابولايتس عندي قليله جدا لازم اعمل ستريس فور فولو اب افتر 2 years. ده طفل عنده ديفلوبمنتال ديلي وعملنا له السبكتروسكوبي. الريشيو اوف انترست هي الان اي على الكرياتينين ريشيو، في حاجات ثانيه بتاثر بس اللي هنا المهمه قوي الان اي على الكرياتينين ريشيو، هو المفروض ان هو يبقى اعلى من 2، اقل من 2 لا يبقى اقول للدكتور ان في نيورونال dysfunction and suggest developmental delay. تيك كير واحنا بنعمل السبكتروسكوب بتاع الاطفال بتاع الديفلوبمنتال ديلي، الاوكسيبيتال فوكسلز بتبقى ساعات بناخدها في التيرمينال زون اوف مايلينيشن. تيرمينال زون اوف مايلينيشن بيبقى فيه هايبو مايلينيشن، بنلاقي كولين وكرياتينين قليلين جدا في الجزء اللي التيرمينال زون اوف مايلينيشن، وبالتالي الجولد ستاندرد ميتابولايت عندي هيبقى عالي جدا. يعني لان ايه كرياتينين اللي احنا قلنا المفروض ان هو يبقى 2 ممكن يطلع عندي 3.5 4. طبعا دي خادعه لان احنا حاطينها في اريا التيرمينال زون اوف مايلينيشن او هايبو مايلينيشن، وما اخدش من الفوكسل ده اي نتائج واستبعده. Summary of metabolite changes in developmental delay: decrease NA creatinine ratio ده الجولد ستاندرد، بيبقى decrease NA على كولين ريشيو وانكريز كولين على كرياتينين ريشيو. الدايلما الكبيره بتاعت الميتابوليك ديس اوردر، ودايما لما الروتين الدكاتره بيبعتوا لنا مع الجينيتك انفستيجيشن والحاجات دي كلها بيبقوا عايزين يعني نساعدهم في الوصول للميتابوليك تشينجز او ديس اوردر اللي عند الطفل. للاسف السبكتروسكوبي مش هيقدر يحط ايديه يعني بقرار جامد الا في بعض الديزيزز من الميتابوليك، غير كده مش هقدر اتكلم. اول حاجه الحلو جدا جدا بالسبكتروسكوبي هو كرياتينين ديفيشنسي ديزيز، لان انا بلاقي كرياتينين قليل جدا، بلاقي لان ايه على الكرياتينين، لان الكرياتينين في المقام فالريشيو بتاعلى جدا، بلاقيها 3.5 او 4، وده بيشخص لي بسهوله جدا الكرياتينين ديفيشنسي ديزيز. الكانافانز ديزيز برضو بلاقي الان اي وده الديزيز الوحيد اللي بيزود لي الان اي، وبشوف طبعا الاذر abnormalities الهايبر انتنسيتي في الوايت ماتر ريتشنج تو ذا سب كورتيكال يو فايبرز مع الانكريز الان اي مع سيمبتومز. خلاص انا ما اقدر اقول فعلا الديزيز ده كانافانز ديزيز. ميتوكوندريال ديزيز مش بقدر احدد قوي لان هو هيتروجينس وفي حاجات كتير بيزيد لي فيه اللاكتيت، ولكنه ما يدينيش دايجنوزس واضح الا مع مجموعه حاجات بقى زي ما قلنا الجينيتك والحاجات دي كلها. النون كيتوتيك هايبرجلايسيميا ممكن اشخصها بالسبكتروسكوبي، هلاقي فيه بايلاترال هايبر انتنس سيجنال انتنسيتي خاصه في الديفيوجن والفلير. في السبكتروسكوبي في الشورت تي اي بلاقي في لونج بيك along المايونستول عند 3.5 كده، بس البيك دي المفروض ان هي في الانترميديت تي اي المفروض انها تقل خالص. لو هي ما قلتش يبقى البيك دي ما هياش مايونستول، البيك دي جلايسين، وبالتالي اقدر اشخص النون كيتوتيك هايبرجلايسيميا. دي الميتابوليك ديزيز والتشينجز الدايلما كبيره جدا والتعامل معاها صعب جدا جدا جدا. لو انا ما قدرتش اوصل للدايجنوزس، ودي انا طلبت مره الدكتور ياسر عبد العظيم قلت له انا محتاره مش قادره اوصل للدايجنوزس، فقال لي خلي معاكي دايما المالتي موداليك ديزيز. في الميتابوليك ديزيز بشوف لازم لو انا فشلت هقول له ان في ليبيدز لاكتيد ده في ميتابوليك تشينجز في البرين، او انكريز جلوتاميت ده دينوتيك ميتابوليك ديستربنس. ده على اي حاجه اقدر اساعد بيها الدكتور، انما كشور دايجنوزس مش هقدر. الابيليبسي كونفنشنال ام ار اي از امبورتنت، ان 3 دي تي 1 مهم جدا، اكزيال ساجيتال كرونال 3 بلينز و3 بولز، الفرونتال اوكسيبيتال تمبورال. لازم الف حوالين الكورتكس في كل الحاجات، لازم اشوف الهيبوكامبس فلير ايمج اكزيال كورونال باراليل تو ذا temporal horn of lateral ventricle. ده انا باخد الباراساجيتال ايمج وامشي باراليل للهيبوكامبس عشان اوصل للصوره دي اللي هي الاكزيال. هاخد مالتي فوكسل هحاول اعمله على الناحيتين مع بعض، ما عرفتش هاخد الرايت لوحده والليفت لوحده. هحط فوكسل انتيرور وميدل وبوستيرور في الهيبوكامبس، انتيرور وميدل وبوستيرور، واطلع الميتابولايت. الميتابولايت او الريشيو اوف جولد ستاندرد ريشيو دلوقتي عندنا هو ان اي على كولين زي الكرياتينين ريشيو، ده الجولد ستاندرد بتاعي، وده بيقل في الابيليبسي. مشكلتنا ان احنا في الميدل والبوستيرور لو الجولد ستاندرد ميتابولايت ده لو اقل من 0.7 دينوتج نيورونال تشينجز ريليتد تو ابيليبسي. لكن الانتيرور ريليتد للانتيرور هيبوكامبس او الاميجدالا احنا ممكن نوصل لحد 0.4. تحت ال 0.4 ممكن نقول لان المكان دون بيبقى يعني اولا اللاكتيت فيه بيبقى عالي جدا، الميتابولايتس فيه بيبقى مختلفه عن بقيه الهيبوكامبس، فبالتالي انا اوصل في الانتيرور ده ل 0.4. تحت ال 0.4 يبقى ده ابنورمال، انما في الميدل والبوستيرور لا ارفعها شويه ل 0.7. انكريز الليبيد لاكتيت لو مهم جدا في تقرير الابيليبسي، ان انا اقول للدكتور في انكريز ليبيد لاكتيت ده دينوتنج ريسنت سيزورز او ميتابوليك ديسفانكشن ريليتد تو انيروبيك ميتابوليزم. في حاجه اسمها اسيمتري اندكس، لو انا لقيت البوث سايدز بتاع الهيبوكامبس الاثنين فيهم افكشن، الاثنين فيهم ميتابوليك تشينجز، هعمل حاجه اسمها الاسيمتري اندكس. هاخد الريشيو بتاعتي الجولد ستاندر، هطرح الرايت ناقص الليفت على الرايت زائد الليفت واضربها في 2. لما تكون الاسيمتري اندكس دي اقل قوي من 0.05 دي نقول ان في اسيمتري او laterality of the epilepsy toward the lower NAA على كولين. يعني انا لو لقيت الاثنين فيهم NAA على كولين زي الكرياتينين ريشيو قليلين هعمل اسيمتري اندكس بتاعي، لو لقيته اقل من 0.5 يبقى اقول لا في laterality toward the right side، لو لقيته عالي لا يبقى الاثنين ما فيش laterality معينه. كلو زي ما قلنا في difficult cases يعني try multi modality studies زي diffusion tensor imaging، البيت MRI، ال ASL. الconclusion MRS is essential MR technique in pediatric neuroimaging detected changes at the metabolic level. Pediatric radiologists should be aware of normal spectral changes according to the age, and the changes occur during development and significance of abnormal peaks and ratio in a variety of neurological conditions. Thank you.
Thank you very much دكتورة رشا. يعني لا ده جميل جدا. أنا بس يعني I have to give her credit for her talk لأنها as somebody like me doing spectroscopy for a long time to do spectroscopy in children and with such metabolites and everything is rather difficult. So she's doing a great job. We are working with brain tumors, so our life is much easier يعني. انا بس معلش لازم اسالك سؤال، الميجرمنتس اللي هي الاولانيه دي كانت على سنجل فوكسل اللي هي في الميتابوليك في الهايبوكسيا واللي هي في اول سلايدز كنت بتقول يعني كل الريشيوز دي كانت يعني لا مش سنجل سوري شورت ايكو ولا انترميديت؟
ما بينفعنيش قوي في الهايبوكسيا، مش بس بعمله برضو عشان الاقي كولين عالي كده، انما وطبيعي الطفل لما بيتولد بيبقى كولين عالي جدا، انما الهايبر بيليروبينيميا انا بعتمد على الان اي على الكرياتينين ريشيو، بعتمد على اللونج تي اي اكتر، بس ما زال برضو بيبقى معايا انكريزد ليبيد لاكتيت والتورين والحاجات دي بترجح لي ان في ميتابوليك تشينجز في البرين ريليتد تو ذا هايبر بيليروبينيميا.
So it's also you have to choose the proper echo time for the proper age for the proper location.
صعب جدا مع الأطفال جدا.
يعني you are doing a great job. Thank you very much. We moving on. We have dear Professor Dr. Muhammad Hummus from Cairo University, and he, as I know from my colleagues in Cairo University, is one of the rising stars in the field of neuroradiology, and he will talk to us about something also innovative, which is arterial spin labeling perfusion. Dr. Muhammad.
شكرا دكتور ياسر. بسم الله الرحمن الرحيم. Arterial spin labeling perfusion technique and potential applications. First, you have to define perfusion. Perfusion is delivery of oxygen and the nutrients to tissues by means of blood flow. Cerebral blood flow is the volume of arterial blood delivered to capillary bed in a unit volume of brain tissue per unit time. Regarding arterial spin labeling is an MR technique used to quantify tissue blood flow. It labels the arterial blood protons or spins by radiofrequency pulses, and there is no need to inject contrast media. The advantages of arterial spin labeling or ASL, it is a non-ionizing technique. It is completely non-invasive, no need of IV contrast. It is very suitable for perfusion studies in healthy individuals, patients with renal insufficiency, those who need repetitive follow-up, and the pediatric population. The principles of ASL acquisitions, first we have labeling, then post-labeling delay, then the acquisition. Let's take it in details. The first step is to apply radiofrequency pulse to invert the longitudinal magnetization of the arterial blood. Second step, we have a delay to allow this labeled blood to flow into the brain tissue. The third step is to have acquisition of the labeled images that contain signal from both labeled water and static tissue water. Step 4 is the acquisition of the control images without prior labeling of the arterial spin. The fifth step is the signal difference between the control and labeled images gives a measure of the labeled blood delivered to the tissues by perfusion. Let's simplify more. We have here the labeling plane, a post-labeling delay, and then the imaging slice. In the labeled image, let us imagine a voxel of brain tissue. This voxel contains stationary protons, which are aligned, their longitudinal magnetization is aligned in the direction of the applied magnetic field. Then we have these arterial protons. Their magnetization also is in the direction of the magnetization of the magnetic field. When they reach the labeling plane, their magnetization becomes inverted. Then they continue till they reach the voxel. In the control image, again, we have these stationary protons with their longitudinal magnetization in the direction of the magnetic field. And in the control image, we don't have a labeling process, so the arterial protons will continue till they reach the voxel. Now we will subtract control image minus the labeled image. The stationary protons will cancel each other. Then we have 3 protons in the control image in one direction, and in the labeled image in the opposite direction. By subtraction, 3 minus -3, we will have as if we have 6 protons in this direction, and these are the protons which are responsible for the MR signal. And from this, we notice that the protons responsible for the signal are very few, and they represent only 1 to 2% of the protons that are present in the voxel. And so the ASL technique is a low signal to noise ratio technique. Again, this is control image minus labeled image equal ASL image. In the ASL image, we can have a perfusion weighted image in which is a signal equal the magnetization of the control minus magnetization of the labeled image over magnetization of the control image. You can also have cerebral blood flow maps, and these are derived via a function that includes the ASL signal in addition to physiological and MR parameters such as relaxation rates, transit times, and the blood tissue water partition coefficient. Now we come to the labeling methods. We have continuous ASL or CASL, which uses continuous RF pulses that are applied to a labeling plane. We have also pulsed ASL or PASL. Here we use short RF pulses that are applied to a large slab, not a plane. We have pseudo-continuous ASL or PCASL, which uses long series of pulses that are applied to a labeling plane. The continuous ASL has the advantage of having high signal to noise ratio due to its long labeling duration and the small gap between the labeling and the imaging planes. But it has the disadvantages of the magnetization transfer effect that causes errors in the subtraction process and reduction of the labeling efficiency. Also, the main disadvantage of CASL is it is taxing on the hardware and requires modified RF amplifiers that is not available in most current clinical imaging systems. Regarding the pulsed ASL, it has the advantage of having it is less susceptible to magnetization transfer effect and so has higher labeling efficiency, but it has the disadvantage of low signal to noise ratio due to short labeling duration and large gap between the labeling slice and the imaging plane. Then we have the pseudo-continuous or the BCASL. It is an intermediate technique. It has the advantage of CASL of having a high signal to noise ratio and the advantages of PASL of having a high labeling efficiency. The last labeling method is called the velocity selective ASL, and it depends on the velocity of the arterial water rather than its position. And for example, if we take a typical cutoff velocity of 2 centimeters per second, it will dephase spins in arterioles that are 100 microns or more in diameter and results in labeling much closer to the site of the capillaries. The velocity selective ASL has disadvantages of having lower signal to noise ratio, and it is sensitive to other flowing fluids such as cerebrospinal fluid. Then we come to the time delay between the labeling and the imaging. This time is needed to allow for the labeled bolus to flow into the tissue target. And this delay is set just longer than the arterial transit time. And the range of the expected arterial transit time depends on age, and the delay should be adjusted accordingly. And as we see in these figures, that the post-label delay differs according to age between neonates, children, and adult subjects. We come to the image acquisition. And as we mentioned before, that the ASL has low signal to noise ratio, inherent low signal to noise ratio. So the imaging sequences used in readout need to have high signal to noise ratio. First, echoplanar imaging was used, but it has the disadvantages of artifacts at regions of high susceptibility and introduction of variable delay between imaging slices. The preferred readout method is 3D sequences, such as 3D Grace or 3D Rare, which allows acquisition of the whole brain volume with either multi or single shot excitations and with reduction of the susceptibility weighting. What about the field strength needed for ASL imaging? ASL, as we mentioned, is a low signal to noise ratio technique, so it will benefit greatly from high field strengths, because high field strengths will offer high signal to noise ratio in addition to T1 prolongation, which allows for greater accumulation of tagged blood water. Again, 3 Tesla is much better suited for ASL than 1.5 Tesla. However, this does not mean that 1.5 Tesla cannot be used, and in fact, it can be ideal in certain applications where a relatively high perfusion is expected. Now, how to optimize the quality of ASL imaging? Magnetic field is 3 Tesla better than 1.5 Tesla. Reception coil, the multi-element coil is superior to gauge coil. Type of labeling depends on the indication magnetic field. P-Castle is better than Passel, better than Castle. Acquisition of images, 3D is superior to 2D with elimination of signal from the background and the use of parallel imaging. The TE is adjusted as short as possible. TR is sufficiently long for sufficient relaxation of protons between the acquisitions. And the post-label delay is sufficiently long to give enough time for labeled proton to reach the capillaries, but sufficiently short to avoid excess relaxation of the labeled protons. Now we come to the potential applications of ASL. In neurodegenerative diseases, PET-CT was used in the workup of dementia via the assessment of brain metabolism, but ASL is a very promising alternative technique for FDG PET. Why? Because perfusion and metabolism are typically tightly coupled in the brain, and also the addition of an ASL sequence to an existing MR protocol is minimally demanding for the patient and does not require additional radiation or the use of contrast media. ASL is less costly, and ASL also allow assessment of brain structure and perfusion in one imaging session. It's a case of Alzheimer dementia. T1-weighted images show atrophy in the posterior parietal regions. ASL shows hypoperfusion at the same region, and FDG PET shows also hypometabolism in the same region. In cerebrovascular diseases, ASL versus dynamic susceptibility contrast perfusion. ASL allows perfusion imaging if there is contraindication to IV contrast, and it simplifies the acquisition of quantitative cerebral blood flow. And ASL is found to be equivalent to dynamic susceptibility contrast and can be used for a mismatch approach with diffusion-weighted images. Also, ASL has additional values. We can perform multi-delay ASL, from which we can acquire both cerebral blood flow and arterial transit time images. Also, we have vessel-selective ASL that provides the chance to selectively label vascular territories, such as the left carotid, right carotid, or vertebrobasilar territories. This case shows acute infarction with penumbra. Diffusion-weighted images shows an infarction in the right cerebral hemisphere. The ASL shows larger perfusion defect denoting penumbra. Here is a case of TIA. Diffusion-weighted images is normal. The ASL shows areas of relative hyperperfusion, the left posterior parietal region, and this acquisition is made by multi-delay ASL. MRA and digital subtraction angiography shows focal stenosis of the middle cerebral artery. In cases of hydrocephalus, it was found that in cases of symptomatic hydrocephalus, there is areas of hypoperfusion at the frontal and parietal regions in ASL. Post-shunting, resolution of symptoms, the ASL retains again normal, despite the hydrocephalus is still present in the T2-weighted images. In arteriovenous malformation and fistula, under normal condition, during the first pass of blood, more than 90% of labeled water is extracted from the capillaries to the extravascular spaces and stay for several times. So most of the labeled water decays within the brain parenchyma and it does not reach the veins. In AVM or dural AV fistula, the capillary bed is absent, so the labeled water appears in the venous structures. Here we have a case in T2-weighted images. There is very subtle signal void areas in the inferior frontal region. In ASL, there is obvious linear high signal intensity within the vein, and the MRA shows evidence of dural AV fistula. ASL in neoplasm, in primary brain neoplasm, high-grade tumors are associated with high metabolism and cerebral blood flow, while low-grade tumors typically demonstrate lower cerebral blood flow. Here we have a case of anaplastic astrocytoma that shows evidence of hyperperfusion in the ASL image. In secondary CNS lesions, ASL may be helpful for detection of metastatic lesions with high vascularity and increased cerebral blood flow, such as metastasis from renal cell carcinoma, angiosarcoma, hemangioblastomas, and melanoma. Here we have a case of multiple hemangioblastomas in the brain. They appear in the T1 post-contrast images. They also appear very well and very clear in the ASL images. ASL and treatment response. Here a case of radiation necrosis of lung metastasis. The post-contrast T1 images shows an irregular marginally enhancing lesion in the left parietal region. The ASL shows no evidence of hyperperfusion, and the FDG PET images also show no evidence of hypermetabolism. ASL has role in postoperative cases. particularly in the recent post-operative cases, because it gives better imaging performance compared to dynamic susceptibility contrast, because dynamic susceptibility contrast is affected by the blood byproducts. In epilepsy, in the acute periictal period, the CSF flow increases due to pathological neuronal activity. In chronic periictal period, the cerebral blood flow is reduced as the epileptogenic region is less functional and less active. To the left, we have an interictal case. The FDG bit shows hypoperfusion in the right temporal region, and the ASL shows hypometabolism. FDG bit shows hypometabolism in the right temporal region, while the ASL shows hypoperfusion. To the right, we have ictal images. The flare and the diffusion weighted images show left temporal hyperintensity with corresponding hyperperfusion in the ASL. Finally, in depression and psychosis, the ASL studies showed that the different subtypes of depression or stages of psychosis are associated with different patterns of CSF alterations. And in pain and migraine, it is thought that migraine attacks might involve vascular dysregulation. So mapping the brain cerebral blood flow by ASL might reveal insights into the pathophysiology of migraine. Thank you.
Thank you very much, Dr. Mohammed, for such a wonderful talk and overview and covering of this nice topic. And to take from him, I advise you all to advocate ASL in your practice. You don't need to inject contrast. It's a quick sequence. And if you are buying, buy the P-Castle, as he alluded to, because it's the best now in the market. And it really is helpful in all aspects of neuroradiology, as Dr. Mohammed eloquently showed. Thank you very much. Now moving to our next speaker, Dr. Hoda Sakr, and representing the Mansour University team, who are pioneers now in Egypt in the artificial intelligence in neuroradiology. We like very much their work, led by our dear professor, Dr. Lamia Esserougi, and with her is Dr. Mahitab as well. And in the past meeting, they talked about, and maybe yesterday I was not here, about artificial intelligence in gliomas. Now today we are talking about posterior fossa tumors, which is something also fascinating, so we are so anxious to hear you.
Thank you, Dr. Yasser. We want to talk about deep learning for posterior fossa tumors detection and classification. First, we will go through certain important definitions in our lecture: artificial intelligence, machine learning, artificial neural network, and deep learning. We want to talk about clinical applications of artificial intelligence in neuroradiology and its application in posterior fossa tumor in particular. Also, we will go through challenges against artificial intelligence and deep learning. And finally, we will talk about future role of radiologists in artificial intelligence world. First, what is artificial intelligence? It is a science devoted to making machines think and act like humans. While machine learning is a subset of artificial intelligence in which a model learns to solve a particular task by encountering multiple example inputs for that task. What is deep learning? It is a form of machine learning that utilizes artificial neural networks which have multiple layers. Artificial intelligence means the computer ability to perform tasks that are similar to those performed by humans. Intelligent machines will replace human capabilities in many areas, especially in radiology field. What is artificial neural network? It is a mathematical representation of the human neural architecture. It is formed by a series of neurons or nodes that are organized in layers: input layer, one or more hidden layers, and an output layer. This is a basic representation of the artificial neural network with neurons similar to those within a brain. What are the main clinical tasks artificial intelligence can perform? It can perform three main clinical tasks: detection, characterization, and monitoring. Detection is by localizing objects of interest in radiographs. Characterization is by segmentation, diagnosis, and staging of tumors. While monitoring is by monitoring changes in a tumor over time, either in natural history or in response to treatment. There is an important term called the CAD system, including computer-aided detection system and computer-aided diagnosis system. The detection system is for detecting and locating the abnormal area, while diagnosis system is for diagnosing and classifying benign or malignant tissues. What is the application of artificial intelligence in posterior fossa tumors? Among childhood malignancies, pediatric brain tumors are the second most common and the leading cause of death from solid tumors. Posterior fossa tumors account for about 54 up to 70% of brain tumors in pediatric population, compared with less than 20% in adult population. The most common subtypes of posterior fossa tumors among children are medulloblastoma, ependymoma, pilocytic astrocytoma, and diffuse midline glioma. Accurate preoperative diagnosis could also help in preoperative evaluation and to guide surgical planning for patients with different types of tumors. MR imaging review is essential for tumor diagnosis and evaluation, yet definite tumor histopathological classification is done by biopsy. The methods: first, image acquisition. The MR imaging was performed using 1.5 Tesla scanners. The main MR sequences are T1 contrast enhanced sequence, T2 weighted image, and ADC maps. ADC images were calculated from acquired diffusion weighted image with p-values of 0 and 100 seconds per cubic millimeters. Then the image segmentation. MR images of all patients were segmented using a 3D slicer software, and regions of interest were manually drawn section by section on T2 weighted image, T1 contrast enhanced sequence, and ADC images. The ground truth labels for our study is pathology from surgical specimens from medulloblastoma, ependymoma, and pilocytic astrocytoma, except for most patients with diffuse midline glioma who were diagnosed primarily by MR imaging. Our study includes a number of 50 children with posterior fossa tumors, including medulloblastoma, pilocytic astrocytoma, and ependymoma, extracted the radiomics features from T1 contrast enhanced image, T2 weighted image, and ADC maps. Then we will go through the posterior fossa tumors pre-processing. Pre-processing is applied to the contrast enhanced MR scans to delineate the tumor lesions. These lesions will be used as regions of interest across different imaging modalities. Then we extract features. 3 features are modeled to provide a quantitative discrimination between the tumor lesions. First, the texture features, then morphologic features, and finally functional features. Generally, the tumor appearance is modeled using a set of texture features. The morphologic features are based on constructing histogram of oriented gradients and estimating the tumor volume, which is a 3D representative model of the lesion. Then the functional features by estimating voxel-wise apparent diffusion coefficient. First order texture. Here we extract the texture analysis features from gray level histogram of the 3D constructed objects for each tumor lesion. The second order gray level co-occurrence matrix is a matrix that considered the spatial relationships between voxels at a neighborhood block. Gray level co-occurrence matrix accounts for how frequently a pair of gray level intensity values appears adjacently within the object. The second order gray level run length matrix measures the voxel's connectivity by looking at voxel runs. It examines how many times each gray level value appeared consecutively in a run of voxels. Then 3D histogram of oriented gradients, or HOG. The HOG descriptor is concerned with an object's morphologic structure, finding a simplified image representation that only includes the most significant details about the image. The HOG descriptor measures how frequent a gradient orientation occurs in a specific area of an object. The functional features, or ADC values. The functionality of posterior fossa tumors has effects on the imaging. ADC can be estimated from different gradient field strength and duration, p-value, for each voxel within the segmented tumor. Though it had investigated a large cohort of 617 children with posterior fossa tumors, including pontine diffuse midline glioma, medulloblastoma, pilocytic astrocytoma, and ependymoma, and the study constructed a 2D deep learning architecture model and use the T2 weighted image as input for tumor extraction. In this image, we can see how the computer-aided detection system succeeded in detecting how accurate the pathology is. For example, our first two images represents accurate prediction of the pathology. The truth label was pilocytic astrocytoma, and by 95% it predicted that it was pilocytic astrocytoma. In image B also it accurately predicted it to be medulloblastoma, while images C and D represent false prediction of the pathology. The performance of deep learning model in that study was compared with that of 4 radiologists and yielded an area under curve of 0.99 in the accuracy of tumor detection and the accuracy of 92% in tumor classification. Now, what are the challenges against artificial intelligence and deep learning? First, false positive rates remain a major barrier to its wide-scale use in health industries. The system is almost completely incapable of providing an explanation for its diagnosis. Implementation in radiology practice has legal and ethical challenges. For example, who will be responsible for the mistakes that a computer will make? We should also consider the patient acceptance or non-acceptance of humans not being involved in the process of interpreting their images, as well as regulatory issues. And finally, how to incorporate deep learning algorithms into the radiology work field in order to improve rather than disrupt the radiology practice. The future role of radiologists in AI world. Artificial intelligence medical imaging tools engenders palpable concern for the future of radiology about threat of increasing automation to job security. However, previous experience with automation in medicine tells a different story, like in ECG. The threats of AI to the size of radiology workforce may be overstated. Artificial intelligence to augment performance rather than replace radiologists are the most likely near-term outlook. And the benefits of augmentation is to improve quantification, reduction in repetition, and productive allocation of the tasks to radiologists. In long term, our field is likely to be transformed in ways that are difficult to predict. Artificial intelligence is set to alter many different aspects of practice beyond diagnostic support. Artificial intelligence education will need to target learners of all levels, from medical students to senior practitioners. Thank you.
Thank you very much for this eloquent talk, and really so interesting, Dr. Hoda. Now, I can't let you leave the podium except to ask you, have you reached the stage yet when you have a case that's difficult and you do the AI, and I know you're working with the people in Kentucky, in Louisville, Kentucky, and then this difficult case, you think of something and then the result from AI comes something else.
It is very common and very accepted, especially we are still in the, we haven't collected enough data to get enough results and the accuracy from the machine learning we are working on. We have to يعني in Arabic يعني هم دايما بيقولوا لنا it's like يعني ايه طفل واحنا بنعلمه، كل ما نعلمه اكتر كل ما هو يعرف اكتر.
You need more cases.
بالظبط، كل ما حالات اكتر كل ما هو يعرف اكتر.
So you have 50 cases and the guy in the article has 617 children. So there is still.
We are still working on it. Yes.
Right. But when you reach this stage, please tell us that AI really helped you in this diagnosis. Thank you very much.
Thank you.
Now we have finished our neuroradiology, moving on to head and neck, and what a better start than to start with the master and the professor, Dr. Rami Edward. His title is also fascinating. Mr. Sphenoid Sinus, because when Dr. Rami sent it to me, I wrongly wrote it MR of sphenoid sinus, and then he told me no, It is Mr. Sphenoid Sinus. So he has a great admiration to the sphenoid sinus that he's giving it a title. دكتور رامي بليز.
اولا انا بشكركم ان انا معاكم والدكتور ياسر، وحاجه ظريفه ان احنا نشوف بعض بعد الوقت الطويل ده. والحقيقه زي ما الدكتور ياسر قال، احنا لما ابتدينا ان هو موضوع غريب، اسم التايتل غريب، بس يعني هنشوف مع بعض ليه مستر سفينويد ساينس. First of all احنا السفينويد ساينس بيبتدي يبان في ال 8th week of gestation، ويبتدي يكبر from the 3rd year until full pneumatization by 18 or 30 years. وزي ما شايفين ان هو بيكبر مع الوقت. طيب هو it's a paired air cavities drains into the nasal cavity عن طريق السفينواسمويدال recess اللي هو هنا. طب ايه اهميته؟ يعني ادينا له اهميه كبيره كده ليه؟ actually عشان it is a very in a position very central في البرين في السكال بيس، وهاربرنج fossa for the pituitary gland، وكانفيرنس ساينس على الناحيتين زي ما احنا شايفين هنا. طب وايه اهميته برضه؟ ليه مستر سبينويد ساينس؟ الحقيقه اهميته ابتدت تظهر لما الناس ابتدت تو براكتس extensive skull base surgery عن طريق الترانسفينويد او البيس skull base approaches. So عن طريق السفينويد ساينس والسكال بيس we can approach عن طريق cribriform plate tumors، وعن طريق البلينم سفينويدال، وعن طريق البلين سفينويدال والدورسم سيلي والسيلر فلور والتوبركلم سيلي، وايفن we can approach surgeries for the atlantoaxial articulation. So it is an important structure، والحقيقه يصح ان احنا ندرسه باحترام شديد جدا عشان it proved to be a very important structure. First of all, the indications for transsphenoid surgery could be tumors for pituitary gland, craniophryngiomas, Raskis cleft cyst, germinomas, arachnoid cyst, epidermoid, pituitary apoplexy, empty cellular syndrome, meningiomas, cerebrospinal fluid leaks, the CSF rhinorrhea, clival tumors, sinonasal neoplasms. طب هندرس فيه ايه؟ ليه مستر سفينويد ساينس؟ Actually it has a lot of aspects to study. First of all السايز بتاعه والdegree of pneumatization، الشيب بتاعه، هل الفاسكولار structures and neurovascular structures around it ممكن يبقوا bulging into it فيبقى ده يهمني اكومنت عليه؟ هل في accessory septi؟ هل في حاجه اسمها اونودي سيلز؟ وبليز نريمبر المحاضره دي لو طلعنا منها بس بالاونودي سيلز انا راضي. طيب size is variable male and female، مش فروق رهيبه، مش شرط يعني في الميلز يبقى big sinuses. The sphenoid volume is definitely related to the extent of pneumatization. Racial variability exists. However, there is no significant change between the sinus volumes in patients having pituitary adenomas من اللي ما عندهمش adenomas. يعني size is not consistent. طب الشيب والنوماتيزيشن pattern، طبعا احنا عارفين القصه دي ان احنا we have to comment prior to transsphenoid approach على ال extent of pneumatization. We have different shapes and patterns of pneumatization. اول واحد اسمه conical type، يعني حته عظمه الساينس ما فيش ساينس، يعني we don't have an air cavity underneath the cella turcica، or at least we have a piece of bone, plate of bone that is more than 1 centimeter. معناه ان الراجل وهو داخل يعمل transsphenoid approach هيجيب معاه شاكوش وهيجيب معاه ازميل عشان نكسر العظمه دي ان كان اساسا يقدر يعمل كده. طب البريسيلر pneumatization where the air cavity is reaching the edge anterior edge of the cella turcica، وبعد كده incomplete cellular type where the air cavity is underneath the cella but not reaching the posterior aspect of the cella، أو complete cellular type where there is a good pneumatization with the air cavity filling down to the dorsum cell. طب هي يعني ده اللي احنا عارفينه. طب لما ندور بقى زياده نلاقي ان complete cellular type ده ممكن نقسمه تاني، ودي الحاجات الظريفه اللي لقيتها الحقيقه. لو رسمنا لاين اللي يلو دوتد لاين ده الفلور اوف ذا سيلا، والريد دوتد لاين ده هو ده الليفل اوف ذا فيديان كانالز، والبلاك دوتد لاين هو ده البوستيريور ايدج اوف ذا سيلا تورسيكا. هنتكلم على تو تايبس في كومبليت سيلر نوماتيزيشن، حاجه اسمها او فيو تايبس الحقيقه. سب دورسم تايب معناها ان الكافيتي والاكستند ورا يعدي السله، بس مش هتعدي، مش هتوصل للدورسم سيلي، مش هتطلع في الدورسم سيلي. وبالطبع الدورسم تايب الكافيتي اوف ذا ساينس هتعدي الدوتد لاين وتقول اكستند انتو ذا دورسم يعني دورسم سيلي، يعني طلعنا فوق اللاين بتاع السيلر فلور انتو ذا دورسم التوبركلم اللي هو التوبركلم سيلي. طيب اوكسيبيتال تايب، لا احنا هننزل الكافيتي، بدل ما هتنزل كده هتنزل ناحيه الاوكسيبيتال بون بلو ذا لاين اوف ذا فيديان كانال او نيرفز. طيب هو ممكن الاثنين؟ ممكن اكستند انتو ذا دورسم واكستند انتو اوكسيبيتال بون، وساعتها بنتكلم على كومبايند دورسم اوكسيبيتال تايب اوف نيوماتيزيشن. طب ده كان ده الاناتوميكال. طب السيرجيكال هم اسهل، هم بيسهلوا على حياتهم، يعني احنا بنتكلم برضو كتير، هم بيتكلموا type 1 there is no pneumatization, type 2 is a pre-cellular pneumatization, type 3 الحمد لله 57% من البني ادمين عندهم السيلر pneumatization، وده معناه انها accessible for surgery. type 4 ان احنا بنتكلم على post cellular pneumatization. النيوماتيزيشن اللي احنا حكيناها دي كنا بنتكلم in a dorsal aspect، يعني الاكستنشن لورا. طب what about lateral pneumatization؟ هل اللاترال pneumatization دي ليها كلام؟ لو احنا عدينا لاين بيربط الفورامين روتاندم والفيديان كانال اللي هو الدوتد لاين ده، بنتكلم على different patterns of lateral pneumatization. يا اما نروح للجريتر سفينويد وينج، يا اما نروح للتريجويد روت، يا اما نروح للليسر سفينويد وينج، ويبقى عندنا جريتر وينج باترن اوف نيوماتيزيشن، او lateral او تريجويد بروسيس باترن اوف نيوماتيزيشن، او فول لاترال تايبس ياخد الاثنين، ياخد تريجويد روت وياخد معانا ممكن ياخدهم كلهم بقى، يعني ياخد الليسر وينج والجريتر وينج والتريجويد روت. هنا a very nice example ان احنا عندنا well pneumatized hyper pneumatized sphenoid sinus extending to the middle cranial fossa، يعني greater sphenoid wing، وهنا pterygoid process، وهنا كمان aeration في الانتير clinoid process يعني lesser sphenoid wing، وهنا يبان لنا ان ادي الاوبتيك نيرف كانال وفي pneumatization on both sides، فده greater sphenoid wing pattern سواء على مستوى التريجويد روت بس او الجريتر sphenoid wing، وهنا كمان lesser sphenoid wing يعني lesser sphenoid wing pattern of pneumatization. طيب هل في other variabilities؟ Yes there are. هل لو احنا السفينويد ساينس ده بقى extending anteriorly وبقى in contact with the wall of the maxillary antrum، بنسميه حاجه اسمها اسمويدال recess. يعني ايه الكلام ده؟ يعني لو انت تقدر تدخل السفينويد ساينس من الماكسيلري انترم. طيب السبتال recess when we have pneumatization of the posterior portion of the nasal septum اللي هي الفومر بون، وبنسميها سفينو فورميان بولا، وده some sort of excessive pneumatization في ال posterior part of the bone nasal septum. هنا بقى يعني كل اللي فات عدى ده، هنا بقى يعني انا محتاج ان احنا فعلا دي انا اتعلمتها واحب ان الناس تخلي بالها منها. اونودي سيلز هي عباره عن ectopic posterior placed ethmoidal ear cells. طب مشكلتها ايه؟ مشكلتها الاتي. اول حاجه طب نعرفها ازاي؟ يعني حضرتك هتقول لي عندنا اونودي سيلز نعرفها ازاي؟ اول حاجه واسهل حاجه ان احنا في الكورونا نلاقي هوريزونتال سبتم، يا اما يونيلاترال او بايلاترال، يعني عندنا هنا كروس شيبت سبتيشنز بالعرض، لازم نفكر we could be having اونودي سيلز. طب يعني ايه اهميه اونودي سيلز؟ هنشوف اهميتها ايه دلوقتي حالا من الصور دي ونحكي عليها. احنا ماشيين كده، انا بتفرج، انا راديولوجيست، بعمل كومنت على سي تي بعد ما عملنا ام ار اي وشفنا التيومر بتاع ستيلا، عايزين نعمل سي تي نشوف الموتايزيشن، وانا بتفرج الناحيه اليمين هيلاقي عندي ايه؟ سبت. وانس ان عملت كده يبقى انا صحصح كده، اقعد عدل واركز ان انا عندي اونودي سيلز ولا لا. لو انا عملت كده خلصت كده وكده هبتدي اتفرج على السجد، انا كده هقف على نفس المكان بتاع السبتم اهو، سوري اهو. لحظه هنا بقى نقول الكلمتين اللي يهموني بقى. ده السبتم بتاعنا اللي احنا شايفينه في الهوريزونتال. لو لقينا في الساجيتال ان في continuity of the posterior ethmoidal ear cells above the septum ناحيه السفينويد we have onodi cells. طب يعني ايه يعني اونودي زهقتني؟ ليه؟ حضرتك هو بيدخل كده ترانسفينويد، بيدخل كده، هو بيدخل كده العادي يعمل ايه؟ يلاقي الفرونت اوف ذا سفينويد ساينس يشيله، يقول الحمد لله دخلت مين؟ السفينويد ساينس. الخطوه الجايه يشيل مين؟ السيلر فلو، يلعب فوق. طب الاونودي هيقول لك انا الحمد لله دخلت فين؟ شلت السفينويد، الحمد لله ده الفلورا والسلة، احنا رحنا في حته ثانيه. فخطوره الاونودي ان احنا لازم كومنت ميديكو ليجالي المفروض نتكلم عليها عشان نسبير هيم a lot of complication. انا مش عايزه يشيل ده يفتكر نفسه دخل سفينويد وبعد كده يدخل على البلينم. انا عايزه يعرف ان هو لازم يدخل شويه ايه لورا. طب احنا قعدنا نقول ممكن يكون انودي وممكن ما يبقاش انودي. طب ايه في اوبشن تاني؟ في اوبشن تاني. نخلص دي. الاوبشن التاني ان احنا عندنا هوريزونتال سبتم في السفينويد، مش عيب. يعني ده اكزامبل او نفس الاكزامبل بتاعنا at the level of the septum في الساجيتال there is continuity، فاحنا شخصنا انودي، يبقى ادي البوستيريور اسمويدال سيلز وراجع لغايه ورا يبقى انودي. طب نشوف بقى لو عندنا هوريزونتال سبتم. هوريزونتال سبتم ادي الهوريزونتال سبتم في الكورونا، نقعد عدل نقول احنا ايه انودي. اجي اشوف في الساجيتال الله not in continuity، يبقى this is not انودي، this is a horizontal septum في السفينويد. تمام كده؟ دي اهم حاجه المفروض نطلع بيها النهارده من هذه المحاضره. طب نكمل. هو احنا لو عندنا حاجات تانية ايه اللي يهمني تاني؟ اللي يهمني تاني هو السبتي دي اللي جوه الساينس ده، في سبتي ولا ما فيش سبتي؟ طب يعني اهميتها ايه؟ ما يبقى في سبتي، هيفرق ايه؟ هيفرق حاجه مهمه جدا. ايه بقى؟ السبتي مش فارقه معايا هو 2 3 4 5 ان شاء الله 10، يفرق معايا السبتم اللي في السفينويد ساينس ده ماسك في حاجه ولا لا. يعني اكزامبل a lot of patients have septi، بس لو السبتم ده كورونال ايمج ماسك في الاندنتيشن بتاع الاوبتيك نيرف. تعالى نشوف الوضع الكالاتي. الراجل دخل يعمل ترانسفينويد سيرجري، شال السبتم، عمل ايه؟ كسر الكنال بتاع الاوبتيك ايه؟ نيرف. طب another example سبتم تاني اهو، وهنا ماسك في الاندنتيشن بتاع الاي سي اي. الراجل دخل قوي كده بيشيل حديد قبل العمليه، دخل راح شال السبتم، عمل لي ايه؟ طلعني ديسكشن، طلعني ينزف، ان شاء الله ينزف جوه ويبقى محتاس. فيبقى السبتي مش مهم عددها، مش مهم حاجاتها، مش مهم ارقامها، مهم ان هي لما مسكت في الباوندريز اوف ذا سفينويد ساينس were in relation to vital structures ولا لا. يبقى احنا لازم نخلي بالنا انه if we have septi we comment هي ماسكه in which parts، عشان this could be كل الغرض ايه؟ this is only an approach، انا داخل اعمل العمليه مش عايز اطلعه بكومبليكيشن. نكمل. طيب احنا اتفقنا ان السفينويد ساينس مكانه very vital وفي vascular structures ونيرفز حواليه، يبقى لازم نتكلم على هل في indentation للاي سي ايز جوه الساينس ولا لا؟ عشان انا لما يدخل الاوضه هو ترانسفينويد ويلاقي البلج بتاع الاي سي اي يبقى عارف ما يقربش من ناحيته. طيب هل الاندنتيشن دي موجوده بس زي كده superior jugular bulb؟ هل هي اندنتيشن بس ولا في معاها ديهيسنس؟ لو معاها ديهيسنس يعني العظمه راحت، يخلي باله بدل المره 10. وممكن هنا يبقى عندنا اندنتيشن برضو ده up to the extent ان الاي سي اي يمشي totally within a pneumatized sphenoid sinus. طبعا كل الداتا دي حلال في الراجل الجراح لو انا اقولها له عشان ما يحصلش مشكله للعيان. طيب احنا اتكلمنا على الاي سي اي. طب الاوبتيك نيرف ملوش حظ في القصه دي؟ لا ليه حظ. احنا عندنا patterns of optic nerve relationship مع sphenoid sinus. تايب 1 pattern ان الاوبتيك نيرف موجود عادي فوق ومفيش اندنتيشن. تايب 2 ودول اسمهم ديلينو كلاسيفيكيشن. تايب 2 there is indentation، يعني هنا الاي سي اي على الناحيتين، سوري الاوبتيك نيرفز على الناحيتين عمل اندنتيشن لمين؟ للسوبيريور بورشن اوف ذا سفينويد ساينس. تايب 3 ده احنا اولموست كروسنج جوه السفينويد ساينس. تايب 4 احنا بدل ما نبقى سوبيريور احنا بقينا لاترال للسفينويد ساينس، يعني ده نورمال فوق سوبيريور وده هنا ايه؟ لاترال. طب وهنا بقى، هنا عندنا اول حاجه عندنا في الكورونا قال لنا عندنا ايه؟ اونودي. وكمان مش بس اونودي، والاوبتيك نيرف اندنتنج الاونودي، وهنا برضو اونودي والاوبتيك نيرف اندنتنج الاونودي وفي ديهيسنس. تمام. another classification for optic nerve pneumatization او pneumatization of the sphenoid sinus in relation to the optic nerve حاجه اسمها باترا classification. Type 1 there is no adjacent pneumatization للoptic nerve وده 60%. Type 2 pneumatization adjacent للoptic nerve 15%. هنا Type 3 pneumatization وindentation. Type 4 pneumatization with involvement of less than 50% of circumference. بيحاولوا يعني يعملوا لها نوع من الكلاسيفيكيشن. وتايب 5 انوماتيزيشن with involvement of more than 50%. يا عم انا مش فارقه معايا، انا فارقه معايا تقول لي اندنتيشن ولا لا، في سبتم ماسك فيه ولا لا، في ديهيسنس ولا لا، ده اللي يفرق معايا. طب يعني زي ما قلنا الاوبتيك نيرف احنا محتاجين نعرف ان احنا عندنا ماكسيلري نيرف هنا، كل ما الساينس يبقى نوماتايزد كل ما يبقى possibility of indentation of the nerve يزيد. هنا عندنا example for indentation by the maxillary nerve وهنا an example of indentation by Vidian nerve. شكرا يا جماعه جدا وميرسي، واتمنى ان انتوا تكونوا حسيتوا ان هو مهم.
Thank you Dr. Rami for such wonderful overview, innovative, excellent, يعني all the merits that you can find, and we hope you can practice this as you do. Thank you very much. Our next speaker is from this hometown. She is our host, so we are hosting her as well, Dr. Aya Rawi from Suez Canal University, and she's going to talk about something very important that I think all of us do, but we are eager to see how she will answer these questions. Preoperative CT and MRI assessment of cochlear implant candidates, what surgeons need to know. Dr. Aya.
Preoperative CT and MRI assessment of cochlear implantation candidates. What the surgeons need to know. Cochlear implant is an electronic device that's used to bypass the damaged portion of the ear and that directly stimulates the cochlear nerve to regain the hearing process. It is usually used in the patients with bilateral profound sensory neural hearing loss. The components include an externally worn speech processor and microphone with implanted receiver and electrode array. Simply, the steps include mastectomy, posterior tympanotomy, and the cochleostomy anterior-inferior to the round window. For the preoperative assessment of cochlear implantation candidates, we have first to determine what is the imaging modality that will be used and what is the causes of the sensory neural hearing loss, either it's congenital or acquired, and also what is the anatomical variants we should report and that may influence the surgical approach. Regarding the imaging modality, both CT and MRI render complementary information in preoperative assessment of cochlear implantation candidates. CT is an excellent modality to identify the anomalies of the bony laburnus, the vestibular aqueduct, and concomitant middle ear anomalies or anatomical variations that may complicate the surgery. While MRI is superior in assessment of membranous laburnus, internal auditory canal, CB angle, and the auditory pathway. NRE congenital anomalies represent 21% of the causes of the sensory neural hearing loss. It is usually due to abnormalities during the development of aortic capsule or due to genetic disorders. We will now demonstrate the most common cases of NRE abnormalities that was encountered in South Carolina University Hospital when we examined 60 diseased ears with sensory neural hearing loss. Our first case here we can find in the left ear that the cochlea is cystic, the cochlea is cystic with the loss of the external and internal features and loss of the modulus and the interscleral septi. The vestibule is also dilated with dilated lateral semicircular canal. It looks abnormal when we compare it with a normal right side. This was in keeping with the cystic vestibulocochlear malformation. Another case, we talk about the cochlear hypoplasia. Cochlear hypoplasia, a term denotes that the cochlea is smaller in size or less than 2.5 turns. In this type of the cochlea, in this case, we found that the basal turn of the cochlea is completely normal, while here in the apical and the middle turns of the cochlea, they are hypoplastic, especially we compared it with this normal reference image. Mondini deformity was the most common encountered deformity. It includes the incomplete partition deformity too. We can see here there is an cystic appearance of the cochlea in the CT. Cystic appearance of the cochlea due to the absence of the apical modulus and the apical interscalar septi. Confirmed here in the MRI, we can find there is a cystic appearance of the cochlea. Sometimes we call it a cap sign, and also associated with enlarged vestibular aqueduct. We can consider it enlarged when it is exceed 1.5 millimeters. Here it is enlarged, and in the MRI it's reflected by enlargement of the endolymphatic duct and sac. Also in this anomaly we can find that the vestibule is a bit dilated. In these cases, the spiral ganglion cells are present in the basal part of the modulus. So good stimulation with all kinds of electrodes can be achieved when we place the electrode in the normal basal turn. Regarding the internal auditory canal abnormalities, we can found it is maybe stenotic or completely atretic, and here in our case, we found that the internal auditory canal in the right side is completely absent and completely atretic when we compared it to the left normal one. Cochlear foramen stenosis. This case, we found here on the left side there is a marked stenosis of the cochlear foramen. We diagnosed it stenotic when we found it less than 1.8 millimeter, and it is well reflected by abnormalities in the cochlear nerve. Also, some cases of the semicircular canal vestibular abnormalities include here in our case, we found that there is a bilaterally dysplastic vestibule and the lateral semicircular canals, especially when we compared it with this normal reference image of the normal appearance of the vestibule and lateral semicircular canal bilateral. Also, the semicircular canals abnormalities can be detected in the Char syndrome, in which there is an absence of all semicircular canals. We can see here in the CT there is an absence or complete absence of the all semicircular canals, and they confirmed here in the MRI images bilaterally. Also, in this patient, there is one of the pathognomonic features of the Char syndrome, in which there is an abnormal contour of the posterior globe bilaterally with the presence of the retrobulbar cyst here. This is in keeping with bilateral colobomas. This is another abnormality of the lateral semicircular canal called the lateral semicircular canal dysplasia or globular deformity, in which we found here that the vestibule and the lateral semicircular canal are abnormal and forming a single common cavity, especially when we compared it with a normal reference image here. This abnormality should be diagnosed in the absence of the other inner ear abnormalities. Don't forget to give a comment on the round window, which is an important landmark for the surgical procedure, and also it is intimately related to the sinus tympani here. Also give a comment on the oval window and the facial bony canal to detect any abnormalities or concomitant abnormalities. Regarding the vestibulocochlear nerve, it may be completely aplastic or dysplastic. Dysplastic vestibulocochlear nerve, it includes either it is undivided vestibulocochlear nerve or absent cochlear branch or a hypoplastic cochlear branch. Here in our first case, we found that the internal auditory canal found only one nerve here, and it was confirmed in the oblique sagittal image. This nerve was the facial nerve with complete absence of the vestibulocochlear nerve, denoting cochleovestibular nerve aplasia. But in this case, we found there is two nerves in the internal auditory canal in the oblique sagittal image. The anterior nerve here is the facial, and this big nerve is undivided vestibulocochlear nerve. Normally, in this normal reference image here in the upper part, we found that the vestibulocochlear nerve should be divided into superior and inferior vestibular, and the cochlear nerve anterior that not occur here, so it is undivided vestibulocochlear nerve. And in the literature, they say that the cochlear implantation is technically maybe possible in these patients because of the presence of both the cochlear and the vestibular fibers, but it will be with disappointing outcome. This interesting case of 8-year-old boy presented, we found here in the coronal images of the CT a bony septum within the right internal auditory canal. This partition or internal auditory canal reflected in the MRI by a stenotic internal auditory canal, and when we do the oblique sagittal images, there was only two nerves present within the internal auditory canal. Again, it is only the facial nerve and the undivided vestibulocochlear nerve. Unfortunately, in this boy, the left side also showed an absent cochlear branch of the cochlear nerve. Regarding the acquired causes of sensory hearing loss, it may be inflammatory, tumorous, or traumatic. One of the most common is the labyrinthitis ossificans, and it is usually preceded by bacterial meningitis in the child. Here we can find a normal appearance of the cochlea at the right side, while in the left side there is an abnormal density within the cochlea. We can look here. We found that the apical turn of the cochlea showed at the position of the bony density, and it reflected in the MRI by the presence of the signal loss in our drive sequence T2 high resolution. Also here in the basal turn of the cochlea, the same finding, and also reflected by the signal loss. So this patient was in keeping with the left labyrinthitis ossificans. It is important when reporting a case of labyrinthitis ossificans to give a precise location for the ossifications, because once the obliteration exceeds the second half of the basal turn of the cochlea, surgical access to the scala tympani will be precluded, and the implantation of the double array may be considered. And if it limited to the scala tympani, a full insertion of implant into the scala vestibuli will be done. So it is influence the surgical approach. Also, we can comment on the anatomical variations. For sake of the mastectomy, we should comment if the mastoid ear cells is hyperpneumatized as here, or hypopneumatized and sclerotic as here, which is usually associated, may be associated with a low-lying dura, so we should comment on it. Also, the presence of a large mastoid ear cells inferior to the round window with a niche that may be confused with a round window niche and should be reported to the surgeon. A lot of vascular variants we can see in the inner ear, including arterial or venous variants. One of the arterial variants is the transinternal carotid artery. We can see here that the horizontal part of the internal carotid artery exceeds the second half of the basal turn of the cochlea. Here in this case, many studies found that we should comment on the cochlear carotid distance here. The less the distance, the more the incidence of the complication. Also, we should comment if there is an apparent internal carotid artery in which there is a segmental agenesis of the cervical part of the internal carotid artery and associated with the enlargement of the collateral to compensate for this absence. And this collateral is usually presented as a vascular structure at the cochlear promontory. Also, regarding the venous abnormalities, we should comment on the jugular bulb, high jugular bulb, when it extend above the floor of the internal auditory canal, or if it dehiscence the jugular bulb with absence of the cortical covering. You should also comment if there is an anteriorly located sigmoid sinus to avoid the profuse bleeding and cerebral hemorrhage during the operation. And finally, regarding to the emerging techniques in the assessment of the cochlear implantation candidates, many studies found that the preoperative DTI images can detect the microstructure abnormalities that not detected by the conventional MRI, and so we can predict the outcome of the cochlear implant. They depend that any abnormality in the myelin sheath or the white matter fibers will be reflected as a change in the fractional anisotropy through change the direction of the white matter diffusion. So they put a row and areas of interest along the auditory pathway, like here in the trapezoid body or the inferior caniculus or the auditory radiations or the Heschel's gyrus. Any decrease in the fractional anisotropy along this auditory pathway in the patient with sensory hearing loss will reflect an underlying poor myelination and will be associated with a poor outcome as measured by the categories of the auditory performance post-operatively. Thank you.
Thank you, Dr. Aya, very much for such eloquent talk, and especially you covered it all, even the DTI and all the new stuff. And actually, I did some of this work with an eminent professor in my university, Dr. Badruddin Mustafa, and he will not say that the child is not candidate for cochlear implant, but they will discuss the issues with his parents, and also it helps in the choice of the ear where the implant is done, because usually they prefer to do it on the right side, but when we found that there is DTI and function abnormality on the right side, so he will go to the left side. So thank you very much. Moving on to also one of my dear students and rising star in our neuroradiology. When actually we have a neuroradiology group in Ain Shams. Whenever anybody puts a case, Dr. Manar is always present and always gets the right answer. So she's our rising star, and I like her reports very much, and she will talk to us about the added value of DWI and T2 to the ECR NIRADS criteria. Dr. Manar.
Okay. Good afternoon. All data included in this presentation was published in the American Journal of Neuroradiology. You can review it later. First, NIRADS is the neck imaging reporting and data system. It was originally developed by the American College of Radiology. It was developed for contrast-enhanced CT imaging with or without PET for post-treatment imaging surveillance for cases of head and neck squamous cell carcinoma. Later, it was adapted to MRI. Very recently, just on last November, a new MRI lexicon was released. This paper and work was done before the release of the new lexicon. We noticed in our daily practice that we depend a lot on diffusion features and T2 signal intensity at the primary tumor site when we report. So we decided to study their added value to the ACR NIRADS algorithm that depend mainly on enhancement features. We did so through a retrospective study that included 69 patients with head and neck squamous cell carcinoma who underwent contrast-enhancing MRI imaging surveillance in Ain Shams University hospitals. All scans were done on 1.5 Tesla machine. We did so through image analysis using two reporting templates. The first template confined to the ACR NIRADS criteria for contrast-enhanced CT that depends on the enhancement features. Then we did another reporting using another template that evaluates the T2 signal intensity and diffusion features at the primary tumor site. Then we applied our proposed criteria using T2 and diffusion features as a modifying rules to the original ACR NIRADS, and we did NIRADS rescoring. Our gold standard was a set of criteria including clinical and imaging follow-up with or without pathological assessment. We used a scale manner for assessment of T2 signal intensity and diffusion features. 4-point scale was used for T2 signal intensity. 1, iso-intense signal intensity to the normally appearing surrounding tissues, because we had a few cases that you can hardly notice any post-operative or post-treatment changes, as in this case, where there were a right-sided nasopharyngeal carcinoma and nearly it's normal. 2, for very dark T2 signal intensity that usually represent fibrotic tissue. It's much lower than the original tumor if you have a pre-treatment comparison scan, or you can compare it with muscle if you don't have a pre-treatment comparison scan, similar to this signal. The intermediate T2 signal intensity is the pathologic T2 signal intensity in our study. It is the signal similar to the initial tumor signal if you have a pre-treatment scan. It's known in the literature by the evil gray signal, which is the signal of the original tumors of squamous cell carcinoma. 4, high signal intensity in T2 weighted images approaching CSF and fluid signal, or much higher than the original tumor. It's usually represent edema and fluid collection. All these scales are benign finding except for intermediate to T2 signal intensity. 2-point scale used for diffusion assessment. First, diffusion restriction for low signal intensity in the EDC map, much low, similar to the original tumor signal, or you can compare it with the brainstem if you don't have a pre-treatment scan, with a high signal intensity in diffusion weighted images, corresponding to abnormal enhancement. We added the point of corresponding to abnormal enhancement to exclude post-operative infected seromas and abscesses from being categorized as pathologic lesions and NIRADS 3 category. The second point is facilitated diffusion for high signal intensity in the EDC map with high or low signal in diffusion, or much higher than the original tumor signal. We used T2 signal intensity and diffusion features as a modifying rules to the ACR NIRADS categories as follows. Presence of both diffusion restriction and intermediate T2 signal intensity would upgrade NIRADS category by 1 grade from category 1 to 2 and from 2 to 3. Conversely, absence of both would downgrade NIRAD's category by 1 grade from 3 to 2 and from 2 to 1. The presence of only one feature without the other wouldn't alter the original NIRAD's risk category. As in this case, you can notice a nodule of intermediate T2 signal intensity with high signal in diffusion-weighted images. The EDC map was low but not shown here. So this, by applying our criteria, if this case was categorized as NIRADS 2 in the enhancement features, we should categorize it as NIRADS 3. Conversely, this case represents NIRADS 3 lesion here, representing previous perineural spread of nasopharyngeal carcinoma because it's mass-like enhancing lesion. Yet, when we assess T2 image, you can notice that there is very low dark Z2 signal intensity, and there is no diffusion restriction in the operative bed. So we downgraded it as NIRADS 2 instead of NIRADS 3 because of its enhancement features. And it was confirmed to be post-radiotherapy fibrotic scarring by further follow-up. After applying our modifying rules and upgrading and downgrading lesions, 7 NIRADS category 3 were downgraded to category 2, 3 NIRADS 2 were upgraded to category 3, and 10 NIRADS 2 were downgraded to NIRADS 1. The rest of the cases showed concordant findings between the original ECR NIRADS and our modifying rules and proposed criteria. Such in this case, you can notice a nodule of intermediate T2 signal intensity that shows focal mass-like enhancement, and it shows an area of diffusion restriction with low signal intensity in the EDC map. And this was proved to be squamous cell carcinoma by histopathology. On the other side, you can notice a low signal intensity in the rest of the surgical bed in T2 weighted images that show sheet-like enhancement that's categorized by NIRADS criteria to be NIRADS 2, and it shows facilitated diffusion in the EDC map. Most of our cases represent oral cavity and oropharyngeal cancers, followed by the nasopharynx. Leukoregional tumor recurrence occurred in 26 out of 69 of our patients. We had a number of interesting results regarding diffusion and EDC map. First, there was no statistically significant difference between qualitative and quantitative assessment of diffusion-weighted images in our study. 24 cases out of 28 cases showed diffusion restriction in our study. 24 out of these cases proved to be leukoregional tumor recurrence, and only 4 cases were post-treatment changes and showed diffusion restriction. 41 cases showed facilitated diffusion. Only 2 of them were proven to be leukoregional tumor recurrence, and the rest were post-treatment changes. One of those cases was proved to be post-operative inflammatory process, and the other case was the residual tumor couldn't be detected by all sequences and by all other sequences, so it was like microscopic residual. Results of T2 signal intensity. The intermediate T2 signal intensity, which is the pathologic T2 signal intensity, was shown in 29 cases, only 5 of them proven to be negative, and the rest were all proven to be leukoregional tumor recurrence. So post-operative scarring, especially in the initial phase, could have intermediate T2 signal intensity in few cases, so follow-up is essential. This table shows the diagnostic performance of T2 signal intensity, diffusion features on their own, and the diagnostic performance of the ACR NIRADS that was developed for contrast-enhanced CT, and the diagnostic performance of our proposed NIRADS criteria using diffusion and T2 signal intensity as a modifying factors. Here you can notice that the highest specificity goes to our proposed criteria, combining NIRADS with diffusion and T2 signal intensity. Yet diffusion showed a very comparable result compared to NIRADS with modifying features, but we preferred to use T2 signal intensity and diffusion-weighted images because they had a higher specificity when combining both of them. Limitation of the study: it was a single center and a retrospective study that should be applied in a larger scale and prospective study in the future. Conclusion: incorporation of diffusion features and T2 signal intensity to the current NIRADS criteria for primary tumor site assessment as a modifying rules enhances the diagnostic validity and accuracy of the ACR NIRADS template. Thank you.
Thank you, Manar, very, very much. And it's an honor that this was published in AJNR, which is the most prestigious. Now, I have one advice for you, if I may, as your professor and professor of your tutor, Dr. Tugan. You have 69 cases, right? If you reach 100 cases, please let me in the game, and we'll send them for artificial intelligence post-processing so that you can have this parameter as well, because this is typical. You have T1, post-contrast, you have diffusion, and have T2. You only need to add more 30 cases, and then we will do AI, okay? Now, moving to Dr. Dua Khedr from Mansoura University. And Mansoura University is actually, they are pioneers and leaders, and whenever I say Mansoura University, I have to remember my dear beloved colleague, may peace be upon his soul, Professor Dr. Ahmed Abdelrazik, who was actually pioneering in many aspects, including AI and everything. And I know that you all were his students and benefit from him in neuroradiology and in head and neck. So, Dr. Dua will talk to us about imaging of invasive fungal sinusitis in the era of COVID-19 infection. And I can see that only a minority of us now are wearing masks, so maybe you will give us some good news. Okay.
Thank you, Dr. Yasser, for kind invitation. Thank you, dear colleague, for a fruitful lecture. Our topic today is about imaging of invasive fungal sinusitis in the era of COVID infection. I will answer some question about invasive fungal sinusitis. What is the invasive fungal sinusitis? Invasive fungal sinusitis is rapidly progressive transmucosal angioinvasive infection, which is rare. The main pathology is aggressive necrosis and infarction. It carries high morbidity and mortality. The definite treatment is radical debridement. What is the imaging feature about invasive fungal sinusitis? This is the imaging feature including early imaging of unilateral proptosis and abnormal signal intensity along the superior ophthalmic vein. If we see in the second lecture in the right, there is minute erosion of the sinus wall. This example of case of well-established invasive fungal sinusitis with intensive osteonecrosis or osteomyelitis with subperiosteal abscess of right orbit, alveolar osteonecrosis, post-operative imaging, still ongoing osteonecrosis and subperiosteal abscess, and this is the microscopic picture of the case revealing the fungal hyphae. Another case of established pathologically proved invasive fungal sinusitis. I would like to you all to see the diffusion restriction of the mucosoperiosteal or mucoperiosteum thickening, which is surrounding the necrotic tissue. For young doctor, what is the other most common finding of fungal sinusitis we know? We know there is allergic fungal sinusitis, where it's most common, and it's show high density content on CT. The MRI of the allergic fungal sinusitis may be misleading, so this is the most common type. Other cause is focal type is sinus mystoma, which is diagnosed also with CT. The MRI loss of signal intensity, susceptibility weighted imaging may be useful in both cases. So there is difference between chronic sinusitis and acute invasive fungal sinusitis. In acute invasive fungal sinusitis, don't look for a fungal ball. The major differential diagnosis is complicated rhinosinusitis. In the early imaging features of acute complicated sinusitis maybe cannot differentiate between both, but acute complicated rhinosinusitis is not associated with bone erosion. Why we are talking about invasive fungal sinusitis and why there is correlation with COVID. In the second wave of COVID, there is increased rate of invasive fungal sinusitis globally, maybe related to a treatment regimen or corticosteroid use. In cases hospitalized, the major risk factor is diabetes mellitus. And why we should all know about invasive fungal sinusitis. Example of high morbidity and mortality of the case, a 45-year male underwent exenteration and aggressive treatment of paranasal sinus, represented by right hemiparesis. After 6 hours, well-established acute left MCA infarction. Another case in ICU, represented with facial swelling. 1 day after admission, there is increase in cheek thickening and preseptal edema. There is suspicious guitar beak sign, which is indicated for acute visual damage on the right side. After in another imaging, there is haziness and stranding of the right retroorbital fat, indicating ongoing cellulitis. After 5 days, there is panophthalmitis and bilateral cheek abscesses and ongoing infection of the brain. Unfortunately, those two cases passed away. These are our publication about COVID-associated viral invasive fungal sinusitis. We demonstrated that the orbital symptom is the most common symptom, and the diabetes mellitus is the most risk factor for our cases. Despite the aggressive medical treatment, the ongoing infection leading to 30% of mortality. When to suspect a case of invasive fungal sinusitis? We must have a pure clinical history of the case and know about early sign of diagnosis of invasive fungal sinusitis. The early sign of invasive fungal sinusitis include our first case of abnormal signal intensity and urinational polyptosis, black turbinate sign, and perimaxillary fat infiltration. There is example of perimaxillary fat infiltration. The fat better be evaluated in T2 spare imaging and post-contrast T1 fat suppression. There is example of necrosis of the right middle and the inferior turbinates with loss of enhancement on post-contrast fat suppression. This is black turbinate sign. How we image a case of invasive fungal sinusitis and how we report a case of invasive fungal sinusitis. Imaging, all literature, paranasal sinus, pre and post-contrast CT, and pre and post-contrast MRI. But in our hospital, we have a specific protocol for isolation cases. Contrast enhanced CT with soft and bone window, and even non-contrast CT is enough for the raise susceptibility of acute invasive fungal sinusitis. If the patient is in ENT ward, we can use non-contrast CT bone window for bone erosion and pre and post-contrast MRI for detection of the necrosis and soft tissue extension with specific brain imaging. We must have, for all young doctors, we must have structural report data for reporting a case of invasive fungal sinusitis. Our protocol is take your breath. Mainly in all cases of head and neck, young doctor rush for diagnosis, and we don't rush for diagnosis. We need to take a breath before writing any report for a head and neck case. We must have full history, clinical history, and the previous imaging of the data, especially if the case is a post-operative. We must comment on the several items separately by positive and negative, including sinus and nasal cavity, orbit, osteonecrosis, soft tissue, vascular, and intracranial. What is important for the surgeon is what is yellow, but because he is seeing the sinuses and he will perform surgery for sure, but he wants to know what beyond the sinus affection. Let's see, have a constructed report for a case example like this. We have a case of post-COVID infection with left apical fungal ball. Regarding the sinus inflammation, there is right maxillary and bilateral ethmoiditis. Regarding the osteonecrosis, there is ongoing emphysema in the left hard palate, and the post-contrast MRI reveal a mucoperiosteal or periosteal thickening around greater wing of sphenoid. This is osteonecrosis. About the orbital affections, there is preseptal and post-septal inflammation. About the soft tissue, there is cheek, buccal, masticator, and lip thickening, and left temporalis muscle enhancement. About the brain and vascular, there is suspicious left cavernous sinus thrombosis and meningeal enhancement. In conclusion, it's absolute necessary for all radiologists to be aware of imaging feature of acute invasive fungal sinusitis. Since 2020, invasive fungal sinusitis, so common, has been identified in COVID patient. ROCM causing a fulminant clinical course, ongoing process, need to prompt and aggressive treatment, and image play a key role in early identification and delineate extent of the disease. Recommended paper for further reading. I would like to thank my team in Mansoura University Hospital in Head and Neck Unit and the ENT and Pathology. And thank you. And
thank you, Dr. Daaf, very much. I see you became an expert in the invasive fungal sinusitis in this era, and it's really devastating disease, but it's good that you teach us how to recognize it and try to help these poor patients. Thank you very much.
عشان ما تضايقنيش، ما اعرفش تعتمد على ايه؟ ماشيه معاك القصص دي ولا عايز واحده بواير؟ ماشيه شغاله. طيب وبعدين هنا انا بقدر اقلب السلايد بينها بقى كده واشاور بيها هي نفسها، صح؟ اوكي شكرا. Well, I'm glad we reached this point. We are 45 minutes late than what's in the schedule. So I'm going to give my cases until I find you are bored and leave the room, so I know I'll have to stop. I have arranged them like in order of complexity so that we can go with them. I want to thank these young doctors, really bright, working with me all the time. May, Maha, Basant, Khadija, Aya, and last but not least, Muhammad Zakaria, who I think is here, and Ahmed Zobi. They helped in this presentation. Now the first case, 20 years old male with headache and low back ache who underwent a multi-parametric MRI together with MR of lumbosacral spine before and after contrast simultaneously. And so as we can see, there is a right cerebellopontine lesion with diffusion restriction, low EDC, and intermediate signal on flare and adjacent edema.
T2 shows low signal confirming high cell packing, and then T1 low signal and T1 post contrast moderate, somewhat heterogeneous enhancement. And so in a 20 years old male in this location, I don't want to make it as a quiz in the sake of time, so I'm just going to go for it. We thought that it is a medulloblastoma. And the MR spectroscopy is really has what you can call a fingerprint in this case, because you have this remarkable elevation of choline, while some people use the word dwarfism of the other metabolites. They are really very small peaks in comparison to the very high choline, and also there is some taurine peak at the 3.6 ppm, which was also detected in this case. So going with medulloblastoma by this criteria. The perfusion of the lesion, it was mildly hyperperfused by this T2 star perfusion, but look at the elevation in percent signal recovery. And I think a lot of you know that we noticed this in primary CNS lymphoma, but in my cases of medulloblastoma, I also noted this. However, the lesion is usually mildly hyperperfused, unlike with lymphoma, and it also has this. And the explanation could be that it causes somewhat more retaining of contrast media than normal brain tissue. Now, for the lumbosacral spine, there were drop metastases of similar signal pattern, low on T2, and this is the pre-contrast T1, and intensely enhancing on the post-contrast. So this was the explanation of the combination of the headache and the low back ache in this particular patient. And this is a summary of the findings which I just said in spectroscopy perfusion. And collectively, this would go with a desmoplastic type of medulloblastoma. Mind you, the age of the patient, I said at the beginning that he's 20 years of age, and also the location of the lesion. PET-CT was subsequently performed and confirmed the high metabolic activity of all the lesions we talked about, and also of some of the cervical lymph nodes in this case. Also, there was the PET detected another deposit within the upper aspect of the dorsal spinal canal. Okay. And sorry about this. Is the pathology report in this case, medulloblastoma, WHO grade 4. Now to have a little bit of learning information, this is your differential for drop metastasis, GPM, medulloblastomas, of course, like in this case, embryonal tumor with rosettes, which was formerly known as peanut, ependymoma, germinoma, choroid plexus carcinoma, and most pineal body tumors. Another learning point is that this is the like a recent classification, not that much recent, but it is the most common use classification for medulloblastomas, dividing them into WNT, SHH, group 3 and group 4. I'm not going to go through it, just for your knowledge, and the least common is WNT, and the most common is group 4, and the locations and the ages and so forth. The importance is that now these have different drug regimens for oncological treatments. So it's important for you as a neuroradiologist to try to make such a distinction. Also, we heard nice talk about AI. AI people are doing also a lot in this regard, trying not only to say that it's medulloblastoma or ependymoma, but even to go into this subgrouping. This is an example of the WNT in an 80 years old, where the mass is more localized to the right CP angle and has intense heterogeneous enhancement. While the SHH, it is more lateral and posterior and has fainter contrast enhancement. So this is some way of differentiating them. Busy slide, and we don't have time, but basically it talks about medulloblastoma metastases and their incidence and where to look for them. And here is a case from the literature showing you that you have not only to look for the medulloblastoma, but for the metastasis along the spinal canal. And even in this poor child, he had a mandibular region tumor or metastasis. Now moving to the second case, 39 years old male with right hemiparesis, and we can see by diffusion a moderate sized lesion, left deep parietal, mainly thalamic, with some tendency towards diffusion restriction and high signal on flare, low on T2, so can be going with the somewhat diffusion restriction, T1 intermediate, SWI, maybe few small foci blooming susceptibility effect. I don't know, faintly enhancing, and the spectroscopy was, it was somewhat equivocal between calling it a tumor and calling it something else. And this was a really puzzling case because it's unilateral. But there is something I didn't like about it to call it just a left thalamic tumor, okay? And when we did the perfusion, I found that it is hypoperfused. It's not, I would have expected with the enhancement and the diffusion that it would be more hyperperfused. Something else, if you notice here, but maybe the numbers are small, there was some delay in mean transient time and time to peak compared to the contralateral normal. So I began to think, why not an infarct? But left thalamic unilateral lesion, can it be an infarct? Can it be a venous infarct? So I looked in the literature, and actually, let me just go. In the higher cuts, there were some degree of subarachnoid hemorrhage and high signal on flare. So the differential low-grade glioma, unilateral venous infarct, okay? We ordered MRV, and the MRV basically shows that the patient has a congenital anomaly where there is only unilateral deep veins, okay? And when the unilateral deep veins are hit, then you find this pathology, which is a big mimicker of low-grade glioma. So actually, the MRV data at the end showed that there is deep venous thrombosis of the internal cerebral vein, vein of Galen, and vein of Resonsal, and with the patient having unilateral venous structure. So that was a case of deep venous thrombosis that can affect only one side. So it's a rare case, but it was difficult, and we went through and forth with the clinician. And so remember that not all the cases that have unilateral thalamic lesion is glioma or infection. Also think that it can be a venous infarct presenting unilaterally, not like the traditional way we all know of the bilateral thalamic involvement. And this was reported in the literature to occur in about 11% of cases, such variants. And this is a similar companion case from the literature also as well of unilateral venous, deep venous system infarct, and this is the corresponding MR venogram. And in this case, they were discussing that they considered other possibilities like ADEM and viral encephalitis, and even did a lumbar puncture before they arrived at the diagnosis of such unilateral venous infarct. The third case is that of a 12-year-old male with right-sided hemiparesis, and of course all of us can see an obvious lesion on T2 and on flare left parieto-occipital with edema, T1, post-contrast. I think the clue is in the post-contrast. Maybe this one I'll just let you shout off if you know what it is. Yeah. Exactly. It's a demyelinating lesion because of such incomplete pattern of enhancement, horseshoe, and always you find that the part that is not enhancing towards the cortex, whether like in this case. So of course, I'm sure those of you who work in neuroradiology met these cases that are usually, I don't know why, diagnosed as glioma, and then come to us and we are the savers, you know. So people look at them, say it's a glioma, we tell them no, it's not a glioma. And also mind you, the mass effect is not that big. The diffusion data also shows that incomplete pattern. And here is the ADC color map of diffusion. Here is the SWI, no blooming of pathological vessels. The spectroscopy showed increased in myoinositol, lipid, and lactate besides the choline. The spectroscopy in this case is somewhat equivocal. That's the value of doing multi-parametric thing, because with the multi-parametric, everything helps you one way or the other. So don't rely on one technique alone. Perfusion-wise, the lesion, as you can see in the teeth star perfusion, is hypoperfused, unlike any glioma. And these are the findings. And the patient, even to make a definitive diagnosis, they went for biopsy and histopathology, and the histopathology came with Schilder's disease, which is one of the rare subtypes of MS, like Marburg, like Belo lesions, etc. Okay? So this was a case of Schilder's disease, a subtype of MS that you have to be aware of so as not to misdiagnose it as a brain tumor. The fourth case is of 75 years old female who has this obvious dural-based lesion, extraaxial, right deep parafalcine parietal with surrounding edema, and in subsequent images like the T2, you notice that it has a solid and cystic components and with a surrounding edema. Now, this is the T1 diffusion, restricted diffusion of the solid part, facilitated diffusion of the cystic part, enhancement, intense enhancement of the solid part, and the cystic part is towards the brain and has rim enhancement but with smooth inner margin of enhancement. Okay, so in a 70 years old female, this pattern, some calcifications by SWI, the spectroscopy showed increase in choline but remarkable increase in lipid and lactate, and there was an increase in alanine as well. Okay, so this was a case of meningioma, but not the traditional meningioma. There is a subgroup of meningiomas which are called the cystic meningiomas, okay? And these cystic meningiomas always are somewhat difficult because they have two main differentials. First of all, usually occur in females And I don't know it's my luck or what. I usually get them with females who have breast cancer. So always the issue, I am dealing with a cystic meningioma or with a pachymeningeal metastatic deposit from the breast cancer. And the other differential is a hemangiopericytoma, okay? So you have these three players in the field, and you want to make up your mind which of which. Perfusion-wise, it was remarkably hyperperfused with reduced percent signal recovery on the washout curve, unlike lymphomas. And this is a summary of the data. So it's cystic meningioma, Nauta classification type 4 or 5, and this is the Nauta classification. You have 5 types. You can find this, of course, in the literature, but the most common is type 4, and the classification is regarding where the cystic part exactly is located in relation to the solid part. And as I said, hemangiopericytoma or cystic schwannoma, not our case here because the lesion is away from the nerve courses. What about the pachymeningeal metastatic deposit, especially from breast cancer? No cancer was found in this patient. Of course, multiplicity of lesions can help you. The degree of edema. Some people have used the reduction in percent signal recovery, as they said that with metastasis, the reduction in percent signal recovery on perfusion is lesser than that of meningioma. Spectroscopy, if you are clever enough to find alanine and second creatine peak with meningiomas, not with metastasis. So there is a lot to do, and at the end you try to make the best of your diagnosis. Now, this is a companion case actually with another. I'm going to tell it to you right away. It's another type of cystic meningioma occurring left frontally and with the septa and etc. And we did the spectroscopy, we did the perfusion, and maybe here is a chance to tell you that here the reduction in the percent signal recovery is so much markedly reduced percent signal recovery. This is more a sign of meningioma than other entities. And what I wanted to do with this case is now to differentiate it from hemangiopericytoma. Okay, we said why it is not deposit because of the perfusion pattern with lesser perfusion values and more reduction in percent signal recovery. Now, why not hemangiopericytoma? I wanted to say it by giving a representative case. This is actually a case from the literature, and they had a 30-year-old male. So first of all, it's kind of a different age group, okay, than with cystic meningiomas, usually in more elderly female, but not, I mean, everything has exceptions, okay? Notice that this has on CT a mixed solid and cystic behavior. In the literature, in this case report, and it was by Japanese group, they actually called it wrong. They actually called this case a cystic meningioma. Why? Because they saw this mild hyperestosis. And they reported to everyone in the world that even with small hyperestosis, this ended up to be a hemangiopericytoma. Okay? Here are the MR data. I just want you to look at the T1 pre-contrast. In hemangiopericytomas, the T1, there is a slightly high signal of the solid part, somewhat higher signal of the solid part with hemangiopericytomas. In the group, this case was hemangiopericytoma, but by all the methods of histopathology and staining and immunohistochemistry. This is the key slide. Now this, I will stop here because this is, I collected this from many articles in order to put this table for you. So with cystic meningiomas, usually low signal on T1, as I said, but with hemangiopericytoma, usually you have a high signal. By T2, meningiomas have low signal, and of course I'm talking about the solid component. Low signal compared to gray matter in T2, ISO to high to gray matter in hemangiopericytoma. Cystic component more heterogeneous, hyperostosis, of course more with meningiomas, but can be present in hemangiopericytoma, like this case report, okay? Dural tail, of course, more with meningiomas, but also can be present with hemangiopericytoma to a lesser extent. Flavoids, it's a more vascular lesion, has more flavoids by SWI. MRS, as I said, if you are clever enough, you can, sorry for the mistake, this is not my inositol, it's actually alanine. This is my mistake, alanine or second creatine peak would go more with a meningioma. Perfusion, both have remarkably increased perfusion. Recurrence and metastasis rare, but hemangiopericytomas have more recurrence. So I hope by these two cases you benefited a little bit about how to make this differentiation between cystic meningioma, which is a subtype of the big meningiomas, and between pachymeningeal metastatic deposit and between hemangiopericytoma. The next case is actually, I wanted to put this case at the end, but since we are talking about meningiomas, I thought to put it here. Now, in the last meeting in Mesa Hotel, I had a big lecture completely about PET MRI in neurological applications, because we have been working with my group for 3 years now with PET MRI, and I have a nice collection. We are mainly doing brain tumors, epilepsy cases, and dementia. This was a recent case, and it was actually a very interesting case, because we used this tracer with us in the PET MRI for the first time. So this was a 37-year-old female with breast cancer who presented with left-sided hearing impairment, and the oncologist, and he is one of our best top oncologists at Ain Shams University, he wanted the most accurate characterization of this cerebellopontine lesion. Is it a pachymeningeal metastatic deposit? Is it a schwannoma, or is it a meningioma? Because he said, look, it's crucial to me that I know the definite diagnosis. Everyone has a different strategy for my therapy for this patient with breast cancer, and she's a young patient. Okay? So, conventional wise, you have a T1, post-contrast, axial T2, axial flare, and actually, when I looked at it, I said, okay, to me it looks like a meningioma, you know, like people say, it looks like a duck, it walks like a duck. I think it's a meningioma. And he said, no, I want the best thing that you can offer. So, and diffusion data, again, it is restricted diffusion. It even has a small dural tail on the sagittal view. Okay, ADC confirms the restricted diffusion. Perfusion study. It is hyper-perfused using arterial spin labeling. This is actually arterial spin labeling, but it's a color map. Okay, remarkable hyper-perfusion like we would expect. Also, this is an ACL color map of RCPF map of ASL. RCPV also hyper-perfused, and then the reduction in percent signal recovery. So what else? What can I do to Dr. Sabri Al-Adi, our oncologist? Due to start perfusion as well. And then he told me, can't you do something with PET MRI? I told him, okay. I know that gallium dotatate, which is one of the more expensive tracers, It's more expensive than FDG for those of you who work in the PET arena. And I told him, okay, meningioma, unlike metastatic deposit, is known to have a high affinity and high uptake of gallium dotatate. Same like, I don't know who of you attended Dr. Rasha Salah lecture in the morning, and she showed a nice case of pancreatic tumor, neuroendocrinal tumors. So neuroendocrinal tumors are also known to have high affinity to dotatate. Same with meningiomas and few other tumors like pheochromocytomas and like this. Okay, so I said, okay, I can offer the gallium dotatate. He said, go for it. All right. So after we did all this and we did the spectroscopy, not that conclusive. Okay, and this is the gallium dotatate. This was like it was the first time I can see a meningioma by dotatate, because actually not everyone does this expensive study for a meningioma. But look at the remarkable high uptake, or if I may say with the gallium stuff, the better terminology is expression. So there is a high gallium dotatate expression in this lesion. This will not happen with metastatic deposit, okay? Nor with hemangio, nor with the schwannoma, which were the main differentials. So this proved beyond any doubt that we are dealing with a classic left CPA meningioma. Now I think this is the most expensive meningioma that I ever encountered. Next case is 62 years female presenting with upper limb weakness and other neurological deficits, including sensory neural hearing loss. Additional history is withheld, I don't know why, and MR craniocervical region was done. Okay. So now on T1 and T2, I don't know if you noticed there is a subtle lesion here, which is actually kind of following the signal intensity of the cord or the gray matter of the brain on T1 and T2. So subtle lesion compromising the craniocervical region and the posterior aspect of the upper cervical canal. Okay. On STIR, also not well seen, but intensely enhancing on post-contrast T1 with fat suppression, and even some enhancing tissue posterior to the clival region. Okay. This is a really difficult lesion, a difficult case. So anybody would like to try it now? Maybe we arrived at it, but with effort, with some effort. Here you can see the intense enhancement and also some skull base enhancement as well noted with it. So what we are dealing with is diffuse nodular meningeal thickening involving the foramen magnum, craniocervical junction, mass effect upon the cervicomedullary region, causing compressive myelopathy, and also associated with soft tissue similar enhancement at the skull base, especially at the Meckel's caves bilaterally. Okay, so we considered some sort of diffuse meningeal disease. Pardon? Yeah, we considered sarcoidosis. Everything was on the table. Okay, and so, as you can see, sarcoidosis, lymphoma, metastasis. We went with the, with the common things, and then, lo and behold, we knew that the case started 8 years ago. So we said, and there is no primary malignancy. So what will go for all this time, and the patient only has this myelopathy, okay? We searched the literature and we found this entity, which is that of hypertrophic pachymeningitis, which is an inflammatory autoimmune disease. So as Dr. Rami said, if you don't remember anything from today, remember hypertrophic pachymeningitis. So that next time when you see such case, just put it in your mind and in your differential, okay? particularly not to misdiagnose it as metastatic disease. It's a rare disease, progressive inflammatory fibrosis, thickening of the dura, and the majority of cases have no identifiable cause, can occur intracranially or spinally, etc. Okay? And this was the histopathology for it. Because the clinician didn't believe it, and he insisted on doing biopsy and histopathology, and this what came for it. Okay, and as I say in the highlighted in red, it's more a diagnosis of exclusion. It's not the thing that will pop into your mind right away. You have to, you know, move around, and especially that the patient had no known primary. She didn't look like a cancer patient, etc. Okay. Next case. Are you bored with me yet, or should I continue? Go? Okay. 72 years old female with left hemiparesis, disturbed conscious level. So I did for her the works. And the works for those who work with me is a full multi-parametric MR study that includes everything that I can push. Here T1, T2, and flare, and you find white matter signal alterations and a kind of a lesion on the right side at the right corona radiata. Yani it's more going with facilitated diffusion, SWI, not that conclusive. And then we have enhancing parts in a multifocal manner, enhancing lesions on various parameters. Spectroscopy, you have somewhat increase in choline, lipid and lactate with reduced N-acetyl aspartate and creatine. And this is compared to the normal brain parenchyma, or the not normal but the affected white matter, which is not enhancing, I mean. Perfusion-wise, the lesion had more or less isoperfusion with parts of elevated percent signal recovery. Okay, this is a summary of the perfusion data. And so here is the differential. So I have shown you the multiparametric I do conventional MR pre and post contrast, diffusion with ADC, susceptibility, magnitude and phase, perfusion at least by one method, by two methods, because I also had arterial spill labeling but not shown here. Spectroscopy, single voxel, short and intermediate echo, multi-voxel long echo. And then here is your differential. Is it glioma? Is it metastatic? Is it primary CNS lymphoma? Okay? So on reviewing all the data, and before we go to all the data, the clinician was also asking simultaneously for PET-CT. Actually now I prefer, and this is maybe my own point of view, for such cases I prefer to do PET-MRI, because in one-stop shop we combine evaluating the brain lesion and evaluating the whole body. You don't need to put the patient into two scanners at two appointments at two different times. So in these cases with metastatic workup, when you have the brain lesion is your main concern and you want to rule out any outside malignancy, I prefer PET-MRI. And actually the cost is the same. The cost of a PET-MRI is like doing a multiparametric MR study plus PET-CT. Okay? This is just for your knowledge. So nothing outside or nothing extracranial. Okay? So my final diagnosis for this case was primary CNS lymphoma because of the following: age of the patient, her clinical data, the PET-CT is negative, the lesions are multifocal with solid components, cell packing with diffusion, no blooming susceptibility like we would expect with gliomas. And also what was nice and an additional finding in this particular case, because remember when I said about her clinical data, she was coming with this pattern of reduced conscious level and reduced mental status, and all this. Whenever I hear this history, I always think that there is an angiocenteric involvement, i.e. involvement of the vessels. And this, the most common cause for this in an elderly patient would be a lymphoma, followed by some distance by a glioma, okay? And this is how it looks, that you find this enhancement along the leptomeninges. This is the original lesion, and here is the leptomeningeal abnormal enhancement, which is causing this symptomatology, okay? And if I have just 1 minute, one of my favorite teachers, and I was honored to have her, to visit her in the States and meet her in conferences, and when she came here to Egypt, Professor Ann Osborne, so he's our like godmother of neuroradiology, and she said that she had an exact like case of angiocenteric lymphoma, where the whole hospital in her Salt Lake City, Utah, couldn't reach a diagnosis, whether the neurologists, the neurosurgeons, the internal medicine, and then all of them came as a big group to her reading room. I like this very much, you know, I like when all the clinicians come to us, and please, Dr. Osborne helps us with this case. And she said, I looked at the case for half a minute and I told them angiocenteric spread of lymphoma. And they were all like amazed with this. But she said, look, Yasser, but always know that you will not get the credit. Of course, when they went to the ward, they told the patient, we diagnosed your case, and they gave him the treatment and they got all the credit while you diagnosed the case. I tell that this is the story of life of the neuroradiologist, you know. He diagnoses and somebody else gets the credit, right? I don't know. So the 3 biggies, I got this slide from the literature just to show it. It's dark from me here, but the first one, as you can see, is elevation in percent signal recovery is with lymphoma. The remarkable reduction in percent, of course, we are talking about T2 star perfusion, RCPV curves and ratios. Remarkable reduction in the percent signal recovery with metastasis. Mild reduction in percent signal recovery is with glioma, the third one. And also mind you that lymphoma, maybe it's shown in this, is not as hyperperfused as the rest. And you can see it in the color map. So lymphoma is the least perfused of them, but is the highest elevation of percent signal recovery, more than the baseline of normal brain parenchyma. And this is the rare type lymphatoid granulomatosis, which is a subtype of lymphoma. And this is a case for it from the literature and has cross-correlation with immunocompromised patients. Next case, 60 years old male with previous history of posterior fossa hemorrhage. So this guy had an intracerebral hematoma in his posterior fossa, but sometime later he came with weakness and tremors. This is shown as a video, and on the right side you can see the hemorrhage. Maybe we'll go for the next one. Non-contrast T1 showing the hemorrhage. Okay, the next. This is the flare. Okay, so let me I want just to stop. Okay. Can you stop here? Let me go back to the flare and stop. No, it's not showing the image I want to show you. and stop at it. Okay. Here. Okay, I've stopped it. So what I wanted to show you is this zone of abnormal signal centered on the left pyramid of the medulla, okay, in a patient who had previous hemorrhage. And you can see that this is also causing a swelling, all right? So I gave you all the clues I have. So exactly, HOD, hypertrophic olivary degeneration, which is like a rare form of degeneration which causes swelling, not atrophy. And usually follows, the most common cause is previous hemorrhage, but I have seen it in one of my cases also with medulloblastoma after treatment, not initially, but from the effect of treatment, okay? So this is a case of HOD, all right? And here is a companion case from the literature of another person who had previous hemorrhage and presented, and usually the presentation for the neurologist is characteristic because it has to do with this, and I'm sorry, I come from an English background, so pardon me for the French pronunciation, Guillain-Mollard triangle, you know. It's this triangle of these nuclei at the posterior fossa, which are interconnected, and so when there is hemorrhage and the cerebellum, they are affected and get you this contralateral hypertrophic olivary degeneration. And usually, and we do, when I told this to the clinician that I think of this, so at the beginning he did know, and that he said, okay, a characteristic clinical finding is palatal myoclonus, okay? I don't know what's palatal myoclonus, so don't ask me, but I just got it from him and put it in the slide. So usually this is the referring thing. We are approaching the end. This is 30 years old female. Also, this runs as a video. You find a lot of parts that are of extremely low signal on T2 weighted images in various parts, especially cortically and subcortically, that have an aneurysmal-like pattern. Okay, so I'm telling you now all the findings. Aneurysmal-like pattern in 30 years old female in different locations. So this was also a difficult case. The obvious thing we can say, hemorrhagic venous infarcts, whatever, something like this. But actually this was so interesting, because also one can review something or think of something. We said, why it cannot be, you want me to tell you right away, surprise, embolic from right atrial myxoma. Okay? So when we thought of it, I called my dear colleague and friend and partner and everything and student, Dr. Ahmed Samir, our famous cardiac person, and we did cardiac MRI, okay? And with the cardiac MRI, we found an atrial myxoma. Atrial myxoma usually has to be differentiated from thrombus because it is usually fleshy and soft, and it is of low signal and usually sticks to the intra-arterial septum. I think we should let the video run, because now it will give you some better images for viewing it, hopefully. Okay, here. So within the right atrium, still waiting for the best images to come up, to pop up. This cine cardiac. Okay. Anyway, for left atrial myxomas, they can send emboli intracranially, and when they reach the brain, they are usually lodged in these places and cause these aneurysmal dilatations, and the best sequence you can think of is SWI for such diagnosis. And as I said, left atrial myxomas are soft in consistency, mobile, usually connected to the intraatrial septum. This is for you who do cardiac MRI. This was really a fascinating case because it was a big shot to put this diagnosis and then prove to be in the right track. Okay, 10 years old with paraparesis and urine incontinence. I want to tell the story of this child really quickly, and I wanted to make it more appealing, but actually now it is even much more appealing because the treating clinician called me yesterday, believe it or not, about this particular child. This is the newest case I had. So you can see a conus medullaris lesion, okay, of heterogeneous high signal on T2, isointensity T1, better seen on T2 with fat suppression. Now, mind you, on the T2 fat set, first of all, this child was referred to me with another report that it is an ependymoma, okay, for a multi-parametric study. The first thing I noted that the T2 pattern, it has a somewhat granular nodular texture, okay, and became more evident to me on T1 post-contrast, and it is more confined to the anterior aspect, all right? So exactly, bilharziosis. You know how I even, you are even more clever than me. Why? Because the patient's name was at the end Bou Bakr, and I said this is not an Egyptian name. I called him, and then his Sudanese mother answered me. They are from Sudan. I didn't know that, okay? But I told her, does your child play in the Nile? She said, we are living in an island. He is always playing in the river, and we have rain like 9 months a year, okay? So the good news, and this is, please remember this granular arborized pattern of a bilharzioma. All right? The tropical medicine doctor called me yesterday. He said, I gave him antibilharzia drug. I don't know anything about drug, but it's something praziquantel, exactly. I only know gadolinium and urographene. That's my, this is the drugs I know, okay? And he said, this patient came with urinary retention and lower limb paresis. He said the child now is playing and his mother and father are dancing from joy. Okay? So instead of an ependymoma, we went to something treatable. So the key factor here was the such granular nodular pattern of enhancement. And I remembered of course, the spectroscopy was not that of a tumor. All metabolites are reduced, only you have lipid and lactate. Tractography-wise, there is no infiltration or interruption of the fibers. Perfusion, the lesion is hypoperfused. And this is the summary of the data. Endemic region from Sudan. And this is a review that neuroschistosomiasis can be cerebral or spinal, cerebral schistosomiasis japonicum and spinal mansoni. Of course, we studied all this long time ago, but I don't know. I insisted on bringing this slide. Who of you here is from Cairo University? Who is remaining from Cairo University here? Anybody from Cairo University? Okay. You know, my dear friend and colleague and your professor, Dr. Sahar Selim, Dr. Sahar Selim actually published an article in AJNR like maybe 15, 16, 20 years ago, and you can see from the quality of the images. But she was actually maybe the first person in the world to report about conus bilharzioma. So we have to give her credit for this. Okay, and if you dig in the literature or Google, you will always find her article. There were so many publications after that, but she pioneered in this. This is another publication, but it's from the people of tropical medicine, okay, about the same entity. This is much more recent, of course. Right, okay. This is the last case, and I left like the most innovative, the most new, the most appealing case for the last. It's how we use all the high-end techniques in difficult entity of the cognitive impairment people, okay? We have a 50 years old female, so she's reasonably young, coming with behavioral disorder, bilateral pyramidal tract affection, dysarthria, gradual and progressive. And we have a very clever young neurologist, young professor. I like such young professors, Dr. Heba Rashid. She is like subspecialized in these neurodegenerative diseases. She sent me this case with the history and said, please do whatever you can to help us. I start with the conventional MR, where you can find in this 50 years old, there is somewhat premature for age brain atrophy, but it's more frontotemporal, slightly more on the left side, okay? So this is the first clue. And proven on the coronal views. Then we went for perfusion. Of course, we do all these studies without any contrast, so we go for arterial spin labeling. I don't have the images, but there was somewhat hypoperfused status of the cortical gray matter at these frontotemporal regions. And I think Dr. Hummus, who talked to us about ASL, one of the applications was in neurodegenerative diseases. Then we went for volumetry, and in the volumetry, which we do by comparing to several age-matched controls quantitatively, there were subvolumic changes of the deep cerebral white matter, cortical gray matter, and also certain components of the hippocampal formation, CE4-DG and SRSLSM. As you know, the hippocampus has 5 main components, and the volumetry comes with, for every component alone, compared to age-matched controls. So there was some sort of hippocampal subvolemia. Then we did tractography. We have the fractional isotropy color-coded maps. This is the tractography. We do it for the corpus callosum, for the cingulum, corticospinal tracts, arcuate, which is the dorsal language pathway connecting vernix and Broca's areas, uncinate, ventral language pathway connecting inferior frontal and temporal language areas, inferior occipitofrontal fasciculus between the occipital and frontal lobes, inferior nocturnal fasciculus between the occipital and temporal lobes, frontoascending tract, which is connecting frontal and parietal language areas. And this is the table for fractional isotropy and ADC values. So these are usually subtle findings because you are not dealing with a tumor, with something that infiltrates or distorts. You depend on seeing some minor changes in color brightness, color hues, orientations, etc. And also in these numbers. And if you look here, the cingulum, for instance, had, especially on the left side, had remarkably reduced FA value and an elevated ADC value compared to normal controls, but all the values of her tracts were somewhat lesser than expected. We use the diffusion, we do a diffusion sequence, we get from it tractography, but also you can get from it TBSS, which is tract-based spatial statistics. This is used to measure certain more high-end parameters, including fractional isotropy, mean diffusivity, axial diffusivity, and radial diffusivity. Each of them has a certain thing to measure in the white matter of the brain. And the way it goes is that you are having a layout or skeleton of several age match controls, and then you put the data of the patient on top, and if there is any statistical significant difference, it is highlighted in red, like here, for instance, for the callosal and cingulum tracts in this patient, highlighted in red over the green skeleton, and we also do region of interest measures, and this is the axial diffusivity. Okay, so just to TBSS. So the TBSS and DTI data pointed out that we have a pattern most suggestive of a case of amyotrophic lateral sclerosis, but of the phenotype of the bulbar type of ALS, because we also saw tract abnormalities in the brain stem, especially the anterior parts, and the bulbar type of ALS, and the ALS, as you know, affects the corticospinal and the corpus callosum more than other tracts. There is a phenotype, which is the bulbar phenotype, which is usually starts as bulbar and then progresses towards the pyramidal system, and this matched the clinical data in this patient. Last but not least, because we should have finished like 1 hour ago, we also did a resting state function and connectivity study for this patient, and we found the red colored are the default motor network, and the salience and the dorsal attention and the sensory were all below normal, i.e. showed hypoconnectivity compared to age-matched controls. And this is the summary of the data, and this is the table giving the other method of resting state function connectivity. Okay, so this patient, by the resting state, we found that she had also simultaneously frontotemporal type of dementia, which if you come back to my first slide, when she had the atrophy bifrontotemporally more on the left side, these are the characteristic parts for frontotemporal dementia, and was proven also quantitatively by the resting state. Okay, so the final thing in this so coherent case with all this thing, it's a case of frontotemporal dementia, more of the behavioral variant, combined with a motor neuron disease, particularly bulbar ALS. Okay, and this is what I sent to Dr. Heba. تمام، أخرناكم جامد، أخرناكم، بس إحنا بادئين 40 دقيقة.
Okay, thank you very much for the neuroradiology session. Please stay with us for a very short closing ceremony. We will close the conference immediately. We thank everyone who joined this in this conference. We thank all the speakers, all the chairpersons, all the audience, everyone, all the delegates, everyone who attended the conference. شكرا لكم جميعا على حضوركم معنا المؤتمر، وان احنا يعني لو كنا نجحنا في المؤتمر ده فده بسبب وجودكم. Our success is simply because of your presence with us. Now, Professor Tarek Dasti, President of the Egyptian Society of Radiology. And by the way, we have to congratulate Tarek because today he got an honorary fellowship by the Royal College of Radiology, which is something I know they don't give to anyone. It's something very elite. So congratulations for Tarek. Okay.
Thank you so much. First, I would like to thank the Royal College for this great honor, and thank the representative of the Royal College in this meeting, Dr. Joanna and Patrick and Tanya. And we hope that in the future we'll fix a session in every of our activity for the Royal College, beside other sort of activities, inshallah. I would like to thank all speakers and chairpersons, thank the moderators of the subspecialties, and also our colleagues from the Arab countries and all of the participants. As Ahmed said, the success of the meeting is due to your attending this annual meeting of the Egyptian Society. We have this year some quiz cases and best published papers, and also best presentation of the scientific sessions. So I'd like to announce the winners. And for the best published papers in last 2 years in the Egyptian Journal of Radiology and Nuclear Medicine, the first winner is Dr. Rabab Yassin, Menofia University. The published paper was entitled Chest X-ray Findings Monitoring of COVID-19 Disease, Course and Severity.
The gift is presented by REAP Solutions. We thank them for presenting this gift.
Yeah. Dr. Rabab, this is not just this certificate. Medical Space is offering you a free registration for the next ECR in Vienna, inshallah. Yeah. The second best published paper was from Cairo University by Dr. Rasha Mustafa. It was about post-COVID-19 pneumonia, lung fibrosis, worrisome sequelae in surviving patients.
This gift is presented by Nebras Technologies. Thank you for Nebras for the gift.
Regarding the scientific research, the best presented paper was presented by Dr. Donia Sobh, Mansoura University. It was left ventricular strain analysis by tissue tracking, cardiac dysfunction in children with end-stage renal disease.
Again, this is presented from Nebras Technologies.
And regarding the quiz cases, there was two winners for the quiz cases presented by Professor Ragab. The second best solution was Dr. Aya Atif, Aya from Urology and Nephrology Center, Mansoura University. And the first one was Nihal Hazim. She also is a resident doctor at Urology and Nephrology Center, Mansoura University. With no bias, was no. It's also sponsored by Medical Space, and I can receive the on behalf of both.
Okay. Now we can show you a short video. Actually, the video is some of the moments we had in our conference. الفيديو. جميعا مع بعض. Thank you.